Very good morning to one and all. We'll get started with the day. On behalf of the organizing committee, I welcome you all for the Obstetric Critical Care CME. It's really exciting and encouraging to see so many busy practitioners come over on a Sunday morning. We sincerely hope and have strived hard to fulfill your expectations in imparting knowledge and disseminate the recent advances in the field of obstetric care with a vision to homogenize critical care services in our region. Now, the first session will have 3 talks. At the end of the session, there will be question and answer session. So I request our first session moderators, Dr. N. Anita, Consultant Obstetrician Royal Care, and Dr. T. Murli, Consultant Intensivist from KMCH Institute of Health Sciences and Research, to kindly come over to the stage. Thank you.
Good morning, one and all. So, on behalf of Royal Care Hospital, we extend a warm welcome to all the delegates and to the speakers and to the moderators and faculties. And so now we start the first talk for the day. We call upon Dr. JSK Chaitanya. She has finished his MBBS from Guntur and DNB from Kobe Medical Center and Hospitals. He is the consultant and head of the department Critical Care Medicine, KIMS Hospital, Gachibowli, Hyderabad. Special areas of interest: neurocritical care, neurological emergencies, digitization in ICU. Over to you, sir.
Good morning, everyone. I'd like to thank the organizers, especially Dr. Sivakumar sir, to give me an opportunity to come back to Coimbatore and present here in front of all of you. My topic today will start with anatomical and physiological changes. So, anatomical and physiological changes in pregnancy and their implications in handling a patient who is critically ill. I'll brush up on all basic fundamentals. I think most of you would have already heard from your teachers yesterday at the workstations. And I'll superficially brush up on them, and in detail as the sessions go on, we'll have more discussions on that. So why are these changes expected in pregnancy? There are increased metabolic needs. It is preparing the body to develop a fetus, and also to prepare for the birth of the fetus, and further on maintenance of the child during its growth. So how does it implicate the course? Somebody who has a disease already, there might be aggravation of their symptoms. Some of the diseases which are unknown might get unmasked during pregnancy, or they may face on diseases which are associated with pregnancy. So it is very essential that all of us know in detail what adaptations body undergoes, both physiological and anatomical, how these lead to challenges in making a diagnosis, or how it will influence your treatment. One thing we should remember is we are handling not 1-2 patients, both the mother and fetus. You have to make a fine balance between supporting both mother and fetus. Sometimes your treatment or diagnosis, you will have to choose on mother versus fetus. So having strong knowledge on these basic fundamental anatomical and physiological changes helps you in fine tuning and provide a safe care to the patient. So all these changes which you are talking about are mediated by hormones, and this slide simply answers all of them. What we see during pregnancy as it progresses, starting with human chorionic gonadotropin, and then as gradually estrogen, progesterone increases, and the other hormones like relaxin, human chorionic somatotropin, human placental lactogen, and many other such hormones bring about all these physiological changes. So as I go through each system one, I will try to superficially tell what important changes happen and how they influence their presentation to us. So rising progesterone level as the pregnancy progresses will cause a drop in systemic vascular resistance. This, to maintain a normal blood pressure, there will be increasing cardiac output and heart rate. And as you can see, once the systemic vascular response drops down, then the kidneys will try to retain more fluid and there will be plasma volume expansion. And pregnancy, there will be significant increase in erythropoiesis that is also mediated by progesterone and increased erythropoiesis from the kidney. But you can note, as we all know, though there is an increase in hemoglobin production, but most of them we see is anemia because there is an disproportionate increase of the plasma volume compared to erythropoiesis. So they are in a physiological anemic state. So all these changes as they happen, we can see there are many cardiac diseases which many of the patients present only during pregnancy. They come to know that they have a disease in pregnancy because all such diseases where they can't handle rising cardiac output, especially stenotic lesions. So they present as the pregnancy progresses. Patients with stenotic valvular disease come to us. Patients who have recurrent lesions, all through pregnancy they would be fine, but at the end, during the postpartum period, they present in pulmonary edema. There are some diseases who have LV dysfunction, dilated cardiomyopathy, postpartum cardiomyopathies, or where some disease of aorta like coarctation of aorta, aortic stenosis. All these patients, as the pregnancy advances, being unable to support the raised cardiac output, raised heart rate demands, become symptomatic. So WHO has given a classification of all heart diseases based on their risk of developing complications, and they've graded them into class 1 to class 4, where class 1 where there would be mild increase in morbidity or mortality, to class 4 where pregnancy itself might be a contraindication. So it's always good to know what all diseases during which phase of pregnancy they come up and because of what changes they manifest. And one other significant anatomical change that can influence the course is, as we all know, as the pregnancy progresses, the uterus becomes an abdominal organ. And when they are supine, out of gravity, the aorta is off the great vessels in the abdomen. But when they lie supine, because of gravity and because of the weight, you can see in the first slide that the fetus and the fetoplacental unit try to compresses the aorta and the inferior vena cava. But so what happens due to this? It leads to reduced venous return and at the same time reduced cardiac output, making patient hypotensive and symptomatic. Hypotension here, when they turn laterally, the baby tries to move away from the vessels and the compression is relieved. This is how patients present to us, like they say they are very giddy, they feel giddiness when they lie flat, they are comfortable lying late. But how does it affect critically ill patients? So somebody who is present to you in a shock or a bleed with the placenta inside, even that's the routine position which we use to examine a patient or to give care to a patient, lying, make them flat and then assess. So even this simple task needs to be modified. So you should be conscious about aortocaval compression happening in pregnancy. So that's why yesterday in the workstations also you would have heard from your teachers, lateral uterine displacement is very essential when you have a patient who is hypotensive or presenting in shock. So coming to influences on respiratory system, this graph will show you on how lung volumes get affected. With the effect of progesterone relaxing, there will be, as the uterus grows on, the uterus tries to push the diaphragm up. Increased relaxin levels will try to relax the ligaments, and there is increased anteroposterior diameter of the thorax. Progesterone itself can act as a stimulant at the respiratory center, and it will lead to higher minute ventilation. Minute ventilation here is not achieved by increased rate rather, but it is through raised tidal volumes. So diaphragm, though it moves up, the diaphragmatic exertions increase to meet the requirements, and there is always increased minute ventilation, which is achieved by raised tidal volume rather than rate. And we can see that the vital capacity most of the time doesn't change much, but what happens is the functional residual capacity goes down. Why is it important? So all these changes are reflected in the ABG, which is just next to that. So compared to a normal patient's blood gas analysis, you should be aware that because of raised minute ventilation, carbon dioxide levels normally stay slightly lower. So when you see a patient whose ABG is otherwise normal with PCO2 of 40, you need to worry, it is not normal. They are already, who are normally should be in a respiratory alkalotic state, are presenting with normalization of carbon dioxide, which is a sign of worry. Same way with acidosis. Bicarbonate of 18 is what is expected during pregnancy to compensate the respiratory alkalosis. So if you see something even lesser, you should always be worried about acidosis. So why should you identify these early is because the fetal oxygen delivery is dependent very much on pH. So any change in this milieu will lead to alteration in the fetal oxygen supply. So the anatomical changes like rising edema, there will be more congestion in the mucosal vessels, which will suggest you that you should be ready to handle a difficult airway. You will have to choose a smaller airway because of increased chest wall, like increased breast size. There will be limitations on getting a visualization. There will be mild increase in the Mallampati scale when you land up for intubation. All these things, all these changes should be in your mind so that you need to anticipate all these challenges while handling these patients. Because of the anatomical changes which I have discussed, there will be reduced chest wall complaints, but there will not be much of change in lung complaints. And as I said, the functional residual volume drops down. So at the bedside, what is it telling you is they don't have much of reserve. And these people don't tolerate apnea or desaturations for a long time. They're reserved to tolerate these as less. So intubation or whatever procedure you do in an emergency, we should have this in mind that they don't have much of reserves. As I said again, all these influence fetal oxygen delivery. So always have in mind all these things. Coming to renal, its effects, the changes in renal system. As I said, progesterone increases renin secretion and it also increases erythropoiesis from the kidney. So increased renin secretion leads to excessive stimulation of the RAS system, both by renin and also through the drop in systemic vascular resistance. But at the same time, there is also resistance to angiotensin II activity. So these changes will lead to increased water retention and expansion of the plasma volume. All these also lead to raised renal blood flow and glomerular filtration. How do all these influences, like in our patients, there will be increased volume of distribution of your drugs. There will be excessive clearance of your drugs. There might be drugs which you need to give during pregnancy for their cardiac illness, whose dose needs to be adjusted at those times. And the same time, as the uterus grows on, it will be compressing the ureters, and there might be mild hydronephrosis which can occur. There can be glycosuria in the urine. There will be loss of, there could be proteinuria up to 200 mg, which is normally expected in pregnancy. All these make them, you should be mindful of these changes and anything abnormal or greater loss from these, you should always look at diseases like gestational diabetes or eclampsia. Simpler problems like, it might start with simple nausea or vomiting, or it can go to hyperemesis gravidarum because of raised human gonadotropin. But as the pregnancy advances, as HCG level drop, these symptoms abate. But progesterone leads to relaxation of muscles and it can lead to lax LES sphincter. It can delay the gastric emptying, and raised intragastric pressure because of the rising uterus size makes them more prone for aspiration during emergency intubations. There will be some changes in the liver enzymes. There will be rising alkaline phosphatase level, but they don't cause much of influence on your routine care. Its influence of endocrine is so expansive, but I'm just simply outlining you simple things. So pregnancy, as I said, there is increased metabolism. So there is a gross increase in the basal metabolic rate. The human placental lactogen will lead to an insulin resistant state. So there will be excess release of insulin. But why is this happening? Because raised insulin level will try to shift the maternal metabolism towards a fat or an fat dependent rather than glucose dependent metabolism, so that the glucose is available for supporting the fetus growth. So this adaptation makes them more prone to develop ketosis. There is increased level of prolactin in the body. There are increased cortisols, corticotropes, both from pituitary and from placenta. There are reduced gonadotropes. All these have different influences over the system. There is increased erythropoiesis, as I said, but at the same time, there is more plasma volume expansion, which will take your patient to a physiological anemic state and maybe also to an iron deficient state. We also note there will be raised white blood cell count, predominantly polymorphs, but they are not so functional. But that doesn't mean your patient is immunosuppressed, because still your antibody mediated immunity is still very well and active. So rising WBC count doesn't only tell that it is infection, their immunity is well under control. There is increased thrombin generation and increased fibrinogen generation. There is also reduced fibrinolysis. There is reduced protein C production as well. So all these things leads in a pregnancy to a hypercoagulable state. They are at increased risk of DVT, pulmonary embolism, almost 5 to 10 times higher risk. Apart from these changes, we should also be aware of how the fetal physiology works, especially the fetal oxygen delivery and their metabolism. Fetal oxygen delivery happens through a concurrent exchange where uterine blood flow through the placenta delivers metabolites and clears off the metabolites from the fetal circulation, delivers oxygen and clears the metabolites from the fetal circulation. So what determines the oxygen delivery from the uterine angle is the uterine arterial blood flow, the oxygen content of the uterine blood, and the saturation. Here, when I say oxygen content, it takes into account both saturation and the amount bound to the hemoglobin. So when you try to increase FiO2, it doesn't majorly influence the fetal oxygen delivery. If you can see, I don't know if it's clear here, the PaO2 pressures within umbilical vessels and the fetal vessels is somewhere around 25 to 35. So, but how is oxygen delivery happening here is because fetus has tried to have some adaptations to hold oxygen and deliver oxygen even at lower PO2s, like unlike adults. So this is achieved by the fetal hemoglobin (HbF), which has a fetal hemoglobin concentration of 16, which has increased oxygen binding capacity, and the pH in the acid-base milieu, which will cause a left shift, especially in the fetal circulation. So any changes affecting these normal physiological changes can lead to compromise. So any patient where uterine blood flow is compromised, like hypotension, prolonged uterine contractions, or vasoconstriction happening in the uterine circulation, can lead to compromise in fetal oxygen delivery. So as I said, fetal hemoglobin has higher oxygen binding capacity, and the acid-base milieu will lead to a better oxygen delivery even at a lesser PaO2s. So the fetal circulation has a reserve of around 42 ml of oxygen, which is against a requirement of 21 ml per minute. So what this says is it can still sustain for around 2 minutes. I mean, the fetal circulation has a reserve of around for 2 minutes. But when in need, when there is in shock or when there is a compromise of fetal circulation, there will be adaptation that the fetal circulation diverts blood flow from other visceral organ to maintain the fetus life. So we'll have to try to save the fetus within 5 to 10 minutes, as we have discussed yesterday in this station. So knowing all this helps in making that fine balance supporting both mother and fetus. We'll be discussing all this in detail in the upcoming sessions. Yeah, thank you.
Thank you, Dr. Chaitanya. It was a very good brief session on physiological changes. Now we'll move on to the next session, next talk. It's triage, rapid initial assessment of critical obstetric patient and when to transfer. It will be by Dr. Vivekanandan, sir, who did his MBBS from PSG Institute of Medical Science, Coimbatore. He did his diploma in anesthesia from Rajasthan Medical University, and he has completed his FRCA from London and EDIC, and he has also completed a neurocritical care fellowship from Royal Care Super Speciality Hospital. Now he is in a position of consultant intensivist in Royal Care Super Speciality Hospital. His main area of interest is teaching and training in critical care. Over to you, sir.
Thank you. Thanks. The second talk will be on triage, rapid initial assessment of critically ill obstetric patients, and when to transfer. The overview, I think probably I'm thinking of covering the background and emphasize more on the early rapid assessment of a obstetric patient. And we'll touch upon some of the early warning scores. And rapid response is something that we see patients across the board, not necessarily obstetric patients, but general critically ill patients as well. And then what evidences have we got in terms of transferring such critically ill patients? So the background, I think Dr. Chaitanya did touch upon in terms of we have got two lives, uteroplacental interface to face with, and the physiological stress that can lead on to a pathological state. And the changes happens all through the gestation. It will be different in different stages of gestation. That makes it unique that the parameters will keep changing, be it the first trimester or the third trimester, it will be quite different. And critical illness in pregnancy per se, I think it could be due to pregnancy-specific conditions. It could be hypertensive diseases of pregnancy, for instance, or it could be a deteriorating pre-existing disease. The patient might have a cardiac disease to start with, and that would deteriorate during pregnancy. And the diseases coincidental to pregnancy, it could be trauma or some abdominal pathologies, acute pathologies as well. So what are the common reasons for ICU admission that we can come across? It could be obstetric and it can be non-obstetric. Within the obstetric causes, I'm sure you would appreciate hemorrhage and hypertensive diseases would be the most commonest. And of course, sepsis, infections, amniotic fluid embolism, acute fatty liver, and periportum cardiomyopathy are not uncommon. Looking at the non-obstetric side of critical care admissions, the conditions like epilepsy, asthma could be worsened by pregnancy per se. And then they could be at increased risk because of pregnancy, like for instance, the pneumonia, urinary infections are quite common, and thromboembolism is quite a catastrophic thing that could potentially be precipitated. And coincidental things like trauma and intra-abdominal acute pathologies can happen. So these are some of the common reasons for ICU admissions that we tend to come across. Obstetric critical need per se in India, I think there are a few papers quoting the numbers, but when compared to the developed conditions, it is quite high. It stands at around 3 to 8%, and nearly 2/3 of critical care admissions are unanticipated. So we may not think that they would be going into critical care, but all of a sudden, within a day, within few hours, things could change. So that is an anticipated group that we tend to come across. So next few slides, I think, will be focusing upon rapid early assessment of patients. So this looks very simple in terms of ABCDE approach. We have heard it time and out from our early medical school onwards, but I think it's a WHO endorsed ABCDE approach. The reason being that we need to use that is that it's quite systematic, it will not miss out anything, and they are prioritized. I think airway takes precedence over breathing and breathing over circulation and so on. So I think if you were to go through these assessments systematically, then we are not going to miss anything out. But at the same time, we can communicate in the same language. So ABCD assessment being communicated to another person, they'll be able to absorb all the details and then they can carry on with the continuum of critical care. So airway with patent airway is a priority, and effective breathing, in spite of a effective airway, we need to have adequate breathing. Circulation, it's crucial to supply the oxygen for the tissues. And what is the level of disability? What is the level of consciousness for this patient? And we need the environmental safety as well, how the patient is in other terms that needs to be looked at. Looking at the airway, one need to make sure that the patient has got a patent airway. Sometimes you could be seeing a patient with a complete obstruction. That's a classical sign of seesaw breathing, where the chest does not rise, just the abdomen rises, and there is a paradox. So that's a complete obstruction. And then what we see more common is the partial obstruction, where there is a gurgling, snoring, or stridor that you come across. When you see that, you immediately intervene. We don't wait for the next assessment to take place, but immediate intervention. Your immediate assessment would be, are you okay? And if they answer you back, the airway is patent, and a partial obstruction could very well be delineated from there on. So look, listen, feel is the approach that is suggested. And if you're going to look at a patient coming in with a trauma, then we need to immediately approach them with hands straight, looking to manually stabilize them. Inline stabilization is what we tend to do. And yesterday's workshop did detail all the airway maneuvers in terms of jaw thrust and chin lift, use of airway adjuncts. And the key thing is, if you're thinking of a compromised airway, do seek help at the earliest. Seek the expert's help, let them be there, let them not be used for the patient, but at least they are there in the background so that they can be aptly intervening at the right time. So looking at the breathing, tachypnea is a very, very sensitive indicator. So tachypnea is a very clear marker that the patient is trying to compensate for some kind of a metabolic acidosis that is secondary to a poor perfusion. So tachypnea cannot be taken lightly. And I think Dr. Chaitanya was alluding to in the last talk about physiological changes that tends to happen. Patients might have a raised respiratory rate, but nothing more than 23 or 25 it should be. So anything more than that should ring alarm bells. So if they are unable to complete sentences, be it not the labor pain induced reason for not completing the sentences, but apart from that, I think if they are unable to complete sentence, then that is a sign that they are having difficulty breathing. Use of axillary muscles is not normal. If that were the case, then immediate intervention. Many of the times within our hospital settings, we tend to have arterial blood sampling that would help us differentiate to a certain extent if it's a type 1 hypoxic failure or a type 2 carbon dioxide retention. And we need to think about why that is happening. Is it a central reason that the patient is not breathing? Or is it a neurological issue? If there is a muscular problem, all these problems should be delineated from there on in subsequent assessments. And they can be supported aptly with CPAP or non-invasive ventilation or invasive ventilation if that's the case that's needed. So that's quite an important task for us to assess next. And the next most important thing which I wanted to emphasize upon is the circulation. So we are looking for shock in these patients. What are the signs that we can come across? These are bedside clinical signs that one has to look for in all these patients. One is the delayed capillary refill, which we'll look at it in detail. And shock index is something that has been in practice for many years. Is there any relevance to obstetrics? Yes. We have a separate scoring system for obstetric shock index. And then a simple blood pressure measurement, systolic blood pressure, diastolic blood pressure, and the difference between them, the pulse pressure. Is it a bigger value or a smaller value? Is it wide or narrow? So that will give us some clue. Then, as we talked about the tachypnea, it could be the circulatory shock per se that's causing tachypnea. Confusion, agitation, that's probably going down the line a late sign, and oliguria definitely is a late sign. So there are two warnings I wanted to just highlight upon. Hypoperfusion can still be there with a normal blood pressure. The blood pressure can be normal, still the patient's tissues can be hypoperfused. That's the patient is in a shock state. Then, if you're looking for hypotension to diagnose shock, we are late. So these 2 points just wanted to emphasize upon. So how about capillary refill time? Capillary refill time has been practiced many years, and Beecher et al. Many years ago, their original emphasis was 10-second hold at the ventral aspect of the fingertip. It has got many fallacies around it, but I think what I wanted to emphasize upon is a simple bedside technique which you can always use and try to elucidate what the condition of the patient is. So 10-second hold is what they recommended, but nowadays we have moved on to 5 seconds. And what would be normal? Within 3 seconds, the blanched fingertip should get the color back. So that's exactly is the capillary refill time. So it's a useful rapid bedside test that you could do. And if you're going to intervene in terms of giving fluids or be it blood products or whatever be the intervention, and you're trying to get the blood pressure to a near normal level without any tachycardia, then probably the capillary refill time could act as a assessment strategy. So it can get better with your interventions. So it can be a assessment tool as well, both a diagnostic and assessment tool. So CRT in terms of clinical significance, have we got any evidence for it? Well, the Andromeda shock randomized control trial did answer that as well. They compared the capillary refill time normalization as against lactate clearance. And the study did prove that there is a slight improvement in the primary outcome. All-cause mortality at 28 days was better with the capillary refill time arm. And also there is a statistically significant improvement in one of the secondary endpoints, that the organ dysfunction at 72 hours as measured by SOFA as well. So this is in particular about patients group of sepsis. So that's the clinical relevance that we've got. So the capillary refill time can be effective as more conventional perfusion biomarkers in gauging fluid status and governing fluid administration. In relevance to obstetric patients, well, CRT may not be prolonged in patients with class 2 shock, but undoubtedly it will be prolonged in class 3 and class 4. Another important bedside parameter I wanted to emphasize upon is the shock index. What is shock index? It's primarily a ratio of heart rate to systolic blood pressure. And you've got a grading to it, and the shock index relates to mortality when it increases. So in a normal non-obstetric group, a normal shock index would be anything from 0.5 to 0.7. In an obstetric group, a normal parameter would be around 0.7 to 0.9. Anything more than 0.9 probably should ring a bell. So the grading of the shock can be done with shock index as well, mild, moderate, and severe shock, and the mortality nearly goes up to 40% with a higher level. And the blood transfusion level can also increase with the increasing levels of shock index. Looking at the obstetric shock index, with those values which I mentioned, more than 0.9, yes, there is a risk of transfusion need. And if it is more than 1.4, definitely they need aggressive therapy. And the consideration or the suggestion is that we need to have an immediate aggressive approach and probably open the massive transfusion protocol as well. And if it's more than 1.7, definitely we are looking at a patient with high adverse maternal outcome. And how about evidence in terms of suggestions that the FIGO recommends use of shock index in the diagnosis and management of PPH patients? So FIGO does consider that shock index can be a marker of severity of PPH, and we need to be alerted to that particular patient if the value is more than 0.9. That's from the recent guideline 2022. So next two slides, we will look at pulse pressure. So the systolic minus the diastolic, that will be the value of the pulse pressure. And the normal value would be anything from 25 to 40. And it's narrow if it is less than 25. It's not rocket science, it's very simple. Anything less than 25 will be a narrow pulse pressure, more than 40 will be a wide pulse pressure. But these numbers can suggest what are the different types of cardiogenic what are the different types of shock that we are dealing with. And if it is a narrow pulse pressure, then probably we are looking at the stroke volume that is reduced. So like that has been highlighted, it can be a hypovolemic shock or cardiogenic shock or obstructive shock that we are dealing with in that particular patient. How about a wide pulse pressure? If it is more than 40, we are looking at some kind of a vasodilatory shock, and it could be sepsis per se as well. So we need to be thinking about these causes as well. So in terms of circulation, regarding the laboratory parameters, which can easily be obtained in many of the centers, let us have a ABG, measure the lactate, and hyperlactatemia could be a marker of sepsis. And looking at the base deficit and pH, we have got few other suggestions as well. So one needs to meticulously measure the lactate and resuscitate the patient. With resuscitation, if there is a lactate clearance, then probably we are going in the right direction. But the evidence is lacking. There are many fallacies around lactate per se, but Surviving Sepsis Campaign 2021 does endorse it. How about the base deficit and pH in terms of obstetric patients? Well, the calculated base deficit reliably reflects maternal oxygen transport dynamics and identifies patients at risk of end organ injury. This is particularly in relation to pre-eclamptic patients. So how about focused assessment for free fluid as a bedside tool? Yes, it can easily detect intra-abdominal hemorrhage well before hemodynamics change. So that can be a good skill that everyone can acquire, and especially in emergencies and obstetrics, it easily can be put into practice. Even in rural settings, it can be done. So that's a protocol from 2022 from the Journal of Clinical Gynecology and Obstetrics, where if you're looking at free fluid within the Morrison's pouch or on the left hypochondriac region, then it can signify that at least a 250 ml easily can be detected with this technique. And Morrison's pouch free fluid, 650 ml. So all these things easily can be quantifiable by the bedside even before hemodynamics change. So that's one of the important things that we can do. And the disability and exposure, AVPO scoring is very simple, whether the patient is alert, talking to us, or they respond only to verbal commands or to a painful stimulus only. That can be a very simple, not necessarily going into Glasgow Coma scale. And we can elucidate, it could be a simple hypoglycemia, check the sugar and then correct it, or could it be even more sinister that we should be looking at hypoxia, hypercarbia, and rest of the abnormalities to correct for. So in summary, in terms of ABCD approach, it can rapidly identify critical illness. Primary survey should be followed by secondary survey and make appropriate, accurate diagnosis, and definitive management should follow thereon. And employ appropriate staff, and senior help should be instituted at the earliest. So the essence is we need simple measures which are well performed by the bedside so that we can prevent a deterioration, and organ dysfunction should be stopped at the earliest. So that's the crux of the whole purpose of this talk. So next few slides I'll touch upon early and late signs, looking at the odds ratio. This is from the SOCAT study. 5 early signs: partial airway obstruction, poor peripheral circulation by the bedside assessment, pH not less than 7, if it is less than 7.3, that initiates an early sign. If it is less than 7.2, that's too late a sign. So you can see the odds ratio that with partial airway obstruction goes up to 40. Higher the odds ratio, more the risk of death. And you can see on the other side the late sign. If the pH is less than 7.2, the odds ratio goes up to 116, huge jump. So those are late signs. Just be aware, we should be trying to catch patients with early signs, not the late signs. So we have got recommendations from the confidential inquiry into maternal and child health that early recognition is the key, and we need to manage them then and there. And then they have suggested use of Mu score, and we can't use the routine Apache and SOFA scores because they are more prognostic, and as suggested, alluded in the last talk, that the physiological changes may not be appropriate for this particular group. So there are certain disease-specific obstetric risk scores. Wanted to draw your attention to many peers. Pre-eclamptic group can very well be caught at the earliest. So that's one of the peripheral apps that can be used for diagnosing patients at risk of deterioration. So next, we need to be looking at patients, how much of support are they on? Are they on 6 liters of oxygen and having a normal saturation? So all those things should ring a bell. The higher the support, like this house, which is standing with a lot of supports, the numbers might be normal, but the patient is at risk. So we need to identify those patients with higher risk. For 2 minutes, I suppose, yeah. Okay, next few slides, we'll look at triage. Triage is the practice of prioritizing. What we have now looked at is patients with all the acute deteriorations, or catching them early. But we need to prioritize patients based on the deterioration. And then with the best possible care, which is instituted at the shortest time, they can be prevented from deterioration. So they might be at the cliff, just about to fall, with a good physiological reserve. So we need to catch them then and there. So these are the principles of triage, that we need to assess them within 15 minutes and prioritize care based on the urgency. So the modified early obstetric warning score is one of them that has been widely used, and there are quite a lot of physiological parameters they stick to, and based on that, the scoring system happens. And this is the triage pathway that they will fall into, the green, amber, and red pathway. And the green pathway is where we decide what kind of the periodical monitoring that needs to happen. And the red pathway will tell us whether the patient should be shifted to HTU or ICU. And this has been very well validated in sepsis as well, whether the patients have, these groups have a good sensitivity and specificity by using this scoring system. And the Birmingham symptom-specific obstetric triage system has been very well validated, that this is the best of the triaging systems with a good inter-observer variability to at least minimum. So it does rely on Muse scoring and standard investigations, and evidence-based guidelines can be used, and women have been, many percentages have been assessed within 15 minutes. So some of the caveats of Muse: it's a signal for us to have an opportunity to intervene to prevent further deterioration. And the level of consciousness can be a late sign, just be aware of that. And the Oxford did come up with a new scoring system. They are looking at gestation-specific Muse. So different phases of gestation can be addressed accordingly. So the RRT is what we tend to do on a normal basis. The rapid response systems are definitely useful in our settings. And it is defined as highly skilled individuals who will appropriately respond to those calls so that they will intervene and then prevent clinical deterioration. So who should be on it, when it should be intervened, and who will be doing it, and how can the hospitals implement that, has been widely in literature. So one can use the Petra scale to assess the effectiveness. And next few slides, I'll touch upon and finish my talk when to transfer patients within the hospital to a higher level of care, like ICU, or intra-hospital transfer. So our maternal health division of Ministry of Health and Family Welfare, Government of India, proposed in 2016 who should be getting obstetric HTU care, who should be getting obstetric ICU care. And factors to consider: yes, we need to be looking at the maternal need, the fetal need, and also is there any non-clinical grounds that the patient should be shifted in utero prior to the deterioration that happens. So in terms of continuum of care to safety, any center could do a bedside assessment. And a center with ABG interpretation and ultrasound bedside can easily deal with assessing a critically ill patients. But if you have got no further services available, then we should be looking at transferring them to a higher center, which will have interventional radiology services and a multidisciplinary team, which have got a dedicated obstetric critical care services as well. And are they prepared to do a resistive hysterectomy if the situation arises? So those are key questions that we need to ask. And specific guidance on transfer of PPH patients from hospital level. The PPH bundle should have a transfer plan if things go pear-shaped. And in a community center, yes, the shock index, if it's more than 0.9 and if you've got no further services to offer, then we should be thinking about pathogen transfer as well. And the FIGO 2022 recommends how it should be done, having a NSAG, basically a anti-shock garment, which should also be applied prior to transfer. So in take-home points, early clinical signs of deterioration are the key in detecting patients at risk. Implementing a scoring system with a view to rapidly intervene as per the severity is what we need to do. And taking help at the earliest from the most skilled personnel at the most suited center will handle the patient to safety. And time is key. Let us not miss the golden opportunity when the patient gives. So multidisciplinary input on medical and obstetrics conditions is a key. And we need all these specialists at hand. And of course, we might have to do mock drills within this group of multi-professionals so that we can deal with situations. It may not arise in 6 months' time, and later on 2 or 3 patients come in a row. So we need to have mock drills regularly done to deal with such situations as well. Thank you very much.
Thank you, sir. That was detailed protocol-based, and we could see your passion for teaching in your presentation. Over to the next speaker.
The next talk will be on cardiac arrest in a pregnant patient, and I'm happy to welcome Dr. Rami Rajagopalan sir, who is a well-known faculty teacher in critical care. He did his MBBS from Madras Medical College, and he is an board-certified internal medicine critical care physician. He did his fellowship in critical care medicine from University of Pittsburgh. Currently, he is professor and head of clinical services, Department of Critical Care Medicine in Sri Ramachandra Medical College. And he is the past president of Indian Society of Critical Care Medicine. He has a special interest on cardiopulmonary resuscitation, point of care ultrasound, and ethics and end of life care. Over to you, sir.
Thank you for the introduction. Good morning, sir. It's always a pleasure to come back to this meeting. I'm almost like a mascot. Whether I'm giving a lecture or not, they want me around somewhere here. This must be, besides the last 3-4 meetings which Siva has done in Royal Care, it's been a tradition that's gone a long time ago. So it's absolutely a pleasure to be back here. So am I going to say anything new? If you were listening to me yesterday, I'm going to repeat myself again today. I apologize for the fact that many of the things that I'm going to be talking will be a reinforcement of the same ideas that we've already spoken about. So let me just start somewhat with the epidemiology. And here, obviously, it becomes very obvious that cardiac arrest in pregnancy is going to be a direct consequence of the critical illness or the serious illness that you see in pregnancy. And the causes for these kinds of events are reasonably routine. We know all of this. We know sepsis can be a reason, hemorrhage can be a reason, and we know eclampsia and hypertensive disorders are a definite factor. There's one thing that I wanted to point out is very traditionally, we'd like to say amniotic fluid embolism is a common kind of an association. When we see somebody in an arrest, we have a tendency to blame it on that. But I would argue that it is a relatively rarer condition. It's very high mortality, there's no doubt, but it's not something that is going to be a very common cause for a cardiac arrest. On the other hand, if you look at some of the data from UK, on the other hand, there is very clear association between an anesthetic event and an anesthetic complication as a cause of a cardiac arrest. And in this particular study that I've seen over here, it is almost 1/4 of all cardiac arrests were related to that. And very easily retrievable, considering that the patient is in the monitored setting, it's very easy to retrieve most of them. Yeah. Most of these events will not be arrhythmic, so the issue about defibrillation and things like that become relatively irrelevant. Let's just look at what is the frequency of this event. At least in India, we don't have any hard data, so we'll have to extrapolate over here. And if we are going to extrapolate it from the UK kind of study where they have a maternal mortality of 7 in 100,000, and we have something closer to 150 per 100,000 as our best estimate right now, we can estimate that we would probably be seeing 1 CPR event for every 700 pregnancies that we're going to be handling. And if I was to put that in perspective, an average or above average practitioner, obstetrical practitioner, probably who's seeing, say, 2 deliveries a day and is deciding to work the entire year except for 15 days of holidays, is probably going to see about 700 deliveries and probably will see about 1 or at most 2 CPR events that in the course of a year. And it is quite important for us to recognize that the skills that are required to do CPR are not something that can be easily retained when you're doing only 1 CPR in a year. And as a consequence, a process of training has to occur. And this can't be done with just a broad overview. It has to be done probably through a BLS training or, if necessarily, even an advanced life support training that is required. So with that in the background, I'm just going to go rather rapidly to the relatively most recent guidelines that we've had as far as CPR is concerned. I have to be very careful to say that even under conditions where we know much about CPR, that is in the non-pregnant state, the evidence base is not very good. There's a big mismatch between the quality of the evidence and the strength of the recommendations. And this becomes even more prominent in pregnancy, where there are no randomized controlled trials, and a lot of it is based on observational series and physiological rationale. And as a consequence, we are extrapolating from what we see under other conditions to what is being done in pregnancy. And as a consequence, it can be something that will change very rapidly. Now, let's see what are the predictors of successful resuscitation. Whether you're working in a Western country or whether you're working in a low-income country like ours, and even under the circumstances that I was facing in a community hospital in Sundaram Medical Foundation many years ago, there are 3 factors that become extremely strong predictors of survival after CPR. And that is basically you have to recognize the arrest early enough. You need to provide high quality CPR. And if you have access to defibrillation, it should be done as fast as possible. That's exactly what we see in our model as well. And it is quite important that I'm going to emphasize on this. We need to recognize when the patient arrests and as fast as possible. We need to initiate what I say high quality CPR. And then we can talk about the issues related to defibrillation, which I said in pregnancy is relatively less likely to be a concern. So when we talk about basic life support, we always talk about airway, breathing, and circulation. And along these lines, the American Heart Association, for instance, has tried very hard to emphasize that when somebody like a lay rescuer is trying to identify somebody in a cardiac arrest, that they can't use the traditional methods that we will use, like palpating a pulse, for instance, which will be very problematic, or even assessing the quality of their breathing. And I have extended it to, unfortunately, to the obstetricians, where I'm saying that since you do it so infrequently, trying to use a professional approach, saying I will look for the pulse and things like that, is totally inappropriate. If you identify an individual as being unresponsive and demonstrating anything other than normal breathing, you're going to make a presumption that the patient is in a cardiac arrest, and initiating CPR at that point is not totally inappropriate. So this sort of shifts the focus a little bit from that airway, breathing, circulation to a focus dominantly on a circulatory path, where you start with circulation, airway, and then breathing. Okay? But it is important to recognize that this doesn't mean that there is no importance to airway and breathing in patients who arrest under these circumstances. The advanced part of life support usually goes on to the use of defibrillation. But as I will keep, we've been talking about this during the course of the workshop also, defibrillation has come thanks to the fact that you have automated methods. It can be done in the basic life support level itself. And the use of the AED dramatically improves the way in which you will be using defibrillation in these patients. Let me go through a rapid review of how we need to provide high quality compressions. And I'm re-emphasizing this over and over again because I think this does make a difference in terms of the outcomes of these patients when you have an arrest. Quick, most important thing that we need to recognize is if we identify somebody as having an arrest, the first thing that we need to do under these circumstances is to call for appropriate help. And this is because it is not just the need for an anesthetist to provide you with a definitive airway, but also for a team that can perform a perimortem cesarean section when it is needed as an urgent kind of a process. We always recommend that all you need to do is identify the chest and place your hand in the middle of the chest. We don't need to go through the old processes of tracing the ribs and then trying to say that we have to place it 2 finger points above the lower sternal border, which again is going to be associated with a significant delay in the performance of the CPR. The current recommendation is very straightforward, whether it's a pregnant or a non-pregnant patient. The placement of your hand in the middle of the chest is very relevant to the performance of CPR early enough. And then we initiate the compressions, which are going to be done at your traditional rate of 100 times per minute. Yesterday, I emphasized bringing my metronome to show people what 100 times per minute is, because there's a big tendency for us to do resuscitation that is very rapid, and very fast resuscitation can be associated with very poor perfusion. I think we need to be very clear that we need to continue the CPR till a perfusing rhythm is seen, and it should be done in a reasonably appropriate kind of a fashion. Something is freezing over here. Oh, I'm trying to show you the process of movement. I think we emphasized all of this yesterday during the course of the workshop. The basic process when we're doing CPR is we are creating what is called a cardiac pump. The heart is being compressed between the sternum and the vertebral body and effectively functions not as a conduit but as a direct pumping mechanism. And it is quite relevant that for the return of circulation, it is not just the preservation of output during the compression that matters, but for the return of circulation, there should be an adequate enough coronary perfusion pressure, which is going to be extremely dependent to create a flow between the aortic pressure and the atrium, and that is going to be very relevant. And the ways in which you can maximize this coronary perfusion pressure by chest compression is going to be very essential. And in that sense, the ways in which we perform the CPR is quite relevant. To do it at a rate of about close to 100 is associated with the best coronary perfusion pressure. To do it at a cycling rate of 50%, that is your time in during compression and during relaxation being equal, is also associated with the best coronary perfusion pressure, as is the increase in the depth. But here again, we have to be very careful. You can't keep increasing the depth eternally because you have a certain limit to the amount of injury that you may create to the chest wall or to the lung underlying. So we do limit it to about 5 to 6 centimeters and say do not exceed that. So this has become the standard: 100 compressions per minute, a 50% duty cycle, and a 5 to 6 centimeter depth of compression is absolutely relevant for us to achieve the ideal output. And this has been very nicely documented in clinical studies. This is the PRIMED study in which they show a rate of compression of about 100 to 120 with a 50% duty cycle is associated with the best outcome. And that is quite relevant for us to understand this. This is high quality compression, and this is what is being recommended again in the ACS, American Heart recommendations as we see it. Do we have methods by which we can judge this quality? Some of these devices that you can have are a little complex, but a simple thing like the Cardio First Angel, which is a clicker device, basically it's a clicking device you put on the chest, and as you press and as you relax, it tells you whether your appropriate compressions are being done. And this can be associated with better outcomes, and monitoring the quality of your compression is going to be extremely important. The big question that we have asked, and yesterday also we saw that when we were doing the mega code, when somebody started CPR, everybody else was relaxing. I mean, everybody else was a little tense, but the moment they came and recognized that there was a bleed or something like that, everybody took their hands off and was staring at the patient. That kind of time off from CPR during the process of resuscitation can be clearly associated with problems. This is a study in which paramedics were looked at, and if you really saw the amount of time that they did not provide compression during a CPR cycle was almost 50% of the time, which is very large amounts of time. And the longer you take your hands off, the more likely you're going to have a poor outcome. It is extremely important to recognize that it's not just doing the quality of CPR that matters, but the continuity of the process that is going to be very relevant. Taking the minimum amount of time during the breaks will be probably absolutely worthwhile. We do not wait after we shock. We do continue to do the compressions before and after we shock. We probably wait during the breaths alone, but in general, we try to do a maximum amount of compression to guarantee that the outcomes are going to be good. So this is perfectly acceptable in the non-pregnant patient, But in pregnancy, we clearly need to make certain adaptations that are very relevant. And probably the single most important concern that we have is the effect of the fetus on the aortocaval flow. As was clearly emphasized much earlier, the aortic flow and the venous return can be significantly impaired during the cardiac arrest, that unless we shift the weight of the uterus, of the fetus away from these vessels, you're not going to have an improvement in outcome. Now, this was logically looked at in terms of the way in which you can tilt the patient. Yes, a lateral tilt of the patient, even to about 12 degrees, can be associated with a significant reduction in the amount of hypotension that you see in these patients. And that is also associated with a clear improvement in flow, the lowest being in a supine position and the highest being in either a left or a right lateral kind of a position. But this does not mean that we should be using these kinds of processes, which are extremely popular for CPR a long time ago. At that point in time, we always said, since the uterus weight has been shifted away from the vascular structures, we either use a human wedge or you use very specific kinds of methods to tilt the patient to provide the CPR. But this, unfortunately, is going to be associated with very poor cardiac compression during CPR. And this is something that we need to recognize very clearly. A lateral shift of about 27 degrees is associated with a transference of pressure that is roughly only about 3/4 of what you normally can generate. And as a consequence, this kind of a shift is probably going to reduce the efficiency of compression. And this has been clearly documented in a big meta-analysis that was published in 2022 that very clearly showed that the depth of compression and the position of your hand is significantly altered by the lateral positioning that you have. These are not outcome studies if we don't know what will happen, but it's logical that if you can't do good positioning and good compression, you're unlikely to have good outcome. So if you really look at the idea of tilting the patient during the performance of BLS in a pregnant patient, it's really not very logical. While it may improve the perfusion, it has a big problem in terms of the quality of the compression, and in general, it is not going to be a process that is going to be recommended. The alternative that we have is very clearly an issue of maternal displacement by a manual process. This is data from JIPMA, which clearly showed that in a hypotensive, this is basically patients getting epidural anesthesia. The process of lateral displacement can be significantly associated with an improvement of the hypotension. And this is the same kind of logic that is being right now recommended in CPR in pregnancy, where the recommendation is either a two-handed or a single-handed approach of displacement of the uterus during the cardiac compressions to improve the outcomes in these patients. This comes to the next specific topic, and I think I learned the word resuscitative hysterotomy only yesterday. I promise you that I made the changes in my slide. My wife is standing there smiling, not standing there. She's looking at me very happily. She is the one who gave me that terminology first, okay? And I will go through that a little bit, because even now, the American Heart Association's recommendation says something about perimortem cesarean sections. It doesn't talk about the word resuscitative hysterotomy, okay? The recommendation has usually been that when you're doing CPR under these conditions, you're trying to reduce the aortocaval pressure, and the primary intent of reducing the aortocaval pressure is to improve outcomes after CPR that will be associated with better fetal outcomes. And it has had a focus in saying that the quicker we do it, the better the chances for the fetal survival, with the maternal idea being given a secondary kind of an importance. Okay, so it has been very strongly recommended that you should do this within the 4 to 5 minute period, and so that you can have a fetal survival that can be guaranteed. And we always use the word the perimortem on the presumption that the mother is sacrificable, that it's going to be an event that will ultimately lead to her death, but what you're looking at is saving the baby alone. This need not be the right approach. When we look at it, we already talked about aortocaval compression. Please remember that not every pregnant woman will have aortocaval compression, that you need to have the uterus at least at the level of the umbilicus 20 weeks or longer for you to have significant compression. And you need not be focusing on trying to do a cesarean or a hysterotomy on every patient in a cardiac arrest. So with this in the background, I think basically we need to look at where we got this four-minute kind of rule. And here is a review of about 38 cases in literature. Nobody has a big enough series by themselves that they need to put it all together. Here there were 38 deliveries with 24 surviving babies. And when they looked at, I may go much longer than this. Okay, can I? Will I be, okay, thank you. Because I don't think I have any ability to do it any shorter than this. Anyway, okay. So when they looked at these 24 babies that were surviving, the majority of the babies that survived were within the first 5 minutes if the resuscitation was initiated rapidly enough. And as a consequence, this has become a rule in terms of the management of patients with a cardiac arrest. And when you look at the outcomes as far as resuscitative hyperhysterotomy is concerned, I have two databases that I would like you to look at. One is the Dutch registry, in which they compared perimortem cesarean section versus none, and they couldn't show a difference, but this is not necessarily a good comparative study, primarily because the cesarean sections were never done within 5 minutes under these circumstances. And the one thing that they did show is if you go through a training course like this and you do perform resuscitations a little bit better, you're likely to show an improvement in outcomes and the frequency of the sections that are being done. The other study that we look at is the so-called CAP study from the UK, in which they looked at 66 patients during a 5-year period who had a cardiac arrest, all prospectively looked at. And what they saw was the patients who survived had a 3-minute time to resuscitation in contrast to the non-survivors who had an average of 12 minutes in terms of the time. But the sad thing about this is the reason that the 12 minutes occurred is many of these arrests occurred out of the hospital, and the transfer of the patients was probably the factor that was related to the delay in the performance of the CPR. So this doesn't necessarily answer the timing that we need to be providing under these circumstances. So as I said, if you really look at all the data that we have no data on timing, and we don't have any kind of outcome data related to this resuscitation within this certain period of time. And as a consequence, I think we need to be rethinking this entire process and probably not focusing so much on that impractical 5-minute time that we have. That probably extending this time can also be very valid in terms of maternal resuscitation, where if we shift the focus away from focusing only on the fetal resuscitation, but looking on both the fetal and maternal resuscitation, it may not be a totally inappropriate kind of a process. I'm going to be getting into a little controversy over here when I suggest that going beyond 5 minutes is not necessarily bad, but trying to aim for less than 5 minutes may help with the fetal resuscitation as well. The other aspects of the management of these patients include the management of the airway. I just put it away primarily because it is not that it is unimportant, but as I suggest, since it is going to be done very rarely by you, please call for appropriate assistance when you're going to do this. And what you need is definitely an anesthetist to help you with all the processes that are involved in this part of resuscitation. My strong suggestion is at least maybe learn airway, don't do any intubation, and probably even avoid placing a LMA, but consider the use of ambu bagging as your process of providing oxygenation. As I suggested, the definitive airway should ideally be performed by an anesthetist, and I will skip to the issue related to whether we can do defibrillation. With the availability of the AED, it makes a big difference. But as I said, the frequency with which you need to use a defibrillator is going to be far less in a patient with this kind of a situation, that if you identify that the patient doesn't have a defibrillatable rhythm, you need to go through a serious process of thinking it out. In PA asystole, when we deal with standard resuscitation, we are told to look at the 5 H's and the 5 T's, the ha 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 ha, the ta 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 ta, okay? But unfortunately, here it's a little different, and there is a slightly French twist to this, where they suggest that you look at what you call the Beauchamps. Okay, bleeding as a common cause, embolism, and anesthetic complications being quite high. Uterine is something that you should all focus on. Cardiac issues, hypertension, and also the traditional HHs and Ts that we see, placental abruption and sepsis. Here I've divided them into three groups. The groups in which the obstetrician has a primary role, the control of bleeding, the control of the correction of the uterine atony, and probably handling abruption and previa. And also under other conditions where there can be a very significant concern. We do not appreciate the concerns related to the use of epidurals and potential for local anesthetic toxicity that needs to be handled in an appropriate way. We also keep forgetting that when we're treating eclampsia, the drug that we use, magnesium sulfate, as good as it is effective, can be a potential harm to the patients and needs to be reversed. So with that as the broad consideration, this is what the American Heart clearly suggests. See, as you see in the American Heart recommendation, it starts off with the word perimortem cesarean delivery rather than a hysterotomy, a resuscitative hysterotomy, should be considered in the second half of pregnancy with very low quality evidence. There is insufficient evidence on the time at which the delivery should be done. There is insufficient evidence on whether you should use either a lateral lift, tilt, or a uterine displacement. We don't even know which is appropriate. But there is one recommendation that you should perform high quality CPR if you want to go to good outcome under these conditions. Thank you very much. I apologize that I've taken a long time.
Thank you, sir. And for want of time, we will have one question now. And if you have further questions, can be taken up during tea time and lunch.
I apologize. Yeah.
I request the other two speakers of the session to kindly come to the stage for the audience questions.
No questions? Can we close the session, sir? Yes.
Now, we'll felicitate the speakers who have not been felicitated yesterday in the workshop. I kindly request Dr. Rami Rajagopalan, sir, to felicitate the other two speakers and moderators. Dr. Chaitanya. Dr. Chaitanya P. Dr. Vivekanandan. Anita. Dr. Murali. Thank you, sir. Next, we will have the inaugural function, followed by the most expected keynote lecture of the conference. I request all the delegates to kindly be seated. Tea will be served after the keynote lecture in the corridor outside and near the reception registration counter area. That is after the keynote lecture. Now it's time to officially inaugurate the conference. We are extremely happy and delighted to have Dr. A. Nirmala Madam, the Dean of Coimbatore Medical College, as a chief guest of our conference. May I request our beloved Chairman, Dr. K. Madheshwaran, and Organizing Secretary, Dr. Yaman Sivakumar, to accompany our Honorable Chief Guest, Professor Dr. A. Nirmala, and the esteemed dignitaries, Dr. V.P. Paley, Senior Consultant in Obstetric and Gynecology from Rajagiri Hospital, known for his projects on maternal death prevention with the State Government of Kerala, and Dr. Ram E. Rajagopalan, Head of the Department of Critical Care Medicine, Sri Ramachandra Medical College, Chennai, a pioneer in the field of critical care medicine, to the stage, please. May I kindly request everyone to rise for the Tamil Thai Valthu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வத கண்டனிதில் அதில் சிறந்த நாவிடனல் திருநாடும் திரு திரை முதலும் தரிதனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழரங்கே தமிழரங்கே உன் சீரிழமை திறந்தியந்து மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. Now I invite Dr. P. Vivekanandan, Consultant Intensivist Royal Care, to deliver the welcome address. Good morning and warm welcome to the inauguration ceremony of RCH ICU Update 2024. It is indeed with utmost pleasure we welcome our beloved Chairman, Managing Director of Royal Care Hospital, Consultant Neuro and Spine Surgeon, Dr. K. Madheshwaran sir, who has been extremely supportive of all our endeavors in academics. We welcome you, sir. It is with immense pleasure and honor we welcome our chief guest, Professor Dr. Nirmala Madam, Dean of Coimbatore Medical College Hospital, who has been awarded for her outstanding services during COVID pandemic by the Honorable Governor of Tamil Nadu. Madam has also won the IMA State Award and Tamil Nadu Medical Council Awards for Best Administration for COVID-19. We welcome you to grace the occasion, Madam. We welcome our eminent faculty, Doyen of Critical Care in India, past President of Indian Society of Critical Care Medicine, an avid teacher to many, Dr. Ram E. Rajagopalan sir, Professor and Head of Clinical Services, Department of Critical Care, Ramachandra Medical Center and Sri Ramachandra Institute of Higher Education Research, Chennai. We welcome you, sir. We welcome our eminent faculty, a well-known Professor of Obstetrics and Gynecology, Dr. Paley sir, who is the State Coordinator for Confidential Review of Maternal Deaths, Kerala, past President, Kerala Federation of Obstetrics and Gynecology, and State Coordinator of various projects of Kerala aimed at reducing maternal mortality. We welcome you, sir. With great pleasure, we welcome our faculties of national eminence and our in-house faculties for this CME event. I welcome all our delegates who have shown great interest in our academic events over the years and yet again this year as well. Warm welcome to one and all. We welcome each and every one of you for the CME event. Hope you enjoy this day. Thank you, sir. Now we have the lighting of Kuthuvelakku by the dignitaries on the stage. I kindly request Dr. K. Madeshwaran, Chairman and Managing Director, Consultant Neuro and Spine Surgeon, Royal Care Super Speciality Hospital, to deliver the presidential address.
Good morning. Dr. Ram A. Rajagopalan, Dr. Paili, Dr. Nirmala Dean, Coimbatore Medical College, who is here as a chief guest of this inauguration, Dr. M. Sivakumar and his team. I appreciate everyone's presence here, including audience, participants. And I also recognize the presence of Dr. Kalyana Kumari, who has done enormous things in endogynecology and robotic surgery in gynec field. I congratulate Dr. Sivakumar and his team for organizing this wonderful meeting. They have been doing this since long time, almost 10 to 15 years. In between, they had a shift from their previous hospital to Royal Care. There was a gap, then COVID time, there was a gap again. And they started their ICU update some time back, and this year it is critical care in obstetric emergency. I do remember early 90s when I was sitting in primary health center as a medical officer, and Tamil Nadu government was pushing antenatal care, perinatal care, and postnatal care in village level itself for those days, and village health nurses were trained to conduct deliveries, and government encouraged institutional deliveries or trained personal deliveries at least, because so many ayas and self-trained people were conducting deliveries those days in early 90s, at least in remote villages in our state. And government tried to change that scenario by creating PHCs and posting doctors, training VHNs. And that was a huge step those days. And there was nothing to resuscitate an emergency case of obstetrics. even in primary health centers. But every primary health center had a Matador van, standard 20 van, which takes 2 minutes to start. Sometimes we have to push it and start. But still many patients were shifted to headquarter hospitals. Many of them survived. Those things happen. Now I see entirely different things. Whenever I attend this ICU update, it becomes very difficult, even for me, whether I am treating head injury properly. So many things are talked. Always Dr. Ram Rajagopalan sir will say, you do it or don't do it. Yes or no. And finally, you don't understand anything and go. Because it is all evidence-based from all over the world, which creates more confusion. And now I understand my job is to operate and leave the patient with these guys. Let them do what they want. And once my patient comes out of ICU, I will take care of that. And lots of fight goes on in between the intensivist and various surgeons who visit ICU because of various reasons. You tell an amount to the patient, and if he goes to the ICU is very costly place. Many things happen. You don't want your patient in ICU, but still patient needs ICU care. She or he goes to ICU, and many things happen. And personally speaking, last 20 years, as far as my field is concerned, the recovery of head injury is almost equal to an elective surgery now. Any patient who reaches ICU in time recovers well. And I am proud to say most of the patients who reach our ICU recover very well with a minor deficit. I am talking about very serious head injury patients. Some of them might survive and remain vegetable throughout life. I don't see many patients remain like that at present time because of immediate care during the ICU stay, every minute, every second care. All these things make big difference. And rehabilitation has helped our patients to come out of their problems very well. And obstetric emergencies are rare. As Dr. Rajagopalan sir said, it is 1 in 700. And a very busy obstetrician might encounter 1 or 2 cases in a year. But still it is sensitive, very sensitive. Most of the time you end up with the double emergencies. So it is very important to know a few things about it. And still we believe like 20 years ago, any bleeding during pregnancy, surgeon is called to do something. By the time they reach headquarters hospital, patient is unconscious, totally unconscious. And whether cesarean delivery or hysterectomy is going to help, that was a big problem there. Bloods won't be available, and most of them go down. Such things don't happen. Many invasive surgeries have come, and the arteries are tied easily to control bleeding with laparoscope. And surgeons do help these patients to come out of ICU. I appreciate everyone's effort to attend this conference and learn few things from the masters. I also appreciate the faculty members who have traveled all the way to participate in this event. I appreciate my team, Sivakumar and his doctors, ICU, and other departments in the hospital. Thank you very much.
Thank you, sir. Thanks for your inspiring speech. I request our chairman, Dr. Madheshwaran, to felicitate our chief guest.
It's a great privilege to introduce our chief guest, Professor Dr. A. Nirmala, the Dean of Coimbatore Medical College. Madam has completed her MBBS from Coimbatore Medical College, DGO from Stanley, and again she continued to go on to do a MS General Surgery from Coimbatore Medical College. She has been working in the Department of Surgery in various government medical institutions from 1991 to 2018 and has been in the respectable position of Dean from 2019, currently heading Coimbatore Medical College, her alma mater. Madam has multiple publications and has been involved in a lot of academic activities. Her work during the first and second waves of COVID-19 in Coimbatore was commendable. She has received multiple awards for her works, and to state a few, outstanding service during COVID pandemic 2021 by Honorable Governor of Tamil Nadu and IMA State Award for Best Administration during COVID-19. Madam, may I request you to kindly deliver the chief guest address?
Very good morning to one and all present here. First of all, I thank Royal Care team, especially the critical care unit, Dr. Sivakumar and team for having invited me for such a wonderful function. It is a need of our. Everyone should know the basics of resuscitation, BLS and ACLS course. It's a must. In this way, I first of all, I thank the team and also respected chairman, Dr. Madheshwaran sir, and also our teacher, renowned logician, Dr. Paili sir, and Ram Rajgopalan sir, and Dr. Sivakumar, and the other faculties and other delegates. And regarding this program, it's a very, very important in the recent scenario, because I don't know about the private setup, whereas in the government setup, we used to have all the high-risk patients only. Most of the deliveries referred to government setup is high risk. There is a shift of patients, those who are young and healthy patients, those who are we were delivering previously. But nowadays, because of so many other social problems or anything, first of all, the youngsters want to settle down early, then only they want to go into the family way. All these things made the risk of the pregnancy becomes more risk. In this way, we are coming across many of the high-risk pregnancies, and in that way, they are having antecedent complications also. Because they are becoming elderly becoming pregnant, they are already hypertensive or diabetic or unnoticed heart disease patients. More of the scenario is the obesity. All these things come in the way. So managing all these complications is a great task for the physicians. So it is a must that the physicians should act as both as a physician as well as a surgeon. So in this way, not only the physician and surgeon, but also an intensivist. It is the most important that every physician should have the basic knowledge about the resuscitation till we get the help from the other faculties and other department specialists. So in this way, this conference is going to be a very useful, and even I have heard today about the resuscitative hysterotomy. I learned a term that there is a term called as resuscitative hysterotomy. So in this way, every day the updation of the knowledge is very, very important. Unless otherwise we are updating our knowledge and effectively, and not only updating is important, but also practically we have to apply in the field. Whenever we come across any scenario of critically ill patient, we have to apply what we gained in that knowledge, and also in an appropriate way and systematic way. That is the most important. That is, many of them know this resuscitation, how to do, but there is a protocol to do how you have to resuscitate, how much the compressions you should have. you should do, and how much the depth you have to give. All these things are very, very important. In that way, the practical, yesterday there was an workshop I heard, so I showed them these types of workshops will make every physicians to be aware of what to do in a critical situation. And in this way, and also not only the patients with sometimes all of a sudden we don't know, because of the physiological changes in the pregnancy, I don't know who is going to have the complications and what complications they are going to get in the because every pregnancy it is a becoming a risk nowadays, because we are seeing so many cases of we may not even expect that patient to go for a PPH, but the patient may go for a PPH. All of a sudden you must be able to, that also not the primary PPH, they may go for even a secondary PPH in the later part of their postnatal period. So in that way, everybody should be alert and aware of the complications and anticipate the complications whenever you are dealing with any of the high risk patients. And also we have to be how to apply the skills what we learned in the already in all the workshops and the CME programs. So in this way, this workshop will be a great use to all the medical people, not only to the medical people, but also the paramedical people. Paramedical force is very, very important in our field. So it is everyone whomever knows the ACLS and BCLS training very thoroughly, they have to take an effort to teach 10 people at least in the in nearby. Even family members have to be taught how the ACLS, BCLS to be given. So in this way, this training will be a most useful to everyone. Make use of it and learn the new things from which is available in this scenario. And in this way, the Royal Care has taken a step forward to update the knowledge about the obstetrical critical care. I thank the opportunity given for me to take part in this important event. Thanks a lot. Thank you.
Thank you, ma'am, for your thoughts on the high-risk pregnancy management and resuscitation needs, which we hope and aim to deliver in this CME. Now we have the felicitation of the occasion by our respected eminent faculties, the stalwarts in their respective fields. First we have Dr. V.P. Paidi, Senior Consultant in Obstetric and Gynecology, Rajagiri Hospital, Alua, Kerala. Sir is a well-known name in the field of obstetrics in South India. Sir has contributed considerably in the government projects on maternal deaths in Kerala. He was the state coordinator in confidential review of maternal deaths and was instrumental in setting up quality standards in obstetric care for Kerala. He has keen interest in academic activities and research and frequently conducts workshops in obstetric procedures. He has multiple publications in journals and books. So we kindly request you to felicitate the conference.
Thank you. Good morning. Respected Professor Nirmala, Dr. Madheshwaran, Dr. Rajagopal, Dr. Sivakumar, other faculties, and dear friends. Isn't it a great honor to be asked to be a part of this event, which I believe Royal Care Hospital had been continuously doing from its inception. The importance of being prepared to provide critical care for a mother has already been emphasized by our chief guest, who I understand herself is a DGO holder before she took up MS. I would say that obstetrics, being the most unpredictable of the specialities, is not the easy one to practice, and I will not be surprised. And it's already the fact that young graduates do not want to take it up. That is the last choice that somebody wants most of the time. From the obstetrician's angle, our aim should be to see that we don't provide any patient to the critical care people. That should be our aim. We should see that we manage things in such a way that our women do not end up needing critical care. But having said that, we all know that is not always the case. One of the biggest disservice to the specialty is that pregnancy is supposed to be a physiological event. What is there? And even senior administrators will say, especially if they are ladies, they will say, I have delivered so many without any problem, so what is there? That sort of an attitude is there widespread. And as a result, support for obstetric activities, even from the administrators, is not always there. But all over the world, one thing is recognized. Maternal mortality has to be brought down. MMR, maternal mortality ratio, has to be brought down. And every government, every international body like WHO, UNICEF, and of course, governments, they all are interested to bring the MMR down because that is supposed to be the best index of the standard of a society. It reflects the respect the women and children, especially girl children, command in that society. So from that angle, everybody wants to bring down the MMR. But when there are so many people responsible for that, if you take for the Indian setting, Government of India, the National Health Mission, the state governments, and of course, we medical professionals, all of us are responsible. And as happens, when there are so many people responsible, not one person will take total responsibility. That is the tragedy about obstetric care in general and reducing maternal mortality in particular. As was rightly emphasized by our chief guest, being prepared is the best way to prevent that calamity from happening and to tackle it when it happens. So this sort of workshop certainly will help us in achieving that aim. And I congratulate the Royal Care team, especially Dr. Sivakumar and his colleagues for organizing this meeting and the large number of participants who are there. I congratulate you for being here to listen to these experts and take home messages which will be implemented in our day-to-day practice. Thank you once again for this opportunity.
Thank you, sir. Thank you for highlighting the importance of bringing down the maternal mortality rate, a passion which is close to your heart. Next, we have Dr. Rami Rajagopalan, Professor and Head of Clinical Services, Department of Critical Care Medicine, Sri Ramachandra Medical College. Sir is a pioneer and an important person in evolution of critical care medicine as a specialty in India. He is a renowned teacher and many of us here are his students. Sir is an invited faculty in almost all the critical care conferences in the country and has multiple publications to his name. He was the past president of our national society, the Indian Society of Critical Care Medicine. So we kindly request you to felicitate the occasion.
Morning, Dr. Madheswaran, Dean Nirmala, Professor Piley, and my dear student, friend, and right now, clearly a leader in the ISCCM as it's growing at the present, Sivakumar. It's a great pleasure to be here once again for one of these meetings. Like I said, it's almost been more than a decade that Siva has been doing this in terms of organizing focused areas of education in varying aspects of critical care. And this year, the selection of obstetric critical care has a dual blessing for me. The one, not only being a part of Sivakumar's program, but also because he actively involved my wife, the obstetrician in my life, in this meeting. And as a consequence, I have a double connection to this. As expected, and as we saw from yesterday's workshop, the quality of the education that we've been giving has been really top class. I mean, to have Professor Piley over here to talk about maternal mortality is I mean, other than having God to talk about it, is going to be a very, very important kind of a point that we need to convey over here. And again, my two colleagues from the ISCCM, both of who are relatively senior individuals and great teachers, have also been involved in the process. And I think yesterday's workshop went off absolutely terrifically. And I hope that the rest of the conference also does exactly the same. And knowing Sivakumar and his prior record, I guarantee that this is going to be a great program. I thank you all for attending this, and I promise you that the rest of the meeting is going to be something that you will enjoy. Thanks.
Thank you, sir. Thanks for your insightful speech. We at Royal Care Institute of Critical Care Medicine conduct multiple courses in critical care, and we'd like to congratulate last year's successful candidates in various courses at this juncture. First, we have the successful candidates of Fellowship in Neurocritical Care, a one-year course conducted by the Society of Neurocritical Care, India. May I request Dr. Rami Rajagopalan, sir, to do the honor. We invite the candidates, Dr. Nandakumar P. Dr. Sivakumar M. Dr. Sivakumar M. Dr. Sendilnathan T.A. Dr. Vivekanandan P. Next, we have candidates of Indian Diploma in Critical Care Medicine, a one-year course conducted by the Indian Society of Critical Care Medicine. May I request Dr. Pradeep Rangappa, Senior Intensivist and past Vice President of Indian Society of Critical Care Medicine, to kindly do the honor. Candidates, Dr. Abhinaya Ratinavel, Dr. Arun Chakravarti Periyasamy, Dr. C. Mohan, Dr. K. Saranya Raj, Dr. Nitya Kannappa, Next, I would like to invite Dr. Srinivas Samavedam to kindly come to the stage to honor the remaining candidates. May I request our chairman, Dr. Madheshwaran, to honor Dr. Srinivas Samavedam. He is the president-elect of our National Society, Indian Society of Critical Care Medicine. It's an honor to all of us. you, sir. I request you to honor our remaining candidates. Next candidate, Dr. Shajita Beham Naina. Dr. R. Shivaram. Next, we have the candidates of Indian Diploma on Critical Care Nursing, a one-year course conducted by Indian Society of Critical Care Medicine. The candidates, Mrs. B. Bhanupriya, Mr. D. Jacob Franklin, Ms. K. Jyotimina, Ms. P. Ramya, Ms. M. Soundarya. Thank you, sirs. Next, I would like to invite Dr. Yaman Sivakumar, our Organizing Secretary and Head of Critical Care, Royal Care Hospitals, to give an overview about the ICU update and Royal Care Institute of Critical Care Medicine.
Good morning. Once again, a warm welcome to each and every one of you present here. We have been doing ICU update, a theme-based CME program since 2005. Every year, we take up a theme. So we have covered topics like toxicology, trauma, pulmonary, neuro, obstetric. Obstetric, we did in 2012, and we are again doing it in 2024. Barring 2 years of COVID and the year where we did South Zone, we have been doing this program on a consistent basis. This program is an effort to disseminate knowledge, thereby taking an effort to homogenize care across this region. At this juncture, as a token of gratitude, I want to thank few people who have been instrumental in doing this program all these years. First and foremost, I express my deep sense of gratitude to my beloved chairman and the hospital management. Without their support, it may not be possible to do programs of this magnitude. They have been always supportive and they have been always encouraging. Second, I express my gratitude to all my faculties for being part of this program. The huge success of this program is due to the faculties and the scientific content. My teacher and mentor, Dr. Rami Rajgopalan, has been always part of this program. He is like a CSK and Dhoni. So we can't think of an ICU update without Dr. Rami Rajgopalan. So he is always there. And I also express my gratitude to all the faculties, my good friend Srinivas, Pradeep, and the faculties who have been part of today's meeting, Dr. Pailizar, and other obstetric faculties, and the faculties who have been part of this program in the past. I also express my gratitude to all the delegates. I think there has been a huge presence of delegates in all this ICU update, which gives a lot of motivation and encouragement to do such programs over these years. I also take this opportunity to thank my colleagues back in ICU and the marketing department of my hospital. They have been very supportive to do these programs, planning it well and doing it in a meticulous manner. I also take this opportunity to thank the industry. So they have been very supportive to do good quality programs. Last, Yesterday's workshop, we want to restrict to 90 to 100, but I think we ended up in 150 delegates. I'm sure yesterday's workshop was very useful and you had a lot of learning and take-home messages. I'm sure today's meeting also will be productive and you will have a lot of things to take back. Thank you. Wish you a good meeting.
Thank you, sir. That concludes the inaugural ceremony. May I request the dignitaries on the stage to be escorted back to their seats among the audience. Let's move on to the most expected keynote lecture. I invite the moderators of this session, Dr. Manonmani, Professor and Head of the Department, Coimbatore Medical College, and President of Kovai OG Society, along with Dr. Kalyana Kumari, Consultant Gynecologist and Infertility Specialist, Advanced Laparoscopic and Robotic Surgeon, Royal Care Hospitals, to kindly come to our stage and take over the session. Over to you, ma'am. You can kindly invite our speaker.
அனைவருக்கும் வணக்கம். Good morning to everyone present here. I would like to thank the Royal Care organizing team, chairman and the Dr. Sivakumar for inviting me to chair this wonderful session. It is my immense pleasure and is proud to introduce our Paley sir. He is the star speaker of all the conferences and over South India as well in all over India. And as per the Government of India release 2021 maternal mortality, the Kerala is standing first in reduction maternal mortality 19 per 1 lakh live births. So sir is so instrumental in achieving that. Actually, we are in the 4th place following Maharashtra and Andhra, Telangana. So we are having mortality around 54 per 1 lakh birth. Our state government is aiming to bring it down to single digit, but Kerala would be achieving it faster, very, very faster. Actually, they are on par with the Western countries. So it is my pleasure to invite sir to talk on why mothers die and what is there. Please take over the session.
Thank you very much. Thank you, Sivakumar and the organizers for this opportunity, and Dr. Manonmani and Dr. Kalyana Kumari for chairing the session. I have been asked to review with you why mothers die. And an added note there, what have we learned over the years? I assume that Sivakumar is referring to the audit that we had been doing and what did we learn out of the audit. Actually, we asked this question ourselves 20 years ago. In 2002, when we started the Kerala Federation of Obstetrics and Gynecology, the only committee that we formed at that time was the Maternal Fetal Medicine Committee, with the mandate to find out why mothers die in Kerala and what can we do about it to bring it down. And we knew that audit is the only way to know the facts. There are different types of audits. As all of you know, verbal autopsy, it is not really, it's a little deceptive term. Autopsy, people will immediately think about cutting open. It's actually going into the details surrounding a maternal death, right down to the periphery, to the home of the person, to the village, up to the hospital, and find out what really went wrong and why death happened. That's verbal autopsy. There's a facility-based audit. If it's a hospital death, going to the hospital and finding out, especially with the records, that is facility-based audit. There's a near-miss audit because for every maternal death, we all know that at least 10 times there will be near misses who could have ended it in a death but got saved. And of course, there's a confidential review of maternal death. When we thought about all this, we decided that we will do the confidential review of maternal death. In the UK, they call it confidential inquiry into maternal death. We thought we will not put that word inquiry there because it has got some threatening feeling with it. So confidential review of maternal death is what we started. And the purpose was to find out why mothers die. Then, as a sequel to that, we should strive to reduce and eradicate all preventable maternal deaths. As I said a little while ago, in the Indian context, whose responsibility is it to reduce maternal death or to bring down the MMR? The government of India, the state government, WHO, practicing obstetrician, and the medical fraternity as a whole? Or is it the woman's family? Or she herself? Or the society at large? When there are so many people responsible to bring down maternal deaths, what will happen is everybody will think it is the other person's responsibility. We have a saying in Malayalam, "Pala makkalulla thalla vellam irangi chavilla." You know, some of you may know because we get so many Malayali patients here. What it literally means is the woman with many children will not have even one to give her the last drop of water. When the responsibility is with so many, nobody will take it seriously. Of course, there is a corollary to it. If I say that if the woman, dying woman, is a wealthy woman and has plenty of children, all the children will come around fighting who will give the last drop. That's a different matter altogether. So, saying that so many people are responsible, it's the government's responsibility, can we obstetricians wash our hands off? I feel that we cannot. Because the obstetrician has a selfish reason to see that we prevent all preventable maternal deaths. Because when a woman under our care dies, even if it is not due to any of our faults, we are traumatized. We are the ones experiencing and sharing the anguish of the family, of the children, rest of the children, or the baby which survives. And we invariably end up feeling we could have done something better. That guilt feeling is there. At least for that single reason, we should strive to reduce maternal deaths. And when we started in 2002, as I told you, we decided to find out why mothers are dying in our state. And the Maternal Fetal Medicine Committee was entrusted with the responsibility. We knew that we cannot do it by ourselves. So we joined hands with the government of Kerala. At that time, fortunately for us, the Secretary of Health was receptive to our suggestions and accepted that they will recognize us, the agents, as the agents to do that audit. And when we said confidential review of maternal deaths, the first question that was coming up in many people's hands was, will it be really confidential? Can we pass on the information to this body and make sure that they don't, say bad things about us, criticize us like that? That fear was in our professional colleagues. Government also could have said, we have a mechanism to audit, to find out what is happening. There's a hierarchy of people to do this, and why should we entrust you to do that? But fortunately for I would say, fortunate coincidence, the Secretary of Health at that time could be persuaded to our suggestion that we will audit all the maternal deaths. But to audit the maternal deaths, we should get the case records. In Kerala, we were fortunate because even at that time, about 96% of the maternal deliveries were happening in the hospitals. Now it is 99 plus. So because of that, we had some records about the mothers. Without records, we cannot audit. So that is why we started it, and we had the precedents to help us. In the UK, they started it in 1952. So imagine, it's almost like 70 plus years since they started it. But after that, many other countries adopted it, and they are all practicing good about it. But they said one thing: the audit has to be by the practicing obstetrician, not by the administrators, not by the DMO or other people in the team, not by the college authorities. They let them do what they are doing. But for confidential review, it has to be by the practicing obstetrician, because only the practicing obstetrician will be able to know the minor aspects of the care, which an administrator may blame the obstetrician for, but a practicing obstetrician will know in reality whether it was possible to do that. Also, a practicing obstetrician is the one who can say the records are perfect to know where exactly they would have cooked up. So we said it has to be a practicing obstetrician to do the audit. Second thing, confidentiality is important, and there should be no punishment. If there is a punishment, certainly cover-up will occur. And also, they thought that judicial intervention should not occur in this process. And the whole history of confidential review in the UK, nobody auditing was pulled up to give evidence in the court of law. And we were feeling hopeful that that will be the state in our situation in our state, and in Kerala also. So far, none of us has been called up to give evidence in a particular case, because many of these deaths would have gone to the court. The WHO supported us to start the workshop as well as to start it. But the important thing is, government's audit usually happens with the government hospitals. The private setup doesn't get involved. And in Kerala, 70% of the maternal deaths happen in the private sector. So what will you do? Whether they will cooperate? Whenever I present this, everybody's question. Okay, for the government hospital, government says they give the notes. What about the private? But the fact is, in our state, it is the private hospitals which cooperate more than the government hospital in the audit process. This is just a shot from the first meeting that we had. Some of the people that you see over there, this is Philpott. This is Gwyneth Lewis. This is our own Kerala, Mathai Matthews. And these are the people who helped us to start off with this one. And we went on to have these meetings. Every case sheet is photocopied, anonymized, and then handed over to assessors, and that is how we did it. We published our findings. This is the first edition, this is the second one, this is the latest, the third one, up to 2020. So that is what we did. But after the audit, the records are burned, so that nobody can then ask for the records to be submitted to the court. So we could find out why mothers are dying. We have all these, I don't want to go into the details, but the leading causes were, as was mentioned earlier on this morning, hemorrhage, hypertension, sepsis, heart disease, amniotic embolism, and a lot of the other things. Now, audit by itself is meaningless unless you follow up with action to rectify what problems you identified. So WHO itself has changed the concept that we should not stop just by audit. We should have, that is surveillance, that is the audit, and the response to it. What can be done to prevent that happening again? That's the essence of doing the audit. And that's exactly what we did. We did many training programs. We did workshops, went around the whole state in all the districts. We innovated things. We had to, for example, when PPH was the main problem, a couple of our colleagues, you would have heard about Samartha Ram, who popularized the cannula, Dr. Panikkar, who popularized the cannula. We developed the transvaginal urinary clamp. Those who attended yesterday in the workshop would have heard about it. So we innovated, we invented, and then popularized those things. But we also found that about 50% of maternal deaths are preventable. Not preventable in the best tertiary care hospital, even under ordinary setup. And so we had to find out why it was not then prevented. And then only we realized that even small things are not available in the centers where it should be available. People who are supposed to be giving care are not there. But of course, we don't have any punitive power, so we could not take action against what happened, the lapses. But we realized and tried to convey this message to our colleagues, not only to the doctors, but the nurses, and say that this is what is happening in our state. Our strategy was to prevent the preventable maternal deaths. So we started this program of PPMD, Prevent the Preventable Maternal Deaths. And that's a motto by WHO and UNICEF now. By 2025, prevent all the preventable maternal deaths. Whether they would achieve that is a different matter. I think I have to rush through because the time allotted is only 15 minutes. And so I thought it was 45 minutes, so I had kept so many slides, but I would just go to a few of the points which probably you will feel are more relevant. We have to have what Ram Rajagopal was talking about. In every delivery point, every obstetrician should be aware of what to do. So just to So the way forward, we thought, was maternal death audit and surveillance has to be an ongoing process. Causes and circumstances will keep changing. Because when we started, we knew that about 20% of maternal deaths were due to PPH. But at the moment, the leading cause of maternal death is not hemorrhage anymore. We could make an impact on that. So analysis found that suicide is a major cause of maternal death now. And this is something which is going to happen across the world. I'm sure it will happen in Tamil Nadu. Social media is one of the major causes of suicides. All these things, changing concepts, we have to identify. And as I said, audit is meaningless unless we follow it up with remedial action. There's a big pool of faculty required for the training. And who will be there? So we have to train our own faculties. RCH officer, as a functionary in the government setup, is probably the pivotal person who can do the best. I hope it is there in every district, even in Tamil Nadu. Across the country, it is there. Each team, each district has to plan what is relevant for that particular area and then do it. For example, even for your area, or if you go across to the hilly areas, there may be more tribals. The need for them will be different. So we have to analyze what is required in each setup. The problems, once they are identified, we have to find solutions. And the healthcare providers, not necessarily doctors, but the nurses also have to be trained. And The person who is there on the spot when a delivery happens should be trained and empowered. You remember we had this problem. Nurses are not allowed to administer intravenous medication, any medication. So these things have to change. The politicians and the government officials have to be involved, then only anything effective can happen in a democratic setup like ours. And the other thing we found that the magisterial audit, that is what the government of India recommends, the collector auditing in front of the relatives and the villagers may not bring out the facts. We don't have it. There was pressure for us also, but I could convince our other officials that we can do without it. Until now, we have been successful in preventing it. But I know in your state you have it. And that sort of an audit very often make the obstetricians alter the diagnosis, alter the circumstances, change the records. We cannot blame them because the consequence will be so severe. Audit has to be taken to the periphery. So what we did was, as an offshoot from the confidential review, we did what is called MDNMSR, tongue twister, isn't it? Maternal death and near miss surveillance and response at the district level. The obstetricians from all delivery points come together once a month and find out why mothers died or the near misses in that district, and then work out solutions for that. That is one of the things most eagerly followed by our colleagues across the state. Staffing at all delivery points have to be round the clock. No point in saying a delivery point with doctor available only during the daytime. So minimum of 3 obstetricians should be allotted when you plan to have a delivery point, rather than have only 1 obstetrician, and that one lady obstetrician who will go off maternity leave for 6 months and there will be nobody there. The people come thinking that there is a delivery point, and then all the problems start. Cause of death written in the death reporting form need not be the truth. Amniotic embolism was a defensive diagnosis many times. And now that place is taken up by peripartum cardiomyopathy. Anything that is not easy to put word, peripartum cardiomyopathy. But our cardiologist told us, if the myocardium doesn't get oxygen for a short time, all the chambers will dilate. And that cannot be put. So a shock will lead to that. And as I told you, cause of death will keep changing, and we have to adapt and adopt measures accordingly. There will be always problem of supply of money. But if you ask for something which costs crores of rupees, maybe they will find money for that. But if you ask for a speculum which costs only 3,000 rupees or 800 rupees, they may not find it there. That's the problem. So preventing maternal deaths should not be the responsibility of the obstetrician ideally, but we cannot shirk our responsibility on that. So it's amazing what we can accomplish if you do not care who gets the credit. I would paraphrase it like this. It's amazing what we can achieve if we are prepared to share the credit rather than say that I did it or we did it. So yesterday in the workshop, people were asking where we can get all the clamps, which I showed you and all that. This is the address. I will probably leave that slide on. And we have this training program, which all of you are welcome. We call it TOPS, Training in Obstetric Procedures Using Simulation, a 2-day intense training program where you can get some hands-on also. And Toxicon, which many of you usually regularly come, is on August 17th and 18th. So I'll leave this slide on, but let me once again thank you very much for the opportunity to share our experience with you. Thank you.
For his informative lecture. Sir, we realize that there are so many social and political reasons, apart from medical reasons behind maternal death. And you also nicely explained about the remedial measures to be taken at various levels, medical, paramedical, and government level. I would recommend all young obstetricians to read his book, Why Do Mothers Die?, which will be very useful in their day-to-day practice, because most of the maternal deaths are potentially preventable. Sir, once again, I thank you very much for your participation in our scientific program. Thank you, sir.
So thank you, and I am really happy to say here that Tamil Nadu government has purchased SR cannula for all the government hospitals, including all the CMONC centers, and we have NASG suits. Actually, for this IoT clamp and transvaginal uterine artery clamp, we may be giving the suggestions to the government, sir. Thank you. Thank you, sir.
Thank you very much.
Thank you, sir. I request Dr. Perry, sir, to felicitate our moderators. Dr. Manonmani, madam. Kalyana Kumari, madam. We'll now break for the tea. It's been served outside the hall in the corridor and near the registration counters at 3 places. Kindly reassemble soon. We'll be starting our next session in 10 minutes.
Homeopathy and embolic catastrophes. I feel privileged and honored to welcome the first speaker and an eminent speaker, Dr. Tarakeshwari. She did her MBBS from Rangaraja Medical College, Kakinada. She did her MD from Kasturba Medical College, Manipal. She currently heading the department Obstetric and Medicine Unit, Fernandez Hospital, Hyderabad. And she has a special interest over medical disorders complicating pregnancy and high-risk pregnancy. Over to you, madam.
Thank you for the kind introduction. Greetings from Fernandez family. It's an honor to be here, and I thank Dr. Sivakumar and the team, as well as Dr. Srinivasa Samavedam. I think he's the man behind to inform Dr. Sivakumar. So I'll try to do my best over the next 15 minutes, and a little nervous after listening to the eminent speakers in the previous sessions. So I'm given a topic of hypertensive disorders in pregnancy, and we know that hypertensive disorders affect 1 in 10 women. Incidence in the lower middle income countries is much higher. And why it is important? Because it affects 1% of the women with hypertensive disorders, and these emergencies are associated with a higher mortality. As you heard previously, more and more women with advanced maternal age, obesity, and comorbid conditions like diabetes, hypertension, uncontrolled hypothyroidism, underlying chronic renal diseases, they're all coming out with pregnancies, and hypertensive emergencies in such women is associated with a higher mortality. As we all know, before we label somebody as a white coat hypertension or hypertension, sometimes women say, I'm nervous, so BP is high in the clinic. Accurate measurement of the blood pressure is also important, and with mercury sphygmomanometers are being not used because of the environmental hazard, and we have more of automated devices. We should be careful in measuring hypertension, and the proper position is important, and we always say that this take 10 minutes, talk to me, and then I'll measure your blood pressure recording. And also the accurate cuff size and cuff length is important, and we need to measure the mid-arm circumference. We always tell our colleagues, junior colleagues, or the PGs, or the DMOs, accurate measurement is very important. So when it comes to the hypertensive emergencies, when the measurement of the blood pressure more than 160 and 110 millimeters of mercury, lasting for more than 15 minutes during pregnancy or postpartum, is known as a hypertensive emergency because of its effect on the end organ damage. Hypertensive urgency is only the blood pressure measurement. There is no involvement of the end organ damage. So this we should always remember, there is an end organ damage with this hypertensive emergency. It needs an immediate attention, intervention, and intensive care, and delay in the treatment of this hypertension emergencies. It leads to cerebral hemorrhage, pulmonary edema, myocardial infarction, eclampsia, and these are all associated with uteroplacental insufficiency. How do you monitor these women? So once you get a high blood pressure recording, you put her into high dependency unit and you get the labs and the blood pressure is getting under control or not. And if it is a single organ involvement, we can continue to monitor. But if you have somebody with oliguria and a creatinine of 1.4, then immediately shift her into the ICU. So it depends upon the setup where you're working, but definitely they require an intensive monitoring. Let's look at this case scenario. 34-year-old lady booked at 16 weeks. She's a fourth gravida, previous 3 vaginal births. She's a known hypothyroid, corrected iron deficiency anemia. Her regular checkups were fine and the fetal growth was fine. Suddenly she landed up in the emergency department at 35 plus weeks, and she has the symptoms of shortness of breath, uneasiness, and a tachycardia and a blood pressure of 230 over 130 and a tachypnea, and she has got bilateral crackles on the auscultation of the lungs. And the saturations were 94%, and she required an oxygen 5 liters per minute, and suddenly we get a urine dipstick as 3+. Now, I think you all know this scenario. It's a pulmonary edema, and there is acute hypertension. So women with acute hypertension can for the first time present with stroke, and 25% is the incidence. Pulmonary edema, congestive heart failure, sometimes they can have an intracranial hemorrhage. And yesterday we have learned about the eclampsia and how to do the drill. So the most common cause of maternal death is the cerebral injury. The incidence of stroke is increasing. Maybe we are able to pick up more women. It is 30 per 100,000 women. So the systolic BP more than 160 millimeters mercury is the most important determinant. It can be a hemorrhagic stroke or an ischemic stroke. Hemorrhagic stroke is 4 times higher in the women with preeclampsia. There is a disruption of the blood-brain barrier because of the failure of the cerebral autoregulation and the endothelial dysfunction. Incidence is higher in the postpartum period. This emphasizes the need to follow up these women in the postpartum period. Birth is not the answer for everything. Coming to the pulmonary edema, when the blood pressures are above 160 millimeters of mercury, and as I told, associated with preeclampsia or eclampsia, this is basically due to the increased hydrostatic pressure in the capillaries and the reduced oncotic pressure in the plasma, and there is a rise in the afterload, and also the endothelial dysfunction. Coming to the congestive cardiac failure, there is an increased peripheral vascular resistance which increases the afterload, and this leads to congestive heart failure. The risk is increased by 2-fold due to severe hypertension in pregnancy, in the immediate and the later part of life. So we need to follow these women. Coming to the renal pathology, we call it as acute kidney injury now. This can be due to the reduced glomerular filtration rate due to renal artery vasospasm. And also there is an endotheliosis of the glomerular capillary bed. Most commonly we see an association with the HELP syndrome. So somebody with preeclampsia has got elevated liver enzyme, she has got a creatinine of 1.5, and then the urine output goes down and there is a low platelet count. So this is a very important complication. If not taken seriously, it can lead to maternal mortality. With acute kidney injury, the maternal and the fetal mortality can increase up to 30 to 60%. Yesterday we heard about eclampsia and this drill. Most of the times, big thanks to magnesium sulfate, we are able to start the magnesium sulfate prophylactically and able to prevent eclampsia. The incidence is around 5%. Why all these complications are important? While these are happening in the mother, the fetus gets affected because of the effect on the fetoplacental unit. If it is a woman who has chronic hypertension, there can be a superimposed preeclampsia and fetal growth restriction, and iatrogenic prematurity is quite high. Stillbirth, abruption is an important complication, which we know with the acute rise in blood pressure. When we deliver these neonates prematurely, the respiratory distress syndrome and also more admissions into NICU is needed, and also the more incidence of neonatal deaths. So whenever we have such scenario of increase in blood pressure, we call it as a preeclampsia profile. You ask for the urgent labs, complete blood counts with the platelet, because we look at thrombocytopenia. We ask for the liver function test if there is an increase in the liver enzymes, and the LDH if there is a hemolysis, increase in creatinine, as I said, acute kidney injury, hyperbilirubinemia. It can be a part of the HELP syndrome also. or acute fatty liver of pregnancy, and we do the bedside GRBS. ABGs are very important, and in the earlier scenario, I said there can be a chest X-ray, and don't forget to do simultaneous fetal evaluation. And when such scenario with the acute pain abdomen, you need to send serum amylase, lipase, and ammonia. Continuing with the case which I presented, this woman, chest X-ray showed pulmonary edema, ABG showed type 2 respiratory failure. So the important goal of management of hypertensive emergencies is the control of blood pressure to minimize the end organ damage, avoid acute hypotension that is risky to the baby, avoid maternal side effects because of the drugs what we use, and think about later birthing her the long-term control of blood pressure and delivery when indicated. So we heard about modified obstetric early warning scoring system. There is something called as the modified early warning trigger tool. So you have these parameters on the left, the systolic blood pressure below 85 or above 160, the diastolic below 45 or above 100, the heart rate below 50 or over 110, respiratory rate less than 12 or more than 24, the temperature, oxygen saturations less than 93%, and a fetal tachycardia. Along with this, the altered mental status and abnormal pain. This triggered pathway is important because it tells us which pathway to take and how to treat this mother. Either you can go into the cardiopulmonary pathway or you can go into the hypertension management. For example, if somebody has a heart rate of 110 and a mean arterial pressure less than 65, SATs less than 93, and a respiratory rate less than 24 with an altered mental status, you consider cardiomyopathy or pulmonary edema. On the other side, if you have a hypertension above systolic 155 and diastolic above 105, and immediate treatment is required, you take the treatment protocol for the control of hypertension. So the advantage of having mute is that it triggers the pathway and you follow either it's a cardiopulmonary or a hypertension pathway. Sometimes there can be an overlap, as you can see there, with the above on the cardiopulmonary. If you have SATs less than 93% and a respiratory more than 24, you consider pulmonary edema. Lowering the blood pressure, no more than 15% to 25%, because you can't just get acute hypotension. That's why we say sublingual nifedipine should not be used. Small reductions in blood pressure in the first 60 minutes, working towards a diastolic level of 100 to 110 are recommended, particularly in hypertensive emergencies. The target blood pressure without comorbid conditions, systolic blood pressure between 140 to 150 and a diastolic between 90 to 95, and with comorbid conditions, remember it's 130 to 140 systole and 90 to 100 diastole. So you can have different drugs. The first line of management with labetalol, we looked at it yesterday in the eclampsia drill. Whatever drug you have is the first line, have that algorithm readily available in the labor wards and also in the post-operative wards, because initial how much to give labetalol, when to give labetalol, BP persistently 160, 110, 20 mg over 2 minutes, then recheck, then give another 40 mg, and still on the higher side, you give 80 mg. So 10 minutes check. But when it is still on the higher side, then you add the second drug, it can be hydralazine. So you should have a pathway, what you want and what is being followed in your hospital, and the protocol should be followed. And once the BP is under control, monitor blood pressure every 10 minutes for the next 1 hour, and every 15 minutes for 1 hour, and then every 30 minutes for 1 hour. We should assign a nurse or a nursing aide to help us, and then you have to monitor every 4 hours. So the extremely important step is control of blood pressure and monitoring of the blood pressure. So as you all know, labetalol is a non-selective beta blocker and selective alpha blocker, and it is a direct vasodilator. Doubling the bolus to 80 mg can be done. Onset of action is 5 to 10 minutes, and peak action is 10 to 20 minutes. So half-life is 6 hours. Be careful when you're giving to somebody with asthma or who has a bradycardia. This is another chart with the first line management with hydralazine. You should have the doses written over. 5 to 10 mg is the one given over 2 minutes, and then you go to 10 mg over the next 2 minutes if the BP is still high. And here, if it is high, then you go to labetalol. So you have to switch over to the other antihypertensive. And we know that Hydralazine, it's a vasodilator, reduces systemic vascular resistance, and side effects are the headache and also reflex tachycardia, and should be given with caution, particularly when raised intracranial pressures. Some of us centers still, we can use nifedipine, but it should be the oral immediate release, oral nifedipine, not the sustained release tablet. And we can give 10 mg and then repeat 20 mg if the BP is high. And when still another 20 mg, and then you can change the pathway into labetalol. So we should have either labetalol, nifedipine, or a hydralazine. And if you are using one, and over the next 20 to 30 minutes BP is high, switch over to the next antihypertensive. So it is available as an oral preparation. It causes vasodilatation. Side effects are headache, nausea, dizziness. And there is a belief that when I give magnesium sulfate, I give nifedipine, mother will have atonic postpartum hemorrhage. Never it happens in the doses what we give, so don't get worried when you're simultaneously giving magnesium sulfate in anticipation of seizures. So coming back to the case, IV labetalol is given, and then 10 mg, 20 mg, then we gave 40 mg. The blood pressure was 160 by 100. So it's always worthwhile to have a choice of antihypertensive drug based on the organ involvement, and it is always better to have these algorithms available in your own setup. So when do we deliver? Do we deliver always when the BP is more than 160 by 110? Yes, definitely preeclampsia with severe features, with persistent headache, blurred vision, persistent epigastric pain. Pulmonary edema is an indication to birth, and oliguric renal failure or hepatocellular injury. So there is no role for conservative management for eclampsia, pulmonary edema. You stabilize the mother and consider delivery. And if you cannot stabilize, an in utero transfer to the higher center. Simultaneously, you should have a seizure prophylaxis. Yesterday we learned about magnesium sulfate. And the fetal assessment, it depends upon the gestational age at presentation, the limits of viability, and also the steroid cover if you can less than 34 weeks, and magnesium sulfate anyway when we are starting, it helps for the neuroprotection when the baby is less than 32 weeks. So this mother, luckily, she responded to induction. She had a birth within the next 36 hours, blood pressure was under control, we gave Maxelf, urine output improved, and she recovered and she went back home. Not always we have lucky scenarios. They go in for a severe morbidity too when we are birthing such women. Remember, the postpartum follow-up is very essential. Hypertension usually peaks on the day 3 to 6, and in postpartum period, the goal to control the blood pressure is less than 140/90 because we birthed the woman, the fetus is not anyway delivered. Taper antihypertensive slowly, educate the woman on imminent symptoms. It's extremely important to do the postpartum follow-up, either with your own doctor, physician, or an obstetrician. And also in the postpartum period, it is safe to use labetalol, nifedipine, enalapril, and captopril, and atenolol and metoprolol. We use atenolol and metoprolol a lot. Finally, the treatment algorithm for severe hypertension, it's always antenatal or within the 6 weeks postpartum, a woman presenting with 160/110, recheck BP, persistently elevated, call for help, give IV access, and send bloods for the hemogram, liver and renal function test. And then if the pulse pressure is less than 50, pulse rate less than 60, congestive heart failure. And if there is no IV access, immediately give nifedipine, and by the time you get help, you do the IV access and labs, and then continue to monitor her, and you can give IV labetalol and continue the birth. Whatever work we do, we should have a quality improvement initiatives. You can do your audits, you can regularly look at your antihypertensives and how many women went into morbidity, you can look into your near misses. All of maternal deaths related to preeclampsia had at least some chance of being altered by adherence to the systematic, evidence-based, and well-published algorithms for the management of hypertension. And there are so many quality initiatives that are available. The simpler and the best is the California Quality Improvement Toolkit, which is recently in November 2021, we have these algorithms available. They are freely available on the net. Any quality improvement, you look at for readiness, every unit should be ready to have their work being audited, availability of the drugs, and simulation drills being done. Recognition and prevention. Now we have a lot of screening modalities to screen for the mothers who have high risk of preeclampsia. Response to hypertension, reporting and system learning. So prevention, as I said yesterday, it's a primary, secondary, and tertiary prevention. Primary is giving low dose aspirin, 150 milligram. We have good available guidelines, and also we have biochemical markers, PAP-A and PLGF, that is being available. So low dose aspirin before 16 weeks of gestation and stop at 34 to 36 weeks. Control of blood pressure with the IV antihypertensives, labetalol is there, as well as you give magnesium sulfate, and also the tertiary prevention is timely delivery. So the risk reduction for future pregnancies and also follow-up these women is extremely important. So this is one guideline which we have risk factors and recommendation for low-dose aspirin. You have one high-risk factor or two moderate risk factors. It's safe to give aspirin. I'll take a minute, done. So recognition of high blood pressure, accurate treatment and diagnostic updates. And there are some missed symptoms which we always should remember. If mother says, I'm unwell, please listen to her. You may say she may be anxious, but you are missing something like her headache or blurred vision, or when you check low SATs or any severe upper abdominal pain, don't take it away. It just, you have a reflux and you can take some syrup. So we should always recognition of the missed symptoms. This is a nice trigger tool for the preeclampsia with severe features. It's there in the same California toolkit. You can use it in your own hospital. And the response, the seizure prophylaxis, and the delivery, and the postpartum surveillance. So hypertensive emergency in pregnancy and postpartum, it applies to all forms of hypertensive disorders of pregnancy. Do not wait to treat the hypertensive emergency. Give the timely antihypertensives. These algorithms are also available in the same California toolkit. You have an acute treatment algorithm, you have the antihypertensive treatment algorithm, and also the magnesium dosage and the treatment algorithm for refractory seizures. Reporting is very important. Rebriefing the cases, reviews, process, measures, and outcome measures is also important. You have to allow the teams to reflect on their performance and solve their problems, do the case reviews, and also the processes and the measures and the outcome measures, the timely treatment of hypertension, and next looking at the severe maternal morbidity as told by Dr. Piley in the morning. Not only the mortality, the near miss have to be looked upon. So to conclude, acute onset severe hypertension, BP over 160, 110, persistent over next 15 minutes. You start immediate treatment. If it is persistent, give again the dose. Antihypertensive drug should be administered. First line antihypertensives, labetalol, nifedipine, hydralazine. Target BP control 140 to 90. Reduce mean arterial pressure by 15 to 20%. Treatment algorithms for quick reference help in reducing the delay in the treatment. And don't forget long-term risk, because any hypertension in pregnancy, this woman has a risk of major adverse cardiovascular event, increased up to 2 times in her later life, cardiovascular mortality, stroke, as well as persistent hypertension. Please, please, please follow up these women with hypertensive emergencies or early onset preeclampsia. Thank you, and I invite you all to this Stillbirth conference, which we are going to do it in the month of September. I thank you for the opportunity and thank you for the patient listening. Thank you, chairpersons.
Thank you, ma'am, for your excellent presentation. You covered all the aspects of hypertension and its emergencies. I'm sure we gathered many take-home points from this session. Over to the next speaker.
Next two speakers needs no introduction for those who practice critical care medicine. Both are very renowned national speakers. First, I invite Dr. Srinivas Samadhan sir to deliver his talk on peripartum cardiomyopathy, diagnostic elusiveness and management strategies. Over to you, sir. And currently he is the Chief Critical Care Specialist in Ramdev Rao Hospital, Hyderabad, and President-elect ISCCM. Over to you, sir.
Thank you. Thank you for the kind introduction. At the outset, my extreme gratitude to Siva and his team and the team at RMCH for giving me this opportunity yet again to come to Coimbatore for this fantastic update in critical care. Next 15 minutes or so, we will discuss about a problem which most textbooks and literature would say is relatively rare, but also probably is sometimes overdiagnosed in critical care settings. Intensivists and cardiologists probably would try to look at it in a different perspective and more often try to make a diagnosis. But there are definitive criteria which should trigger a diagnosis of peripartum cardiomyopathy. It usually happens towards the end of pregnancy, up to 5 months postpartum, with an ejection fraction of less than 45%. LV dilatation may or may not be present. So it is not an essential criteria for you to include or exclude a diagnosis of peripartum cardiomyopathy. Other causes of LV dysfunction need to be actively excluded, and an idiopathic cause has to be established for us to make a definition-wise diagnosis of peripartum cardiomyopathy. So it's a non-ischemic cardiomyopathy with an ejection fraction of less than 45%, presenting in the first 5 months postpartum or towards the last trimester of pregnancy. Preeclampsia, hypertensive disorders of pregnancy, multiple pregnancies, and advanced maternal age are the known risk factors with no specific symptoms which are exclusive to a peripartum setting. All the common manifestations of heart failure are a part of the presentations in peripartum cardiomyopathy as well. But as Chaitanya described in the first talk this morning, increased respiratory rate, respiratory alkalosis, and hypoxemia are essential manifestations of cardiogenic failure, but they are also part of the physiological changes of pregnancy. So we need to know what is physiological and what is pathological. Multiple etiological factors are described in the pathogenesis of peripartum cardiomyopathy. So you can see that there are neuroendocrine factors, there are infective processes, and there are vasogenic factors. So the pathogenic factors work through the inflammatory cascade and recruitment of inflammatory cells, whereas the neuroendocrine and neurohumoral factors act through your pituitary hormones, and therefore the role of bromocriptine in advanced stages of peripartum cardiomyopathy. Vasogenetic factors through microvascular derangement of the microcircular homeostasis with multiple factors, again mediating through an inflammatory cell recruitment, are potential factors for the pathogenesis of peripartum cardiomyopathy. So the differential diagnosis of peripartum cardiomyopathy should be a pre-existing familial or otherwise toxic cardiomyopathy, valvular heart diseases, which are still not uncommon in this part of the world, congenital heart diseases, hypertensive heart disease, which is increasing in the antenatal population in this country at this point of time, myocardial infarction, stress cardiomyopathy, and we know pulmonary thromboembolism, which we will discuss in the subsequent talks. So when you look at the differential diagnosis of peripartum cardiomyopathy, several common conditions are included. But as you can see in this graphic, a meticulous history and physical examination cannot be replaced in shortlisting the differentials of peripartum cardiomyopathy. Electrocardiogram, echocardiography have been the mainstays in understanding valvular heart disease and congenital heart disease, so also hypertensive disorders and acute coronary syndromes. Currently, the role of cardiac MRI has increased, and it is now recommended to look at cardiac MRI if the diagnosis is not obvious with echocardiography and electrocardiography. If pulmonary embolus is a differential which you are entertaining, a CT pulmonary angiogram may be needed for some of these patients. In rare situations, in myocarditis related, if you want to exclude inflammatory myocarditis before you make a diagnosis of peripartum cardiomyopathy, an endomyocardial biopsy may be indicated in very rare situations. If you look at the etiology, the actual etiology of peripartum cardiomyopathy remains unknown, but the final pathway is likely an imbalance of angiogenic factors, as I have mentioned, plus oxidative stress by dysregulation of the endothelial growth factors and prolactin-based mechanisms. There could be genetic predispositions and also worsened by the hemodynamic stressors of pregnancy, triggering towards the end of the second trimester, which probably explains why it manifests in the early part of the third trimester and in the postpartum period. Some risk factors and worse prognostic markers have been identified for peripartum cardiomyopathy. As I mentioned in the earlier slide, preeclampsia, hypertension, multiple pregnancies, advanced maternal age, and drug abuse are risk factors. And prognosis is worse if the ejection fraction at presentation is less than 30%, the left ventricular end diastolic diameter is more than 6 centimeters, or there is an LV thrombus, or there is associated RV systolic dysfunction. Increased body mass index and MRI abnormalities will determine a worse prognosis among patients with peripartum cardiomyopathy. So if you look at the probable risk factors and proposed risk factors, we see all the things which we have discussed. Add to that, prolonged tocolysis could itself be a trigger for peripartum cardiomyopathy. Emerging risk factors are increased body mass index, genetic predisposition, and preeclampsia. So in this current era of genomic medicine, genetic analysis is an important aspect for risk stratification and prognostication among women who develop or present with peripartum cardiomyopathy. So the echocardiographic description and the clinical and echocardiographic description of peripartum cardiomyopathy includes the onset of heart failure in the last gestational month or 5 months postpartum with no demonstrable pre-existing heart disorder, and echocardiography showing the parameters which are displayed here: an end diastolic diameter of more than 2.7 centimeters per meter cube, a fractional shortening on M mode of less than 30%, and an EF of less than 45%. These are the diagnostic criteria for making a diagnosis of peripartum cardiomyopathy. A lot of units which practice high-end cardiac care rely on biomarkers to look at peripartum cardiomyopathy, and a lot of biomarkers are implicated or have been involved in the stratification of these patients. The most commonly available in this country is the N-terminal pro-BNP, which is a commercial marker for screening, but it is not specific for peripartum cardiomyopathy. It only suggests that the ventricular musculature is under strain, and mostly the left ventricular musculature is under strain. But there are several inflammatory and toxic causes of troponin elevation as well as NT-proBNP elevation. If you have a patient who's got acute kidney injury, either because of an HUS-TTP or an advanced HELP syndrome, you could still get an elevated NT-proBNP with an intact myocardium. So that's the caveat for the interpretation of NT-proBNP. Other biomarkers like prolactin, interferon alpha, cathepsin D, and soluble FMS like tyrosine kinase, these are all documented in isolated case series, but have not yet become part of standard recommendations or part of standard guidelines for analysis of patients with peripartum cardiomyopathy. But we can expect at least one of them, the FMS like tyrosine kinase, which is probably more specific in plasma of PPCM patients, to be coming up as a marker in the next 5 years or so. So when you want to manage a patient with peripartum cardiomyopathy in pregnancy, you need to avoid in the acute phase ARBs, ACE inhibitors, ARNIs, and avoid anticoagulation with warfarin and direct anticoagulating agents. And you need to plan for a delivery mode and timing with a teamwork with the cardiologist and the obstetric colleagues. During delivery, the staple patient should be allowed or permitted to deliver vaginally, accounting for changes in the hemodynamics like placental autotransfusion and relief of IVC compression, which may suddenly increase the right ventricular diastolic filling. But most importantly, at this point of time, a multidisciplinary team should be in attendance to attend to this patient. And during the postpartum period, you need to look at breastfeeding. There is no consensus on the risk versus benefit. So ARBs again probably should be avoided during the breastfeeding phase. Many patients will recover their ejection fraction, so you should probably wait for up to close to 6 months before you talk about primary prevention. So this is the summary of how you will stratify to manage your patients with peripartum cardiomyopathy. If there is a mild peripartum cardiomyopathy, you could manage them with oral medications where the patient presents with a subacute heart failure but is hemodynamically stable. There are no specific ECG changes. The chest X-ray may or may not show pulmonary congestion. There is elevation of the natriuretic peptide. The left ventricular ejection fraction is about 30 to 45%. So such patients can be monitored in the normal obstetric ward, or you can actually do ambulatory treatment if follow-up is assured. So you can manage with oral heart failure drugs like diuretics. Oral diuretics in the case of fluid overload, and for 1 week you can consider bromocriptine, but it's not a mandatory recommendation for this type of heart failure. But the ones which intensivists begin to see more often are the ones with moderate to severe peripartum cardiomyopathy. The ones with moderate peripartum cardiomyopathy are present, those who are present with acute heart failure, jugular venous distension, left ventricular third heart sound, and pleural effusions with hemodynamic and respiratory insufficiency. Now, such patients again only show a sinus tachycardia or maybe intraventricular conduction defects on electrocardiogram. Radiologically would show an enlarged cardiac silhouette and chamber dilatation on echocardiography with pulmonary congestion, a much larger elevation of natriuretic peptides, the ejection fraction between 20 to 35%. Such patients should be admitted at least to a high dependency unit, or if the hospital has a heart failure unit, they should go to the heart failure unit. Intravenous diuretics are required. Vasorelaxants if the systolic blood pressure is more than 110 millimeters of mercury. Such patients probably will benefit from supplemental oxygen and the use of CPAP, which decreases the afterload, which relieves the afterload and probably has a beneficial effect on the right ventricular functioning as well. It is better to avoid inotropes or catecholamines at this stage. Here you can consider bromocriptine for 8 weeks if the ejection fraction is less than 25%, but mainstay again in this group along with oral diuretics would IV diuretic as an immediate measure would be oral heart failure drugs. But the ones who are in most crisis and would require a lot of support, organ system, mechanical supports are the ones with the severe peripartum cardiomyopathy who present with cardiogenic shock with an cardiac index of less than 2.2, hemodynamic and respiratory failure, again can have ventricular tachycardias and supraventricular tachycardias, pleural effusions, a very significant elevation of the natriuretic peptides, ejection fraction of less than 25%, RV dysfunction as evidenced by an abnormal tricuspid annular plane systolic excursion and dilatation who need to be monitored in a critical care unit. IV diuretics, sometimes they may need inotropes, sometimes vasopressors. They usually would end up requiring invasive ventilation for lung protective and cardioprotective ventilatory strategies. In the current era, you cannot just stop with invasive mechanical ventilation. If the cardiac function and respiratory function are both abnormal, you should consider them from extracorporeal mechanical support, veno-arterial ECMO, or if it is very highly refractory heart failure, if you are planning a temporary device, you should actually look at an impeller device for supporting the heart till the acute phase is over. Longer duration of bromocriptine therapy, and after stabilization, you consider to put them on oral heart failure medications. There are other considerations which you should talk about in these patients. You look at thromboembolic complications, and because of the low cardiac output, venous stasis is also more, and they are at a higher risk of venous thromboembolism. So in these patients with low ejection fraction, prophylactic anticoagulation up to 8 weeks postpartum is recommended, and early mechanical support is recommended in the form of VA, ECMO, and impeller devices. Bromocriptine prevents the release of prolactin. It is currently not a high-grade recommendation, but it is part of some few guidelines. If there is no recovery of ejection fraction, you should recommend against future pregnancy, and during a future pregnancy, you should counsel the patients with and screen them with serial transthoracic echo with the help of an experienced cardiologist. So when you look at the management options during pregnancy, you have the choice of beta blockers, loop diuretics, nitrates, digoxin, and low molecular weight heparin. Mechanical circulatory support for severe heart failure, cardiogenic shock. You may also have to support the kidney with a continuous form of renal replacement therapy. Early delivery should be considered if the patient is too unstable and your veno ECMO parameters are not really optimal. Plan ahead for delivery with a cardio-obstetric critical care team. Hemodynamic monitoring, maybe with a pulmonary artery catheter for such patients. Watch for fluid overload, especially immediate postpartum period. They could flood their lungs and decompensate the heart. Heart failure management should continue for a minimum of 8 weeks, and anticoagulation for the LV thrombus, and if the ejection fraction is less than 35%, anticoagulation is required. Also look for arrhythmias and consider for a cardioverter defibrillator if arrhythmogenic LV dysfunction has been demonstrated. So the key to following up of these patients is assessment of the LV ejection fraction at 8 weeks postpartum. So if the patients have recovered their LV systolic function at 8 weeks, where the LV ejection fraction is more than 50%, that's a good cohort of your patients. Now, these patients will have a 30% risk of relapsed heart failure, and they have a 14% risk of persistent LV systolic dysfunction after 8 weeks also. And there is a 13% risk of premature delivery, but maternal death and subsequent arrhythmogenic mortality is less in this subgroup of patients. But those who have a persistent LV systolic dysfunction, where the EF is less than 50%, there is a high risk of maternal death even after 8 weeks after delivery. So that's an important thing you should document before you send the patient out from the obstetric ward. When you look at the outcomes, the worst prognosis, as we discussed already, is with the lower ejection fractions, dilated LV, and a delayed diagnosis. So you need to be prompt and apply the criteria meticulously for an early diagnosis and therefore an appropriate treatment. And for long-term outcomes, after recovery, the optimal duration of medication treatment is unknown, but it is recommended that they should be on medications for at least 12 to 16 weeks before you take a personalized decision on how long more you should continue the treatment. But in case you want to stop the medications, don't just cut them off abruptly, wean them off gradually, and then observe closely with the diuretics coming off the last. And continue the surveillance after recovery. Most of them would need an annual cardiac checkup for at least 2 years following the recovery from a peripartum cardiomyopathy. So subsequent pregnancies in the first visit, if they had a recovered ejection fraction, counsel them and reassess, take off the renin-angiotensin blocking agents and reassess the LV ejection fraction and get the biomarkers and a baseline echocardiogram. For those who did not recover their ejection fraction, counsel the family, stop the ARBs, switch to nitrates, and then follow them up again with baseline echocardiogram and NT-probe, the biomarkers. The maternal risks for those who had an ejection fraction of more than 50%, 20% will have a relapse. One more minute, I'm done. The rate of subsequent recovery is high, but those who have not recovered, 50% would show further deterioration, so they should be on a more tighter surveillance. Medications for those who have not recovered, continue the beta blocker therapy, add nitrates and hydralazine for hemodynamic and symptomatic improvement. You should consider digoxin with therapeutic level monitoring if feasible, and consider anticoagulation if the LV ejection fraction is less than 35%. What about labor and delivery for those who did not recover their ejection fraction? Multidisciplinary care, early delivery, and hemodynamic monitoring with mechanical support, and monitor for volume overload in the first 48 hours after delivery. So it is a complex scenario. There are multiple confounders. Differential diagnosis is vast. Confounding factors are many, so you need to rule them out very quickly. Early diagnosis, stepwise approach, and a multidisciplinary team looking after them can improve the quality of life and survival among women who present with peripartum cardiomyopathy. Thank you very much for your attention.
Thank you, sir. Thanks for sharing your knowledge on peripartum cardiomyopathy. So moving on to the next speaker. The next speaker is, I invite Dr. Pradeep Rangappa, sir, to share his knowledge on embolic catastrophes, amniotic fluid and pulmonary embolism. He works as Senior Consultant Critical Care in Manipal Hospital, Bangalore, and he was the past Vice President of ISCCM. He has numerous publications to his credit. Over to you, sir.
Yeah, so good morning, everyone. So thank you very much. At the outset, I wish to thank Shiva and Royal Care team for having me here. So the topic is little vast. So the topic assigned was amniotic fluid embolism and PE. So as you would know that it's a vast topic, I'll try to see how much we can cover in this. So the amniotic fluid embolism was first recognized in 1926 by Mayer, and it was reported first in 19. So it's an old one. So we seem to be underemphasizing, saying that it is possibly difficult to recognize this, and it's mostly a clinical diagnosis. And it's found to be one of the 5 leading causes of direct maternal death, and the occurrence rate is around 2 in 100,000 deliveries worldwide. So it's a global phenomenon, and we saw from Paley sir's report, it's around 6th cause in our India. So incidence in Fratty et al. Study, it's 5.5 per 100,000 deliveries. And if you look at the case fatality rate, actually, I mean, it's not 100%, so it is fairly acceptable, 24.8, and in one of the Italian study it was 12.8%. It's not like 100% mortality because they may have sort of symptoms with varying severity. And when you look at the risk factors, so elderly primary, which is possibly commonly seen in India nowadays, is more than 35 years, is a risk factor. Multiparous gravida is a risk factor. Preeclampsia is a risk factor. And there are a lot of uterine causes which pose a risk factor. So the rupture of the uterus for any reason, abruptio placenta, placenta previa, and male fetus is found to be risk factor. So the cervical tears and instrumentation during delivery and all the procedures the obstetricians do, so circlage removal, so on and so forth. So these are typical uterine risk factors. So the elderly primaries possibly remain an important risk factor for our population, I would think. So the pathogenesis, when you look at it, I think it is very simple. The amniotic fluid enters the systemic circulation for some reason, and there is a fetal antigen which sort of triggers off all the cytokine storm in the body. So once the amniotic fluid enters some sort of systemic circulation, so there is a release of a lot of these cytokines. So there is arachidonic acid, endotoxins, interleukin-1, so on and so forth, tumor necrosis. So we know these are the typical sort of cytokines which cause grief in our ICU patients. And there is increase in the inflammatory markers like interleukin-2, interferon, CD28, so on and so forth. So the key hallmark feature is they present like anaphylactic shock. So they have an intense vasoconstriction and they go into bronchospasm. So there is a respiratory component and there is a cardiovascular component and there is a coagulopathy component which happens in amniotic fluid embolism. And there is a coagulation sort of a cascade that gets activated and complements get activated. There's reduce in C3, C4. And if you look at the clinical dimension, it is very similar to septic shock or anaphylactic shock. So very hard to delineate whether amniotic fluid has set in or anaphylaxis has set in or septic shock. We may categorize in anesthetic causes or sepsis as one of the etiologies. So we may be under-recognizing this, possibly would be my submission. And there is mast cell degranulation also that tends to happen. So all this sort of leads to very complex sort of a clinical presentation, but they're pretty much acute in most of the cases. So clinical features, it can cause seizures, agitation, restlessness, but the hallmark feature, as I said, is cardiovascular, respiratory, and coagulopathy. So cardiovascular, they can have arrhythmias, collapse, and cardiac arrest. And respiratory, they'll go into bronchospasm, they can have respiratory distress, hypoxemia, and hemodynamic instability. And with regards to coagulopathy, they have multi-organ and bleeding and so on and so forth. So when you do transesophageal echo, they have shown a lot of cardiac changes. So there can be biventricular dysfunction, there can be pulmonary artery hypertension. So there's a lot of cascade that happens and there is multi-organ sort of an involvement. So it's possibly very hard for us to say that amniotic fluid embolism is set in, but it's all acute and it is high index of suspicion is what is needed. And in uterus, obviously, when all this is happening, because there is a uterine sort of a trigger for amniotic fluid, so they can have postpartum hemorrhage, uterine atony can happen, so they can have uterine rupture, laceration, so on and so forth. So there are obstetric complications that set in AFE, and there are a lot of systemic complications. So you need a combined team to handle such sort of a clinical scenario. And the Tsunami et al. From Japan, he has postulated there are 3 ways typically AFE presents. So there is a classic type, anaphylactic type, and DIC type. So if you remember this, that should be good enough. So classic is typically your respiratory symptomology, hypoxemia, respiratory distress, and ARDS. Anaphylactic is all the cardiovascular causes like arrhythmias, collapse, and arrest. And DIC, they can have coagulopathy. So this is a typical sort of a conundrum that tends to happen in amniotic fluid embolism. And the mortality is shown to be relatively less when there is a hematological sort of a cascade that gets activated, but respiratory and hemodynamic is what is devastating and high mortality happens. So your diagnostic sort of a acumen has to revolve around these clinical features that get presented, and maybe you should have high index of suspicion. So they have put in criteria, but that criteria is pretty much what I've shown you in a very schematic way, easier to remember that way. So there are certain laboratory tests if you go ahead to chase and confirm this diagnosis. So they've looked at monoclonal antibodies against CLL-TN, which is essentially an antigen which is present in the meconium and amniotic fluid. So if you are in a research center, you can look at doing this sort of an antibodies. And they've looked at zinc corpoporphyrin levels, which is elevated, and this can be identified in liquid chromatography. And complement level, because complement gets activated in amniotic fluid embolism, C3, C4 can be low. And you can look into cytokine markers in amniotic fluid like interleukin 6, 8, TNF alpha, so on and so forth. So these are some of the diagnostic modalities, very limited we have, but you have indirect findings by doing echocardiogram, looking at dysfunction, coagulopathy, and looking into those criteria. And there is some increase in the insulin growth factor, beta protein. So these are some of the diagnostic tools that we have, but possibly limited to maybe the research centers. So these are all not routinely, but complement is something that you could think of doing. So management of amniotic is largely supportive because there's no sort of a miracle drug for this. So obviously all the lessons that you have learned in the workshop with regards to improving the maternal sort of a circulation by aortocable displacement, so on and so forth. And when there is a cardiac arrest, you have to activate your code blue and follow the principles of ACLS that you all learned yesterday. And look for reversible causes. So I only would say that since the presentation is so complex with myriad sort of a clinical features, you need to see what are the factors that you can reverse. And obviously, now we have coined the new word resuscitative hysterotomy is something that you should consider. And 5H and 5T, please don't forget, although there is so much emphasis on BU chops as obstetric causes, but as intensivists, these are simple things that you can reverse. And all this can have a complex interplay when a complex sort of a devastating presentation of AFE is happening. And the best time for survival, which previous speakers have alluded, is to have that resuscitative hysterotomy. I've written as perimortem cesarean, so I'll change it to resuscitative hysterotomy should happen within 5 minutes for best survival. And best survival happens when there is a gestation of more than 24 to 25 weeks. So can't emphasize on airway. So you all have attended airway workshop yesterday. So it needs to be managed by an expert, not by an obstetrician. So you need to keep in mind that intubation in pregnancy, more than 50% can be difficult intubation. And if you fail in intubation by allowing a junior to intubate, it can increase the morbidity. So for all the obstetricians, have at least 2-3 senior people present when you are in a crisis of this nature. And you all have learned pre-oxygenation yesterday. So try to bag and mask ventilate, and that is given a good recommendation. At least that can save a life, and try to take it to some favorable outcome. And it is shown that pregnant ladies desaturate very, very fast, and the shunt fraction in pregnant ladies is much higher. So it is up to 15% shunt is what they have. So this is something that one needs to keep in mind when you are resuscitating this patient. So management is supportive, and all the intensivists are experts in making good hemodynamic optimization, optimal usage of fluids, vasopressors. Obviously, you would need to have invasive monitoring of some sort, with whatever catheters that all our intensivists are adept to, arterial line, and maybe a CVC lines for drug infusion, so on and so forth. And these patients, as Srini said in the last lecture, if they're very hemodynamically unstable, one has to consider IABP, ECMO, and even bypass if there has been a cardiac arrest, and so on and so forth. And when there is a uterine complications, invariably, as you saw the causes, uterine sort of a complications like PPH is a risk for amniotic fluid. So you have to look at your blood transfusion protocols, which you have in your place. So you have to give all the blood product components, which is packed cells, platelets, and FFP in 1:1:1 or 1:1:2 or so on and so forth, whatever your hospital policy is. And uterine management, so I'm sure I'll leave this to obstetricians, so some sort of a uterine massage and all this tamponade what you have. So basically I've summarized it. You have drugs to attain hemostasis from the uterine, then you have surgical options, then you have intra-arterial embolizations. So these are some of the modalities which you have to work as a team with obstetricians and try to fix the obstetric sort of a trigger that has caused amniotic fluid embolism. So what is key thing in all this is the survival of mother, or the fetus rather, depends on the survival of mother. So the whole focus shifts on the mother, because once you save the mother, the fetus survives. So that is the whole resuscitative hysterotomy I think we spoke about. So I think the key element in this whole amniotic fluid embolism is a coordination. It's a teamwork. It's not only intensivist. So intensivist, along with anesthesiologist, along with obstetric team, along with neonatologists, they all have to work in tandem to make sure the survival of the mother and the fetus happens with their involvement and with their teamwork. So that's in brief about amniotic fluid. So more common possibly is the pulmonary thromboembolism. We'll just switch gears. So pulmonary thromboembolism is the leading cause of maternal mortality or venous thromboembolism. So 1.08 to 100,000 maternity. Risk factors are very similar to amniotic fluid embolism. In addition to that risk factors, they have obesity and BMI more than 30. And just pictorially, any comorbid, if now many smokers are there, so we have to take the history of smoking more than 35 years. If someone has had a previous history of venous thromboembolism or any thrombophilic state like factor V lead-in deficiencies, protein C, protein S deficiencies, concomitant presence of sepsis or congenital heart conditions, or some lung conditions, COPD, so on and so forth, or asthma, or if they have inflammatory bowel disease, all these are the risk factors, or someone is undergone some surgical intervention, having some catheters, all these are the risk factors for pulmonary embolism and venous thromboembolism. And someone having hyperemesis is a risk, or pregnant ladies who had a long history of travel in air also becomes a risk, and ovarian hyperstimulation. So these are some of the risks for venous thromboembolism. And the obstetric risk factors is very similar to the picture I showed in amniotic fluid. All these remain the risk factors: instrumentation, cervical tear, abruptio placenta, more than 35, preeclampsia, so on and so forth. So these are the typical risk factors which are similar to amniotic fluid and the venous thromboembolism, except that if you have hyperemesis, long history of travel, or premorbid medical conditions, puts them at a risk for venous thromboembolism. And there is this virtuous triad where there is a slowing of the blood due to stasis or instrumentation or prothrombotic state, puts them at a risk for venous thromboembolism. And the risk for venous thromboembolism occurs in every stage of pregnancy and in the postpartum. And half of the risk for venous thromboembolism occurs in 20 weeks, I think after that, that is the highest risk period. And if you look at the data, the DVT is found to be more common, 75 to 80%, followed by pelvic vein thrombosis at 10 to 12%, and PE happens in 20 to 25%. And if it's pelvic femoral, it is usually iliofemoral. And the risk increases 20-fold in 12 weeks postnatal. So the risk for venous thromboembolism extends to postnatal period up to 12 weeks. And first 3 weeks is the higher risk. And left lower limb DVT is found to be more common than the right lower limb. And iliofemoral is 72% versus 9%. So these are some of the statistics we have. So DVT is more common, left lower limb is more common, and the risk is more in the postnatal period, and the higher risk is at the 20 weeks. So if you remember that, that should be good enough. And diagnosis is mainly clinical, so they would present with limb swelling, but the duplex ultrasound is the sort of a diagnostic tool that we depend on to determine the presence of VTE. And once it is positive, you have to start on anticoagulation. But if it is negative and there is no suspicion, then you wouldn't treat. But if there is increased suspicion, one has to repeat ultrasound on day 3 and day 7 to determine whether the VTE is possibly there. And there is something called left rule. So one has to examine the left lower limb. I'm sure most of you would be examining both lower limbs. So if the left lower limb diameter is more than 2 centimeters than the right lower limb, possibly that is cited as a hint towards increase in the risk of venous thromboembolism in that patient. And this needs to be noticed in the first trimester is what is referenced. D-dimer has no role because in pregnancy D-dimer tends to be higher. And chest X-ray to rule out any other pathology. So there is a debate, CTPA, whether we can contemplate in a pregnancy or a VQ scan. So that is a clinical call one should take. And they have looked at the breast cancer risk by subjecting them to CTPA, which is around 13.6% versus 1 in 200. ECG, the typical S1, Q3, T3, we all talk about in VTE or pulmonary embolism is only about 40%. So that's the sort of diagnostic tools, but pretty much we depend on duplex ultrasound, and clinical would be the way to go. So, and this seems to be a very simple sort of a thing to look at. So when it comes to management, low molecular weight heparin is the mainstay. So you can use enoxaparin or dalteparin. So for 3 months or 6 weeks postnatal, and even with this, recurrent pulmonary embolism is shown to occur in 1 to 15%. Newer oral anticoagulants, which you may all have heard of, dabigatran, rivaroxaban, these need to be avoided in pregnancy. Only low molecular weight heparin is what is approved. If someone has heparin-induced thrombocytopenia, one could contemplate on using fondaparinux. So additional therapies, if there is contraindications for using low molecular weight heparin, people have looked at using sequential cough compressors, but the evidence for that although if you have no way, then you have to contemplate on using it. There is this SOX trial, which they have done using the stockings. So, and they have looked with graduated compression stockings and placebo, there was no difference with regards to post-thrombotic syndrome, and recurrent DVT also, there was no difference. So the stockings which possibly is looked at should not be considered as a replacement for preventing VTE or treating VTE. So it has, there is no difference between placebo by just putting on the stockings. So if there is contraindication to the anticoagulation, then one should contemplate on IVC filters. So because that is something which is considered safer, but the fatality with that is 0.12 to 0.3, and these filters can migrate in more than 25%, and there can be filter fracture in 5%, and there can be risk of IVC perforation in 5%. So this is the data we have when you're contemplating on using IVC filters. So when there is acute massive pulmonary thromboembolism, so one should possibly think of using IV unfractionated heparin. There is risk of bleeding, especially in a pregnancy. When you're using unfractionated heparin, the risk of bleeding is around 2 to 3%. So how do we manage when you're treating a patient with venous thromboembolism with anticoagulation and they go on to delivery? So obviously you need to take some steps to balance the risk between preventing venous thromboembolism, pulmonary thromboembolism, and the bleeding. So there's always a trade-off when you put the patient on anticoagulation. So it is suggested that when you're contemplating induction or cesarean section, anticoagulation should be stopped for 24 hours prior to embarking on delivery process. And in case of high risk, if patient you believe is in a very high risk for venous thromboembolism, then low molecular weight heparin can be reduced to prophylactic dose if you highly suspect that the risk of venous thromboembolism is very high. You can reducing it to prophylaxis dose, and then going ahead with delivery is what is suggested. And if there is gross hemodynamic instability, fibrinolytics has shown to improve survival. And in advanced cases, one has to think of doing percutaneous mechanical thromboembolectomy or embolectomy. So these are all in advanced cases where you have lost out of all the options and there is hemodynamic instability, then you have to contemplate on these aggressive sort of a maneuvers. So the take-home message is amniotic fluid embolism and pulmonary thromboembolism are the leading causes of maternal mortality. And amniotic fluid embolism pathogenesis, as you saw the classic variant where there is a respiratory sort of a presentation, and then you have a cardiovascular, which is an anaphylactic presentation, or coagulopathy, is very similar to septic shock or anaphylactic shock, very hard to delineate. So all the categorization we see possibly in epidemiological, there may be overlap where we call sepsis, it may be embolism, where we say embolism, it may be sepsis, so on and so forth. So there is a overlap, so it's hard to clinically delineate between this spectrum of sepsis or amniotic fluid embolism. So that's obstetric risk factors for amniotic fluid embolism and pulmonary embolism is very similar. So both are similar. All those uterine atony, postpartum hemorrhage, abruptio placenta, uterine rupture, and more than 35 years, male fetus, all these remain same for both of these. Diagnosis of amniotic fluid embolism is only clinical, and you can use all these exotic tests like looking at the antigen, fetal antigen, so on and so forth in a research centers. Pulmonary embolism, you can obviously use venous Doppler and CTPA in a selected cases, weighing the risk benefit sort of an issue. Management for amniotic fluid embolism is mainly supportive, good ICU management, good hemodynamic management, good fluid management, good vasopressor management, and good sort of ACLS protocols to be incorporated. In advanced cases, ECMO or bypass may be needed if there is a gross hemodynamic instability. Pulmonary embolism, hemodynamically stable, anticoagulation is the mainstay. And please always remember the focus wholesomely shifts to saving the mother, because you save the mother, you save the fetus, and resuscitative hysterotomy is a good thing that we all learned in this beautiful session. And the key aspect, can't emphasize more, on a teamwork. There has to be an absolute sort of a communication channels open between intensivists, obstetricians, neonatologists, anesthesiologists, interventional radiologists I should have put here. That's also so valuable. And so it's basically a teamwork that we need to adopt. So thank you one and all. So I invite you all to our signature meet, Global Intensive Care, happening in Bangalore. So thank you one and all.
Thank you, sir. You have explained a difficult topic in a clear way. Thank you so much, sir. Any questions from the audience?
I invite all the three speakers, Tarakeshwari ma'am, Srinivas sir, and Pradeep Rangabha sir onto stage for Q&A session. mic.
Delegates, if there is any questions, you can come up to the mic and ask the
Please raise your
speakers.
hands, ma'am.
So you told about male fetus being more predisposable for amniotic fluid embolism. Any particular reason? Male fetus.
Honestly, I was also wondering, madam, maybe obstetrician should know that. Even I don't know the reason why males are common. I don't know if anyone has an answer for that. But everywhere it is cited, even for PE
Yes.
and amniotic fluid, male fetus is a risk. Maybe they're more heavy, they're more bigger, maybe, I don't know. I don't know, obstetrician should possibly answer.
Thank you, sir.
Excuse me, sir. If it any specific second trimester left roll, only you have to do in second trimester screening, sir. Left roll for first trimester. 2 centimeter dilatation for differentiation between right and left side.
The limb
Left
you
ro-
meant.
left.
The limb. It is
Left roll.
Yeah, it's mentioned that in first trimester is where you see the difference, and they are the patients who are at a higher risk and they need possibly more closer vigilance and screening. So the left leg circumference being more than right leg
centimeters.
circumference by more than 2 centimeters. And these are all just an adjuncts, I would think. But if someone has that, maybe good to keep a little closer vigil. But there's no hard data.
Thank you, sir.
Sir, routine postpartum for prevention of embolism, how many days to give low molecular weight heparin? Prophylactic.
Routine prophylaxis, if somebody has got an antenatal thrombosis, you have to
No,
continue.
madam, just obese patient like that.
Yeah,
Prophylaxis.
So it is 3 to 5 days after a vaginal birth and 7 to 10 days after C-section.
Okay.
Just to answer, the risk is there up to 12 weeks, madam. So the risk for venous thromboembolism is there up to 12 weeks. But prophylaxis, I think that's your clinical call, who you believe is at a higher risk, how much you give. But if you want to follow on the risk stratification, up to 12 weeks, they are at a risk.
In case of cardiac arrest, the role of lifting up the leg to improve the cardiac output.
Sorry, can you just repeat that, sir?
So in case of a cardiac arrest, generally we lift the legs up to increase the cardiac output. Does it have any role?
Not in the situation of cardiac arrest, sir. Cardiac arrest, you just have to follow regimentally the ACLS protocol and displacement of the uterus to the left to facilitate aortocaval sort of a blood flow and relieve the compression. I think we should just follow the standard protocol, and nowhere in the ACLS or any of this where a head lift, lifting the leg is sort of suggested, because all these theatrics possibly cannot happen in a cardiac arrest situation.
Madam, what is the BMI above which we should consider anticoagulation for a patient postnatally?
BMI you're asking?
Or weight?
Yeah. We take 40 as a BMI, but somebody has preeclampsia and BMI of 30. So comorbid conditions and 30 BMI routine, we are not giving it. 35 BMI and above. Uma, we give for 35 and 40 BMIs.
There's actually an RCOG guidance which gives you, based on antenatal risk factors, intrapartum risk factors. So when a woman books for care, I think it's good practice to put down whether she's high risk or low risk for DVT, and then at the time when they come in for admission, again put down. So BMI more than 30 is not a single risk factor, but if there is, as she said, preeclampsia, if they've had an emergency section, if there's a blood loss that's more than more than a liter, then it'll all add up. So we actually have this algorithm stuck in our labor ward and in our theater, because sometimes even after so many years we may forget. So it's good practice to have this laminated and stuck, and for every case have it, make sure that you have referred and then put down. So that is for routine prophylaxis.
Thank you.
I had a question actually about routine echocardiography. It came up yesterday also when we discussed. I think in the Tamil Nadu government, they routinely advise an echo in the antenatal period. So I wanted to know from Dr. Srinivas, what is the pickup rate? I mean, we are all worried. We're doing this for what is the pickup rate? And also from Tara, is that a practice in Telangana, and what is your pickup? So both of you.
So the issue is rheumatic heart disease and aortic valvular diseases are not uncommon in our part of the world still. Now, a lot of these undiagnosed valvular heart diseases come in extremis, especially if they've been unbooked. When they have a complication towards the term, they would end up in heart failure. That's why they come. So in resource-limited settings, easily accessible echo, if you have an echo in most district headquarters hospitals have now got echocardiography in Telangana, as I can say for my state. So the pickup rate, if you screen about 1,000 antenatal women, it is about 2 or 3 per 1,000. But considering the number of people whom we pick up, I think we will be saving quite a few from getting on to invasive ventilator support. The second reason why it is probably recommended is that you have even if it's a normal echocardiogram, what is the current ejection fraction, what is the current RV and LV size for that trimester of pregnancy for that lady, you would have a documentation. So without any complications. So tomorrow, 6 weeks or 8 weeks down the line, she has a problem. You have a baseline on which you compare that in the second trimester of pregnancy, this lady had an ejection fraction of 65%. It's come down to 55%, which is a reduction, which is something which you have to think about. So that is also something which we are realizing at this point of time, because we do get a lot of the sick patients who come with pulmonary edema immediate postpartum without receiving much blood transfusions, and we do an echocardiogram and we find an EF of 45% or 50%, and there is always this debate, this is a compensation, this is a normal physiological change of pregnancy. The obstetricians would argue with us saying this is abnormal. We would quote physiology and say this is a change in, this is a normal physiological change. Both of us are right, because we don't have a baseline on which you can fall back upon and say this is static or it is a decrement. So,
excuse me, sir. When is echo routinely recommended, and is it necessary to repeat the echo for maternal?
Yeah, I just add on to what Uma has asked. Right now we are practicing for IVF, high BMI of 40, comorbid conditions, hypertension, diabetes, and new onset symptoms. Like, to add on to what you said, Uma, risk stratification should come every trimester. So I should know in the third trimester if a lady has gained 20 kilos and she developed hypertension. And all pre-eclamptics, we are doing an echo. I think we should ask the intensive care specialist to teach us to do the basic echo for a mother, because most of us do the scans. We should learn the basic echo, I think, of a woman, pregnant woman. So if they can conduct a course, we can attend.
So, excuse me, sir. Ma'am, for echo, when can be initially done, and whether repeat echo should be done? Is it mandatory to do in first trimester? And,
no, not in first trimester. Okay. You have to pick up the echo physiologically. If you don't have any clinical abnormality which suggests there is a cardiac disease, when do you expect the peak cardiac output to be there? That is the middle of the second trimester. That is when you should get a baseline echocardiogram to understand what is the peak ejection fraction, what is the maximum LV end-diastolic diameter of this patient, and what is the basic right ventricular size of this patient at the peak of cardiac output and at the peak of her venous return. That will be the baseline against which you will then benchmark her worsening or her further subsequent echoes in the third trimester.
Sir, in patient with DVT, up to if the thrombus extend up to iliofemoral vein, does it mandatory to fix a IVC filter, sir?
Not necessarily, madam. Even if it is PE, we give anticoagulation. So anticoagulation stabilizes the clot and prevents the migration. So the whole concept of giving anticoagulation is to prevent the migration. So we don't need to put IVC filter just because there is a DVT or iliofemoral or pelvic vein thrombosis, but you would have to regimentally start and optimize your anticoagulation. So we would only contemplate IVC filter if there is a contraindication for anticoagulation and you are foreseeing a huge risk of pulmonary embolism. It is only to prevent pulmonary embolism. So we put IVC filter where you cannot give anticoagulation.
Thank you, sir. Then another question, in a case of PPCM, if the patient is stable, does we can allow vaginal delivery even though the ejection fraction is around 30, sir?
So those are two different parts of the algorithm. If somebody's ejection fraction is stable, you won't label them as stable. He will come into category 2 and category 3 patient. So you can't try oral medications on somebody whose ejection fraction, oral medications alone on somebody who is having ejection fraction of 30 or less. Those who are between the ejection fraction of 30 and 45 are the ones whom you can actually, closer to 40, above 40 to 45, you can actually do outpatient medication if they are regularly going to come to you for follow-up. If not, you can admit them in the ward and manage them. But if somebody's ejection fraction is less than 30%, it has to be a hospitalized supervised therapy with a combination of immediate intravenous therapy followed by maintenance oral decongestant.
About the mode of delivery, sir. So you have mentioned
That's what I'm saying. 30% is a sick patient. So you can't allow for vaginal delivery for such a. Am I right, ma'am?
Thank you, sir.
Thanks for that.
Sir. We heard a new word about stress cardiomyopathy. What is this stress cardiomyopathy?
Everybody who has appeared for a critical care exit exam, especially where Dr. Ram would have been an examiner, I think would have undergone stress cardiomyopathy. But it was previously called as tachycardiomyopathy. It's called as Sakasubo cardiomyopathy. It is called catecholamine generated cardiomyopathy. If you have somebody who has an inflammatory response for some other condition, is there a time limit for answers also? I didn't know that. Sorry. Okay. So I will complete the answer nevertheless. But see, so the persistent exposure of the myocardium to catecholamines and the persistent oxygen depletion that happens because of the increased oxygen consumption of the tachycardia causes a relative ballooning of the right heart and the left heart. Apical ballooning is called, and it causes a decrease in the ejection fraction of the heart. So it happens quite often in our septic patients. It happens in our burns patients in general critical care. It is also known to happen in pregnant ladies who have this unexplained tachycardia, uncontrolled tachycardia for a prolonged period of time of more than 2 to 3 weeks. That is stress cardiomyopathy.
Thank you, sir. I did not press the buzzer, sir. Thank you.
Sir, one more doubt, sir. Excuse me.
For want of time, we will. Sorry, ma'am.
Excuse me. Last, sir. Sir, in your setup, in dilated cardiomyopathy, your slide, your document as prophylaxis for 8 weeks, low molecular, low dose. In your slide, you mentioned prevention for coagulant, giving 8 weeks for prophylaxis. So in your setup, you are following 8 weeks, sir? 8 weeks. Okay, sir. Thank you.
Big round of applause for the delegates for asking so many questions. Encourage you asking questions for next sections also. Thank you.
May I request Tarakeshwari Madam to felicitate our moderator, Dr. Kalaivani. Dr. Nishant. Thank you, ma'am. Next, we have the interesting panel discussion on postpartum hemorrhage. I invite Dr. Pradeep Rangappa to take over the session.
Good morning, I'm back again here. So just to do the panel, so I have esteemed panelists with me. So may I invite Dr. Peli sir, Dr. Srinivas Sambedam and Dr. Sampath. So Dr. Sampath is an interventional radiologist working at Royal Care. So Srinivas and Peli sir are already introduced. So we have a good eclectic mix of the panelists. And as you see, the way this whole panel is devised, we need a teamwork. So it's not only intensivists or anesthesiologists, it's a combination of people who can save lives. So we'll just start with we'll put a context, clinical picture, and see how we can work together in saving life of a patient. So can we go to the slides? So me and Srinivas have to catch a flight, so we'll hope to finish this in time. So we'll just start with a case to set the pitch going for the whole discussion. So 29-year-old female, gravida 1, para 1, 39 weeks gestation. So presents with abdominal pain for few hours, episodic abdominal pain, which is increasing in severity. And there is a dilatation of the uterus of 3 centimeters. So then the obstetricians get involved, so she moves to the second stage, oxytocin is started, and they needed to do instrumentation to deliver this fetus, and the fetus was 4.2 kg, possibly a male fetus. And the placenta is delivered after 5 minutes. Okay, so this is the sort of a clinical scenario. So there are no real markers for this patient, no major sort of a comorbids. It's just a large fetus needing instrumentation, and the placenta is retrieved after 5 minutes. So oxytocin is going as a slow infusion. So after 20 minutes, this patient starts having hemorrhage. So she's having vaginal hemorrhage. So my question to Srinivas Sambedam is blood pressure. When this is happening, obviously we are monitoring this patient, 120 by 80, pulse is 90, so nothing unusual with these readings, isn't it? Respiratory rate 18, and capillary filling time, which was spoken by our previous speakers, was normal. So estimated blood loss, obstetrician tells that estimated blood loss is around 500 to 1000 ml. So my question to Srinivas is, would we be worried at this stage that patient has had this bleed, but the vitals, because intensivists, we're all glued to the monitor, looking at the vitals. So would we be comfortable with this, Srinivas? How do you approach?
If you look at the absolute numbers which are at the top of the screen, like a blood pressure of 120 over 80, a pulse of 90, and respiratory rate of 18, and a capillary refill time normal, I would be happy. But when somebody mentions to me that they've lost a liter of blood, and then they are not mounting a tachycardia response, I would be concerned about such a patient. Now, when somebody does not mount a tachycardia response to blood loss, if they were not beta blocked in the community, they were not having a high vagal tone because of preconditioning, and they are not hypothyroid in the community, I would look at, are they acidotic? That acidosis is the most important blunter of your tachycardia response. So at least I may not start resuscitating this patient as yet, because I believe she is not confused, she is completely alert, and capillary refill time is okay. So hypoperfusion has not started, but at least I would make sure that her electrolytes, her blood sugars, and her acid-base status are normal. If that is there, then I would keep her under observation, but not go over-enthusiastic with giving fluids and resuscitating this patient.
Yeah, so possibly, 500 to 1000 ml of blood loss obviously would raise our antennas. So obviously we'll keep certain things ready. We would put a cannula and we would keep certain fluid bags. So obstetric team examines, so they've started prostaglandins at this point of time. There's no tears in cervix or vagina. So after very soon, after we have kept all those things ready, 14 gauge cannula, fluids ready, and we are monitoring the patients more closely because 500 ml is lost, but the per vaginal examination doesn't show any tears, then slowly patient becomes cold, clammy. And so this, I'm sure most obstetricians would agree, this transition may not take too much time in obstetric practice, and they may become unwell very fast. And as you see, this patient has deteriorated, blood pressure drops, and I've heard these narratives that suddenly they become hypotensive and they become tachycardic, and there is a panic situation that generally tends to set in when such a situation, and then there's a delayed peripheral capillary filling. So my questions to Dr. Pally, who's authority in PPH. So in this situation, sir, these are the typical situation, unanticipated, elective sort of a delivery where you needed instrumentation. Evidently 500 ml is lost, but then this situation sets in. So what is running in obstetrician's mind with regards to the blood loss, and what would be your approach on this, sir?
The first thing I want to convey is when the patient is bleeding, we don't have to wait to estimate it is 500,000 or establishing a PPH definition by vaginal delivery more than 500 ml. That's not the way I would suggest the obstetricians to have the policy. The policy is the moment delivery has taken place and there is excess bleeding, as I showed yesterday in the algorithm, if you see there is excess bleeding, find out why and from where it is. If it is before the delivery of the placenta, it's quite likely that it will be a traumatic PPH. Look, that's the best time actually to inspect the vagina. Placenta is holding the blood back and vagina is clear. You put in a speculum and see if there is any tear or anything. Or if it is after delivery of the baby, immediately feel if there is excess bleeding, not measuring 500 ml, 1000 ml. Start acting the moment you see that there is excess bleeding. Every obstetrician knows how much blood. Usually after the placenta has come out, there will be some degree of dark blood coming out, but the uterus, once it is contracted, massaged, the bleeding slowly stops. But the fact that she has lost, it is written that she has lost 500 to 1000 ml, we should assume that she has lost more. The steps should have been activated at that time itself, not waiting for her to collapse. And this is the other problem. Postpartum, especially in the 4th stage of labor, people just wait at the pulse and the BP. And our teaching right from the quality standards that we evolved is pulse and BP alone should not be the observation points in the postpartum patients. You should feel the fundus of the uterus. Is there a hard uterus there? If it is displaced to a side, see why it is displaced. Is it because of a distended bladder? Or is it because of a broad ligament hematoma? And the other thing is, gently press on that, separate the thigh and see if blood is coming. These 4 things have to be observed in a postpartum patient in the 4th stage every 30 minutes for minimum 2 hours. So to answer your question, estimation of the blood loss is necessary to establish a diagnosis, but to start treatment, we don't establish a diagnosis. The moment you see excess bleeding, preempt that patient from going into PPH and start acting. That is what I would suggest.
Very, very valuable statement, sir. More so for intensivists and anesthesiologists, that when obstetrician possibly says there is a bleed of some nature, I think we should start acting with resuscitative sort of a measures rather than waiting. At least put an advanced hemodynamic arterial line to monitor the blood pressure and start resuscitating with some fluids until this situation does not arise. So this patient, as you see, has become tachycardic, tachypneic, hypotension, and oliguria can set in quite acutely in PPH. We have seen this very often. It may be transient, but it does set in. So just looking at background, so just a question to Dr. Sampath, who is an interventional radiologist. So would we be worried for this patient there is a risk of death? And what do we understand by primary PPH and secondary PPH? And just a little background on understanding the concept of primary and whether this patient is at a risk of death. Dr. Sampath.
Seeing this patient, she has a hemodynamic instability and there is oliguria. But at this point, if we intervene, we could avoid the risk of death. Possibly the first, she has to be managed medically, and if the hemorrhage is refractory, and possibly the next step would be embolization procedure, where we can go and block the uterine artery. And coming to the definition of the primary and secondary PPH, the hemorrhage which is occurring within the 24 hours, first 24 hours is the primary PPH, and which is occurring more than 24 hours and up to 12 weeks, it is called as a secondary postpartum hemorrhage. The differentiation is very critical because the etiology between the primary and the secondary PPH are totally different, because the primary is mostly, it is because of atonic nature of the uterus, and the secondary most common, the other causes like puerperal sepsis, or endometritis. These are the causes for the secondary PPH, and the management also differs between these two.
Thanks, Sampath. Just to have a quick comments from Dr. Paley, although there's so much emphasis from RCOG that your bleeding should be more than 1000 ml, or the number of pads as obstetrician would quantify the bleed. So should we de-emphasize on 500 to 1000 ml or more than 1000 ml or minor, major, and put everything into one basket and approach it, sir? Would that be that sort of a lessons?
Actually, theoretically and practically, this quantifying into 500 ml or 1000 ml is artificial. What is the other factor we have to consider is how much that patient can afford. Because a thin, short patient may not have that much blood volume to afford even 500 ml, whereas a larger patient can easily afford 500 ml. So the other factor which is difficult to quantify, and that is why in the definitions usually we stop short by saying 500 ml or 1000 ml. On the American side, they say 1000 ml. On the British side, and generally we say 500 ml after vaginal delivery and 1000 ml after a cesarean section. But what is most important for us to know is blood loss more than 500 ml has to be considered subnormal, and we have to act on that.
Okay, so that's a good lesson, that don't ignore any bleeding more than 500 ml. So all this can be for our understanding what is the severity. But just to answer the question, that that patient is at a risk of death, and this is the sort of risk that statistically, epidemiologically it's put, 1 in 1000 in developing countries can die with PPH. And we saw from Dr. Paley's data that it's the top cause of maternal deaths in our country. So Srinivas, just a quick overview on the pathogenesis and causes of PPH generally, and just to give a brief overview on what are the causes and incidence, pathogenesis.
Yeah, so
of PPH.
I think everybody here knows about the 4 T's. Tissue and trauma are the realm of the surgeons, so I won't be talking about that. Thrombin is something we need to talk about as, I can think about as intensivist, because it's just not the blood that you give. You start with fluid resuscitation with crystalloids, and then you start giving the blood. But when you do that, you are also inducing a little bit of hemodilution, and you may actually be triggering a hypofibrinogenemic state. So you need to be aware that this can be a problem, and you need to keep track of it. The other T is tone. While we believe that it's a structural anomaly of the uterus, but we also have to understand that while resuscitating these patients, the metabolic factors, especially the hemoglobin, the pH, and the temperature, are important factors which regulate the tone and will add to the atony that is happening. So if your hemoglobin is less than 6 grams, your pH is less than 7.2, and your temperature is less than 32, you are more likely to add to the problem of an atonic organ. So that is something from intensive perspective. We need to be looking at it from that perspective also, and try to exclude that from the possible causes of atony.
Thanks, Srini. Just for all the trainees, the incidence reported from various sort of a literature is 1 to 5% or 2 to 3%. Pathogenesis, why PPH is dangerous for us is the uterus receives a lot of blood supply during pregnancy, 500 to 700 ml per minute, and it constitutes 15% of our cardiac output, which is very significant. And that's why there is so much of hemodynamic derangement and dissonance that happens when PPH sets in. And the causes typically, as Srinivas has already said, is atony is the commoner causes, or uterine laceration, or rupture, so on and so forth. So, and again, how do we strategize the management with and the risk factors, Dr. Paley sir? So how do we look at risk factors and trying to minimize the modifiable risk factors to avoid PPH, sir?
Regarding risk factors, any uterus that is overstretched, that means a larger uterus means multiple pregnancy, hydramnios and all that. Any grand multi, which is rare to see in our part of the country, and I'm sure here also, grand multiplicity, all these conventional risk factors, going by that is not very relevant. Any woman in labor is a potential candidate for PPH. That is how we should take it. And the standard management should have prophylactic measures for that. And that is why routinely we say the active management of third stage of labor. And the moment we see that there is excess bleeding, any obstetrician, anybody who has conducted a few deliveries will understand how much is to expect from a normal delivery. If you find that it is more, activate. And that activation, as I was telling yesterday in the workshop, was immediately by manual compression of the uterus, that is compressing the uterus, not just putting 2 fingers in the vagina and massaging the uterus. Compress the uterus. That by itself will not stop the bleeding. Now we have more effective ways of controlling the bleeding. The suction cannula and the clamps, which we were describing again and again yesterday, are the ones to be taken as early as possible. So the risk factors, as you have put down there, obesity, parity, high parity is no more an issue most of the time, but somebody who is already anemic is likely to bleed more and not able to tolerate even the minimum loss. So we have to individualize the situation regarding that rather than put risk factor. Any induced patient is likely to have more atonicity after the delivery of the baby also. Regarding the planning, I think every labor room, every obstetrician should consider that a pregnant woman in labor is a potential candidate for PPH. That is the way we should plan. And the resource availability, one of the things that we usually find missing is the provision to call for help. Even though everybody will be carrying mobile and this and that, the moment you need somebody to be called, you go for the mobile or the phone, nobody will answer. The more senior we are, less likely that we will answer the phone. And especially, so these are the things. So the public address system, if it is available in the hospital, utilize that. We should develop a code system to call for help. In our hospital, we have developed 2 codes. In addition to the standard code blue and code purple and all that, we have 2 codes. One is whenever there is a patient who is collapsing, maybe due to hemorrhage, maybe due to amniotic embolism, we have a code which is, once it is announced, the anesthetist, our rapid response team, and if it is from the labor room, the neonatologist, all of them will rush to the labor room. The other is for a crash cesarean. So we have code 10 for crash cesarean, code 1 for maternal collapse. Once that code is announced, all the people required will come, blood bank automatically is alerted, and they will take action. So I think depending on the situation, we have to develop strategies to call for help. The obstetrician concerned should take steps to stop the bleeding, which are now much better off than, say, even 15 years ago. And hopefully the labor room, the blood bank would have been warned if there is excess bleeding, and blood group of every pregnant woman should be known and should be recorded.
Thank you, sir. Thanks for valuable. So I think the 2-3 points which is of interest to us, it says family history also is something which is important for PPH. And I think we are seeing increasingly obese patients. So should we sort of advocate lifestyle modification and weight control in pregnancy? Because that is a risk. And most importantly, the thing which is of interest to us is many places these deliveries happen where there may not be blood bank. And having blood bank as a backup for these high-risk pregnancy, is it to be made mandatory sort of a thing, sir? Because if the PPH happens, then you do not have resource availability, or if you have not had a blood bank backup. So that can be a serious issue in many places. So what are your quick thoughts on that.
To answer the first part about the obesity part, once a patient is pregnant, we usually don't recommend weight loss to be a part of our management, but weight gain, we should try to ask them to avoid too much weight gain. Weight control should be planned before you plan pregnancy. But anyway, that's not always the case even in our society at the moment. But coming to the blood and availability of blood, it is true. In the state of Kerala, we had about 500 plus delivery points. I'm sure in Tamil Nadu, if you take, it should be much more. All those places cannot have blood bank. But what we insist is every delivery point should have a blood storage facility. I hope that in Tamil Nadu also that should be the policy. Storage facility. And every pregnant woman should be told that she should know her blood group, as well as she should identify one or two donors who will be told when she comes to labor room and who should be made available in case they need blood. This is in addition to having, of course, blood availability to be improved across the state.
Thank you, sir. I think one important aspect that was emphasized from this study was having a robust PPH protocols in any unit which is dealing with high-risk pregnancy has shown to significantly reduce the risk of DIC by 64%. So this is just a preparedness and having multidisciplinary team, because now you have a lot of standalone centers and there not necessarily you may have other team support, especially for high-risk pregnancy, and that has shown to improve their outcomes. So there are studies to say that have a PPH protocol, have a multidisciplinary sort of an approach for high risk, and significantly it reduces the morbidity. In fact, PPH kit, which sir has already mentioned, is possibly something that all the units dealing with high risk pregnancy should embark on having it as a PPH kit. I'm sure Peli sir may have some comments on that. And these are some of the protocols which people talk about, having PPH protocols in place. So Dr. Sampath and maybe Peli sir can give comments after Dr. Sampath. So how do you have PPH protocol in your hospital, and have you adopted some sort of a protocolization, because you are an interventional radiologist? At what stage you are called in the protocol, or is it for every high risk you are involved, or is there some sort of a timelines where you are roped in? So do you have some sort of a SOP or an operational sort of a procedure in your hospital?
In our hospital, since it is most of the time it is PPH is not anticipated, and most of the even risk factors, patients more than 90% of the time, patients without risk factors start developing PPH. So most of the time it is not anticipated. So generally we receive a call when there is significant blood loss even after the medical management. So at that point of the time, most of the time we receive the call.
Now, what if you have gone on a vacation and there is a PPH happening, and
So,
protocol says that IR is always should be there in the hospital, and you are dealing with it because yours is a busy hospital. So how would you address that?
we have a luxury of having two intervention radiologists. If it is a daytime, we don't have much difficulty. Most of the time will be available. But as you said, it is difficult if it is just happening in a Sunday or in the middle of the night, then it will be a difficult task. So if we get a call prior to the hemodynamic instability, we can be in, maybe we'll take some half an hour to reach, and we have to arrange lab things. So it will be helpful to us if we are intimated earlier.
Yeah, so I just need to little bit emphasize here, and obviously I expect valuable comments from Peli sir and Srinivas, because in my hospital, when there is a PPH, very high risk pregnancy, and a patient is blood, 2 phone calls come, one immediately goes to IR. I just want to understand if this is a norm. It goes to IR, interventional radiologist, and one call comes to ICU. And from ICU, obviously we do all this, whatever you are seeing, ABC, oxygen, warmer, we put a 14-gauge cannula, all these resuscitative tools and blood products we arrange. So is it now become a norm that IR is mandatorily need to be there for any such pregnancies? So valuable comments from Peli sir, followed by Srinivas on this.
We try not to lose their sleep. in the last 5-7 years, I don't remember calling the interventional, even though we have the interventional radiologist for any of our PPH management. We call them not for primary PPH, we call them for secondary PPH, where, for example, somebody who had a cesarean is bleeding from the angle of the uterus, or a patient who already had a hysterectomy from the periphery and still bleeding is coming in, sent in like that. Very seldom we think about the interventional radiologist for a primary PPH. We manage it obstetrically. And these days, as I told you, the tools available for us have improved. We can make a uterus contract, provided she hasn't gone in for DIC. We make the uterus contract, and we block the uterine arteries. So that takes care of most of the time. But if there is, for example, bleeding from anterior-abdominal wall, inferior epigastric bleeding, which we have unfortunately lost in our state, I'm talking about our state, about 6 deaths have occurred because of injury to the inferior epigastric artery, not recognized during a cesarean, and then they go on to bleed later, presenting with hemoperitoneum because the parietal peritoneum is not closed, blood goes in the peritoneal cavity, fills up, and only when the patient collapses with a distant abdomen, we know that the bleeding is there. And we may, on reopening, find that it is inferior epigastric bleeding that has happened. We had occasions where, after obstetric hysterectomy, a drain was put, and the drain went through the inferior epigastric, which was not recognized. And then later, of course, when she died under autopsy, we found that it was bleeding like that. So occasions where we find unusual bleeding like this, the patient especially is not that easy or a good candidate to take for theatre, then we may consider interventional radiology. In other words, the occasions we call for interventional radiology to manage a PPH is very, very rare these days.
Yeah. Srinivas, quick comments?
My comments probably will be a little skewed because I'm talking from perspective of somebody who receives patients who have already crossed this stage, because we get referrals from other hospitals for patients on ventilator who are on shock, on vasopressors, for oliguric and already bleeding. That is the type of 30% of my patients who I take in this context are those kind of patients. So that stage is already over. So I don't have that option. So my comments should be interpreted with that background. So when such a patient arrives, I would alert my in-house obstetrics team, because some of them just come from the periphery into my ICU. But I also will call the interventional radiologist, because the hardware required to achieve, they want to do a procedure immediately, they are not easily accessible in the cath lab, unlike a coronary stent, which is available on the shelf in the cath lab. So I would talk to the interventional radiologist, make sure that there is a communication with the cath lab, the nursing staff, the technicians, everybody is alerted. We may not need it, but we will be ready with the hardware required for such a procedure, because the downtime in procuring them, even in a big city like where I come from, is half an hour to 45 minutes, which is big time when you talk about such a patient.
Yeah. So I think the take-home message is, if there is a primary PPH, obstetricians would have done necessary things to achieve hemostasis, and then they come to ICU. This is a typical scenario that happens. And in ICU, we would be doing all this, targeting hemoglobin more than 8, giving good blood products, resuscitating and all that. And if bleeding possibly continues and some bleeder has not, hemostasis has not been achieved, maybe at some stage IR has to be involved. So possibly it comes in a staged way is what we can sort of conclude from the comments from our esteemed panelists. So quickly, Srini, I think you did already mention about 4 T's as a treatment goal for all the trainees. I think you can quickly rattle through these 4 T's, Srini, and then we'll move to the next.
We have spoken about this in the workshop yesterday, and I've already mentioned about this. But again, it's not single person's job. The team has to be focused, all the team members have to be focused on these 4 T's, and those centers which have the viscoelastometric testing, that is the thromboelastogram or the ROTEM, should use it, because it will give you a more focused and more rational use of blood and blood products, because the more ad hoc and empirical blood you give, the more chances of dilutional coagulopathy and the more chances of transfusion-related lung injury and circulatory overload. So you have to pick and choose and hit the coagulation cascade with the target. ROTEM, if you have it, is a blessing. We can use it.
I fully endorse what Srinivas said. If you have the facility, going and selectively give the components that are required, certainly much better than the massive transfusion and all that we usually aim at. Whenever possible, we should aim at that.
Yeah, I think we have spoken a bit on obstetric management, so I'm sure most of the obstetricians are experts, so we'll possibly skip this aspect. Sir, anything specific you want to say in obstetric management?
One thing I wanted to say was about the oxytocic agents, the carbetocin, which has come in, which is certainly a good drug, but I do not know whether it is such a big wonder drug. If you have oxytocin properly maintained, then I think that is good enough. But carbetocin has the advantage, it saves multiple injections. One injection alone will do. We do get cases where carbetocin did not bring on the arrest of bleeding that we expected. So we had to use supplementary oxytocics. Another point, even though from the very beginning we had been talking about the cannula and the clamp, please remember the patient has already gone in for DIC. In such patients, don't go put in the cannula. We can still put the clamp, but don't put the cannula in somebody who is on DIC because that will all drain only all the blood that is there. There what we require is the clamp to cut off the blood reaching the uterus and replace or correct the coagulopathy. And that is where we require the help of the intensivist or the hematologist.
So, yeah, this patient has undergone all this medical management. Obstetricians have looked at all the different maneuvers they do to achieve hemostasis. So bleeding is continuing. Intensivist is working on all the blood products. So at what stage interventional radiologist, because Sampath, you would have got a call by now, and does that happen in concurrence with obstetrician? And what has been your experience with regards to your interventions in doing this uterine artery embolization and achieving hemostasis? What has been your experience? And have you felt that you have been called in late or you have called in appropriate time? How does it work in your place?
So most of the time when we get the patient failed refractory to the medical management, these patients are hypotensive. Most of the times some intensivist will be accompanying the patient and will also request the presence of...
So many a times you've got patients who are hypotensive already.
Yes,
and
most
sick.
of the times it is primarily it is from the referral from the other hospitals where there is no availability of intervention radiologist. These patients are being shifted to the intensive care unit in our hospital, and then only will get the referral. So from the so these patients are generally hypotensive, come intubated, will be accompanied by intensivist, and will also request the presence of anesthetist. So then the resuscitation as well as the management will go hand in hand in most of these patients. And from the intervention radiologist, we generally use ultrasound guidance for the access, because these patients usually in multiple vasopressors will have a small artery. So we'll use an ultrasound guided access. So some of these patients, most of will be already has lost lot of coagulation factors, will be in DIC. So if we use without ultrasound guidance, there will be a chance of access site issues, which will be another problem to tackle. So once we enter, gain the access, then we'll generally take a catheter to cross and will super selectively enter into the uterine artery and put some temporary embolic agent. It's usually a gel foam, so still there is a stasis. So if you have two intervention radiologists available, we'll generally take either side femoral artery, so the process can be a very rapid one. So once the procedure is over, we'll also check for, we'll call the obstetrician and look for any persistent bleeding. And if there is no further fresh bleed, then we'll stop with that, and probably we'll keep the sheath in situ for further, if there is any further bleeding, we can access the arteries. And if there is if there is further bleeding, we may look into the other causes like any other artery which may be bleeding. So we will take an iotogram, we'll look for any other source of bleeding, maybe from an epigastric artery, as I was saying, or from a vaginal branch. Sometimes it can be bleeding, and we have to go and block that also.
Yeah, thank you, Sampath. So, on elaborating on the technical aspect, but what I could gather from your narrative is that patients come little late. So, do you have any data in your interventional group? What is the ideal time you would want to intervene in this patient? And in your experience, what has been the time lag between the PPH onset and the time of your intervention? And is there a literature, body of literature or data to say intervening at this time leads to good outcome and reduction of blood transfusion practices? Do you have any data from your group, just out of our own interest?
Basically, if it is a patient is hemodynamically stable and if conservative measures are failed, it is the right time to call interventional radiology, because it is very easy and simple, rapidly accessible procedure to get hemostasis, because there is no complex nature involved in this procedure. Maybe it will take 15 minutes to block the uterine artery. But most of the time, what we the cases what we get is patients will be already hemodynamically unstable, and it will be difficult to access the arteries.
Okay.
So if it is the patient is hemodynamically stable, that would be the better time.
Okay, so the message for the audience is it's good to keep you involved, informed little early on if there is a feasibility, and intervention when they're more hemodynamically sane or stable is what you would desire to have better outcomes. So that's the message we can conclude on?
Yes, sir.
Okay,
Right.
quickly, I think we are run out of time. Just a quick comments on role of these newer agents. Factor 7 has come and gone. Maybe recombinant fibrinogen, because fibrinogen comes down in all PPH, and we do a lot of give cryoprecipitate. Now we have this new molecule, recombinant fibrinogen. Quick comments, Srini, and then we'll have a concluding remarks.
Yeah, factor 7, as you said, has come and gone. It has not been shown to change much of the outcomes of these patients. I'm not a great fan of, but fibrinogen, yes. If you are not able to source cryoprecipitates, it's easier to buy fibrinogen than get cryoprecipitates in some centers, but the cost is phenomenal. So,
I think quick comments on tranexamic acid from...
Yeah, tranexamic acid is now established as an adjunct to treating PPH. Many centers, the moment they find SS bleeding, they ask to give tranexamic acid. In many centers, they give it just with oxytocin as a standard also. WHO is very much in favor after the trial, and so we have no objection to that use. One other thing, or a couple of points I wanted to emphasize, because even in Tamil Nadu and in all your practice, there may be the occasion to transfer patients to a higher center. And please make sure stabilizing the patient, and if it's a PPH situation, taking steps to prevent ongoing bleeding in transit, and using the NASG, which I am sure in Tamil Nadu is very popular. All these are important when you transfer a patient to a higher level. In other words, taking steps to prevent her ongoing bleeding while she is being transferred is important, and the clamp can be applied and sent. The cannula can be applied and sent. That is one to be kept in mind.
Thank you, sir. Just for the audience, so the women's trial, it's a very positive trial. Just look at this data. So giving tranexamic acid early has shown to reduce death significantly. If you delay by more than 3 hours, it was not significant, which means the sooner you give tranexamic acid in PPH, you will be in a position to save lives. But if you have exceeded more than 3 hours, this big data did not show difference. So try to consider it early on in PPH is the message. So I think we'll just conclude with concluding remarks. So quick concluding remarks from 3 panelists, and we'll close this session, and me and Srini have to rush to airport. We are already running out of time. So quick remarks from 3 of you, sir. Peli, sir, Srinivas, and...
Yeah, as we said earlier on, every woman in labor is a potential candidate for PPH. So the minimum standards should be available in the labor room. Labor room should have a PPH box. Even the most high-tech should have a PPH box, because things that you require, if they are all in one box or tray or whatever you call it, it's easier to get it rather than hunting for things at different places at that time. Only the oxytocin or the drugs which in methergine, which need to be in the fridge, has to be looked for. Other things should be in that tray. So be prepared for that. Second thing, proactive. Expect that PPH is a possibility in every woman, so be prepared. And the moment we feel that bleeding is excessive, start acting rather than wait for established PPH and then act. These are the 2 points which I would suggest. And the obstetrician, unfortunately in the developed countries, obstetricians, the surgical skills are taken away. If you have to do a cesarean, just straightforward, you are allowed to do. If you have a tear laterally, you have to call somebody else for help. My own suggestion is, obstetrician should be able to do internal iliac artery ligation. Anybody who is doing a cesarean section should be able to do an internal iliac ligation. Not that internal iliac ligation is so much needed. For electronic PPH, we don't need it anymore because of the other stepwise devascularization. But for traumatic PPH, we will need it. So don't abandon the surgical skills our seniors had, which you would have seen and which is passed on. Don't abandon that. It is needed to be continued. The Western practice is not to allow the obstetrician to do those things. I think we should not allow that to happen.
Thank you, sir. I think the role of the intensivist is actually a calming influence on the whole team. So just say we are in control, we will manage the hemodynamics, we'll manage the homeostasis, please get the bleeding in control. For that, the intensivist has to have time and stay there rather than you and me who are now rushing away to the airport. If such an intensivist is on the floor, choose a different intensivist.
In interventional radiology viewpoint, I think referring a patient in the right time, because time is very critical in PPH. If a patient is referred in a stable condition, then will be because embolization is a very rapid and way to achieve hemostasis. So referring early would be a better way.
Thank you, Sampath. So thanks everyone. Hopefully there were good learning lessons. So, and we can possibly save more lives with teamwork. And I think the message from my end is give tranexamic acid early and involve intensivists and interventional radiologists little early on so that good optimization happens and we don't miss the boat and cause a lot of hemodynamic dissonance. Thank you one and all.
Thank you, sir. May I request Dr. Paley, sir, to felicitate our moderator, Dr. Pradeep Rangappa. I request Dr. Srinivas Samavedam, sir, to felicitate Dr. Sampath. Now we break for lunch. Lunch is served on the hall behind our registration counter. We request the delegates to reassemble in the hall in 30 minutes. By 2:30 p.m., we'll be starting the next session. Consultant obstetrician and gynecologist, Royal Care Hospital, Coimbatore, and Dr. A.S. Naveen, consultant internal medicine and infectious disease, Royal Care Hospital, Coimbatore, to kindly come onto the stage and moderate the session.
Good afternoon, everyone. This session is on infections in obstetrics. First session is on sepsis in obstetrics. It will be spoken by Dr. Rami Rajagopalan, who needs no introduction. He is the doyen of critical care and he works in Sri Ramchandra Institute of Higher Education and Research. I welcome Ram sir.
Thanks for the introduction. I think that word doyen makes me feel a little senile. Okay, so you can expect me to forget what I'm going to be talking about. I apologize if I do that. I think I'll blame it on you. Anyway, my topic is not going to be on the infectious aspects of the management of sepsis, but I need to emphasize that the intensivist does have a role in the management of the sepsis. And I just wanted to talk about that. Unfortunately, we won't have a talk on obstetric infections as such. I think you're talking on tropical infections. So it may be a little bit of a gap, just to start with that. Okay, so as I said, I don't have the brains to talk about the biology of sepsis in any way. And I'm going to just focus on giving you some kind of a hands-on approach to what you see in the peripartum patient. And this is not going to have enough time for me to discuss virtually all the details. The current surviving sepsis guidelines keeps adding more and more points that we need to look at, and it's virtually impossible to go through all of them. But I will focus on what I think is essential for you as an obstetrician to identify the existence of sepsis, and probably give you some kind of an introduction to how you stabilize the patients initially and then send them over to the ICU. We do know that the frequency of sepsis as a cause of maternal mortality is reasonably obvious. It is very significant, particularly in South Asia, where, in comparison to something like the well-developed world, where the frequency is significantly lower. But what we need to do is probably, the important aspect of managing sepsis is the early identification of the process. So how I'll do this is I'm going to try to take this through a couple of simple cases, or one case in a couple of ways, okay, which you might feel very comfortable with. So 25-year-old trainee, complicated instrumental delivery, vaginal delivery, and an episiotomy about 3 days ago, is now having fever. Okay. The patient has moderate pain, and somebody says maybe the vaginal discharge looks a little purulent. The patient is mildly anxious but is not complaining of any other symptoms. The heart rate is 105. The respiratory rate is about 24. The temperature is 38.5, and the white count is about 11,000. I still won't call Nambi yet. They're saying, okay, is this patient infected? I think most of us will agree that there is signs of infection. But the question that we need to ask is this patient septic? So I need to make very clear that there is a big difference between being infected and being septic. With infection being a microbiological phenomenon where the existence of organisms at a site which is normally not, which is either sterile and not colonized, versus sepsis, which is a systemic inflammatory response to the infection. It's the body's response that we are looking at, and it's not the microbiological event alone. So the question is, how do we identify it? And I'm going to take it through a history of how we did it, just to show you the reasons that we're going back and forth in terms of this process. So under these conditions, we typically would use what are called the inflammatory parameters, or the markers of what you call the SIRS, so this systemic inflammatory response syndrome, where you look at the heart rate and say, okay, this patient had a heart rate of 105 or something, it is higher than normal. The patient's respiratory rate was 24, it is higher than normal. The temperature was elevated, white count was not significantly elevated, but you had 2 out of these 4 criteria, 3 out of these 4 criteria present. We used to call this the SIRS criteria, and we'll say infection with SIRS is going to be considered as sepsis. Okay. The problem with this definition, unfortunately, was this definition was not only non-specific, it was also very insensitive in picking up the patients who are likely to progress to bad outcomes. So the patients who are likely to die, you don't pick them on the basis of these criteria alone. So there was a revision of this process. Sometime in 2016, somebody defined sepsis in a different way. They used what is called the sepsis 3 ideas, where basically the first thing they did was they rejected the SIRS criteria. They said this is not adequate enough for us to use. That what we should be doing is, we find that organ dysfunction, if you develop an organ dysfunction at the time you have sepsis, then it is a prognostic indicator. So we should look at the organ dysfunction and the number of organs that are dysfunctional for us to make that kind of a judgment. And to do that, they used a standard method that we use in the ICU, what we call as a sequential organ function assessment, or the SOFA score as we call it, where they saw if there's a change in the SOFA score by about 2 points, they would call it a definitive indication of sepsis. But then everybody said the SOFA score, you can do it as an intensivist, but we can't do it on the ward. So they suggested that you use something called a Q-SOFA, which is an abbreviated form for non-ICU cases. I'll just go through this very rapidly. So let's just take the same patient, okay, and say, if we are going to use this criteria, we'd rather go by organ dysfunction criteria. So later in the day, this patient is appearing drowsy. Organ dysfunction number 1, neurological. The eye opening to voice, confused, and has a GCS right now, it's about 13/15, couple of points down, but it's definitely an altered function. That's one thing that we see. We're also noticing that the blood pressure is downward trending and the urine output, they claim, was very low. Nobody documented the amount of urine output that is going, except that there was also increasing tachypnea. And you look at the vital signs right now, temperature is 102, heart rate has gone up to 140, the BP is 80/40, and the respiratory rate is 40. Okay, here we have all these signs of inflammation that are also become very severe, but at the same time, you're demonstrating certain signs of organ dysfunction, neurological changes, declining urine output, oxygenation changes that are occurring over here. And as a consequence, if I was to ask you, is this patient septic? Very, very clearly by the new definitions, this patient would be septic. And also we need to understand if she's with a blood pressure of 80/40 at the present time and requiring an inotrope doesn't correct with just fluid administration, she definitely has what you call a septic shock, and these carry very bad prognosis by themselves. Okay, for a long time, this is effectively what you did, and this is the SOFA score. As you can see, it is quite complicated. You need to look at number of parameters and you need to look at a number of grades. And very obviously, it won't be a very practical kind of a score that most people can apply. In the ICU also, it will be a little problematic to apply it on a routine basis. So on the other hand, the Q-SOFA, which was usually recommended, said, look at 3 parameters. Look at the respirations, look at the systolic BP, and look at the altered sensorium. And in this particular patient, all 3 were present. Anytime 2 or more were present, we consider it as sepsis. And the feeling was, this is a good performance, has good performance characteristics. They usually look at what you call an area under the receiver operating characteristics curve. If it's closer to 1, it is good. If it is less than 1, closer to 0.5, it is very poor in terms of discrimination. They said, oh, this is looking very good. But I think we misunderstood it because the area under this curve can change either with your sensitivity or with your specificity. When you're looking at screening tests, we want something that will be sensitive. That is, it will pick up all patients with an infection, and maybe it will pick up some more garbage. But it is safer to pick up all patients with the infection, and that is what we would like to have. And unfortunately, when you go back and look at the Q-SOFA, it has a sensitivity that's even lower than the SOFA, or for that matter, even the SIRS score. So people went back and said, we need to come back. And this is the Surviving Sepsis Guideline, which says, don't use the Q-SOFA. Think of using SIRS, or 2 other parameters, what they call the NEWS and the MUSE criteria, which I think you were familiar with earlier in the morning. So basically what they do is, you would use a parameter that has both inflammatory components and organ system dysfunction components, which is effectively what the MUSE does. If you look at the MUSE parameters, okay, you look at respiratory rate, heart rate, and the temperature, which are inflammatory parameters, and you look at the SBP, the neuro changes in the urine output, which are organ system parameters, and you're combining that, okay? And the nice thing about this is it gives you a systematic set of scores that you can even pass it on to your nurses who can plot it and then be told that if anybody falls into the red category, that needs to be accelerated in terms of care. If they fall yellow category and multiple yellow points, you need to be informing somebody or observing the patient closer. So you can accelerate the levels of care that you have. But unfortunately, there's one other thing that we need to be worried about is the pregnant patient. And we were told today that the features in a pregnant patient mimic sepsis in every way. The classic change in the cardiovascular system, the drop in systemic resistance, the increase in cardiac output, the increase in high heart rate, and probably the lower blood pressure, means that if you use these criteria, you'll have a lot of false positives. So somebody said, we need to redevelop these criteria, and that is what was done when you look at the obstetrics, one of these methods, the SOS score that they use, which is the sepsis and obstetric score, which uses similar parameters, not exactly the same, but it is very careful about selecting out the parameters. It says a BP that is higher than 90, okay, is necessary. I mean, not a BP, yeah. BP has to, if it is less than 90, then we'll call it abnormal, not 100 like we did before. The heart rate has to be less than 120 or more than 120 for it to call it abnormal, not like we used as a 100 cutoff. And you use a respiratory rate that is usually greater than 24, which is very common, again, in pregnant women to have rates that will be in that high range. So this is like an adjustment for the whole process. But unfortunately, as we look at all of these kinds of methods, none of them have an adequate enough sensitivity. This is just basically a summary of what I'm doing. So we said SIRS, SOFA, Q-SOFA are useless, we'll throw it away. We wanted the MUSE score, but then we realized that MUSE score may perform better, but it needs to be adjusted for pregnancy. So we develop scores like the SOS score. But unfortunately, none of these have sensitivity enough. So if I want to say, I want this patient to be marked as septic, you may not find it. Okay? But these scores, like the mu scores, can be used sequentially for you to categorize the progression of the patient, and it can be used to prompt a re-evaluation. Somebody had a yellow point, you'll say re-evaluate the patient to see if they're progressing in any way. If they're progressing in some way, accelerate your levels of care, call your doctor in. And if the patient moves into the red part, you need to consider moving them to the ICU. And this kind of process is absolutely worthwhile, even if it is not 100% diagnostic. So this is what we will do right now. The important thing in recognizing is, when I said about sepsis, and I'm talking basically about an inflammatory response, we need to be very clear that an inflammatory response can occur in wide variety of conditions, and we need to identify if this inflammation was directly linked to an infection. And that is very difficult, okay, to identify the infection on a consistent basis. And it is very important. Inflammation alone is not a marker of sepsis, okay? And we have to be very clear that we need to be able to identify the infective etiology. In this particular patient where I gave it, it's probably reasonably obvious that it is a purpural source that we have for the patient's infection. But it is important to recognize that in an antenatal or a postnatal situation, it is not just the purpural sources that can cause the infection, but you can also worry about things like pneumonias or pyelonephritis that can also be a part of the problem. So definitely, we need to have a little bit more knowledge of the kind of infection sites that we have so that we can, in fact, investigate where we're going to find it. You can't just be very happy that you saw a vaginal discharge and that's it. May not be the most important factor in this particular patient. The patient may have, frankly, a pneumonia, which may be better identified by either radiography or point-of-care tests. We do a lot of ultrasonography to try and identify the site. It is extremely important to draw that and also to realize that before you initiate any antibiotic, giving a blood culture is going to be necessary. But there are a lot of people who get confused, who like to believe that the blood culture alone is adequate. I would argue that it is not adequate. Okay? You have to look very hard for a source of an infection additionally. There are lots of people who say, okay, I can't do all of this. Can I use some kind of a biomarker? And one of the favorite biomarkers everybody uses is procalcitonin, which I tell you is frankly a useless one. It's a lazy solution. Okay, it's got no performance in terms of predicting whether you have an infection or a non-infective etiology. It is a good marker of the extent of inflammation and the resolution of inflammation, but it is not a very good marker to identify what kind of infection it is. So this is very essential. So for us to call a patient as being septic, we need to look at both of these parameters and look at it very clearly. So once you have come to that kind of a diagnosis of sepsis, there is been a process by which the initial resuscitation of the patient was performed in what was called bundles. The belief was if you achieve these bundles, your outcomes are going to be better, but it is not necessarily very valid. Okay? But we do understand that the components of the bundles have a significant relevance, and probably the more we follow these components, it would be worthwhile. So it has been rechanged and said, this won't be bundles. We are not going to compel you to perform all these actions simultaneously, but we would expect that you would use this as a standard operating procedure to make a difference in outcome, and that seems to be reasonably correct. Okay, so with that, I will just approach, I have 2 minutes, and I will approach the three or four major components of these bundles with 3 minutes extra time, maybe 5 minutes extra time, I don't know. Umal missed her flight. Okay. Okay, the first component is once a patient has been identified as being septic, the traditional argument was you have to give this patient volume. The argument is very simple. It's a vasodilated state. There can be peripheral venous pooling, and there can be capillary leak, which will create a hypovolemic state in many of these patients. And there is a reason for you to give them aggressive fluid resuscitation. And the recommendation used to be 30 ml per kg, which for an average person over here is anywhere between 1.5 to 2 liters of fluid that we need to give. Okay? And that seemed a little too aggressive within the first 3 hours. Okay? because it is not based on any hard data, and even today it is not based on any hard data. Any of the clinical trials that are restrictive in terms of the fluid still give the 1.5 liters of fluid before when the patient is found septic. So, whoops, I'm sorry. Why does it not work? Okay, because there is a lot of data. There's a large New York City database which showed that whether you give this in the first hour, whether you give it in the 12th hour, it doesn't make any kind of a difference in outcome. There is also concerns that when you bolus fluids, you're vasodilating patients. Already a septic patient can become a lot worse when you give them the fluids than a bolus. And there is at least one African trial, which they will always dismiss as being a little atypical, which clearly showed that when you use fluid boluses in this kind of an aggressive way, you increase your mortality rather than reduce it in any way. So today, we are much more careful about this volume loading, and we try to use additional parameters, the most typical of which will be the lactate. Okay, the lactate, as you can understand, is not a very specific indicator of sepsis, but it's a reasonable indicator of overall the existence of sepsis. And this, unfortunately, is based on a very simplistic idea. Why is the patient producing lactate? Because they have a tissue oxygen extraction problem. So the Krebs cycle doesn't work in that kind of, because in that environment where there is no oxygen extractable. And as a consequence, pyruvate builds up from the glycolytic pathways, and that goes into becoming lactate. The belief is this is a marker of anaerobic metabolism, and that if you resuscitated these patients aggressively, they will improve. Yes, lactate is a good marker of the severity of illness. It's a good marker of the progression. If the patient's lactate comes down, that the patient is getting better. But is it genuinely a treatable marker where you can titrate your fluid based on that? At least one randomized controlled trial exists, and it says, they themselves say that this observation may actually argue against lactate as a target. What they saw was the change in lactate, whether you do a resuscitation or whether you don't do it, seems exactly the same. So it doesn't seem to make a difference in terms of what you're achieving in that. Oh, I got 0 minutes. All right. Okay. From now on, like in the example, this evidence will not be counted, okay, from me. Anyway, so the reason why that is illogical is this is the way in which we believe the lactate was developing, but what is happening in sepsis is it's a hypermetabolic process in which the acceleration of the glycolytic pathways results in what you would consider a log jam. Anybody who's driven on our roads will know how you'll have 16 rows of traffic which will not move, primarily because 2 lanes ahead is all you have in terms of the space. And this is what is happening. And here, what you see is, it is a marker of the severity of sepsis, and if the sepsis gets better, the lactate will come down. It is not something that is potentially reversible by resuscitation in any way. So we don't use that. So we go on to something far more simple, and this was referred to a little earlier. At least one randomized controlled trial shows you that if you titrated the fluid, or for that matter, the support of the hemodynamics with the capillary refill, it makes a big difference. I disagree with the Vivek's demonstration this morning, where he just said, pinch the finger. It's standardized. Okay, you use a glass slide, press it for 10 seconds with the glass slide, remove it. Ideally, you have some kind of a timer. Even your watch will do pretty well, and demonstrate that it is taking longer than 3 seconds. Then you have a concern about an underperfusion, and you'll be more liberal with your fluid. You can also look to see if there are factors that will identify patients who will not respond. Classically, if somebody comes to you with heart RAS, you're not going to give them fluid for that purpose in any way. And you can clearly see that there are identifiable factors that you can use. So we are a little bit less liberal than we used to be for the volume replacement. The other thing that we need to talk about is the obtaining the blood cultures. I don't have the time to go through the sequence, but ultimately we need to understand that drawing blood cultures are not a substitute for a careful search of the focus of infection. Okay, and this is important. It has to be done as a second step. The third thing that we talk about is the use of what we call empirical antibiotics. Okay, thank you. Can I stop, or shall I just go for a 2 more minute period? Okay, it's up to you. Okay, okay, thank you. Again, my wife would say I'm bullying people, but I am. Okay. Anyway, the next most important thing is the administration of antibiotics. And here, I think there is a famous man called Anand Kumar from the university. At that time, it was the University of Chicago, ultimately somewhere in Canada. who did this very classic study that showed that in a patient who's presenting to you with septic shock, every hour of delay increases your probability of dying by about 12% or so. Okay, so that is basically what he said, that you need to go ahead and aggressively treat these patients early. But there is a very serious problem about identifying infection early. So let's assume that he is right and that you're able to treat the patient early. Okay, some of them will have an infection. You like to believe that your clinical diagnosis will be very good, and most of these patients will have a good outcome. Very few will not have an infection, and very few will probably develop any problems with colonization. The benefit will be favorable. But this is not what we see in most of our patients, that high diagnostic certainty and low antibiotic resistance don't occur. If you have a low diagnostic certainty, when you see something that is septic and you're not sure it's an infection, it's likely that you'll have more people going in the wrong arm of the site. And then when you treat them with an antibiotic, while they may show some response, because the resistance exists, most of them will show you a non-response. And when you give early antibiotic under these conditions, you're likely to create more adverse outcomes than any benefit at all. And this is the reasoning that we have, that if you can wait long enough, can use more appropriate techniques, and it takes a little bit of time, we can always wait, rather than do that 1 hour as a recommendation. The current recommendation says, if you are absolutely certain of the infection and the patient is shocky, give them within 1 hour. If you have any doubts about the infection, the patient is not shocky, there is a way in which you can delay it and treat them as soon as you made your recognition appropriate, and that will be the most important thing about the antibiotic timing. I will not go into my blood pressure goals. There are vasopressors that are recommended. The typical vasopressors that we will use will be norepinephrine. And there are many other issues that are also present, which I said I may not have the time to talk about. But I hope that I have emphasized that the early recognition is what is relevant. Yes, I'll leave this over there. Okay, early recognition is relevant. Number one, inflammatory parameters combined with organ system dysfunction parameters are the way in which you do that recognition. We'll never be very certain. Even then, we need to hunt for a specific site of infection and treat it reasonably appropriately. The initial resuscitation with large volumes of fluid are probably totally inappropriate. Thank you very much, and I'm sorry that I gave you 3 beeps, bap, bap, and bap. Okay, bye.
Thank you so much, Dr. Ram Rajgopalan, sir. So it was yet again another brilliant presentation from you, emphasizing on the finer nuances in the diagnosis and management of sepsis. Thank you very much, sir. So we move on to the next presentation.
Next presentation is tropical illness in pregnancy. Speaker is Dr. P. Senthur Nambi, who happens to be one of the teachers from Apollo Infectious Diseases Department. We as students admire him for his perfect blend of knowledge and practicality in approaching each and every case. And he's also known for crisp talks with a lot of pictures and memes. Hoping for a blasting talk yet again, sir.
Very good afternoon. Thanks for having me here, Dr. Sivakumar. Post-lunch session, audience is kind of dull. Even the speaker is dull. I also had a good lunch. Topic is tropical infections in pregnancy. It's a huge topic. It's 17-18 minutes. What we need to understand is no patient with fever comes with a diagnosis of malaria, dengue written in his forehead. So the assessment of fever is not blood test. The assessment of fever is good clinical history taking, examination, and then go for testing. So history, exam, and testing, that should be the focus. Many times it's testing, then comes the history. It doesn't work out that way. So based upon the history, you can have an idea whether you're dealing with a differentiated febrile syndrome or an undifferentiated fever. With differentiated febrile syndrome, you're very clear where is the focus of infection based on history and clinical examination. Most of the tropical infections, you're not able to localize the source of infection to one particular organ system. So they have fever, headache, body pain, cough, abdominal pain, joint pain, everything is there with all the tropical infections. So when you have an undifferentiated fever where you are not able to localize the focus of infection, then on clinical exam, you need to focus on certain things like looking for a rash, purpura, eschar, and a hepatosplenomegaly. These are focused clinical exams that you need to do when you are dealing with an undifferentiated fever. By day 2, day 3, when you do not know what is the cause for fever and your patient is not getting better, then you go for the testing. Till then, you'll have to do rest, hydration, paracetamol. You can do a complete blood count, malarial smears, dengue NS1 antigen. And when the fever is not settling by day 3, day 4, then you go for blood cultures, minimum 2 aerobic bottles, 20 ml, liver function test. A common practice error people do is they resort to doing serologies up to day 5 of illness, doing a dengue IgM, scrub typhus serology, leptospirosis serology. The initial 5 days of fever has got no meaning because serologies are expected to be positive after day 5. So don't do serologies up to day 5 of illness. That's a common practice error most of us do. This is a typical dengue rash, full-flown dengue rash, where you have the isles of white in the sea of red. You have the background red and then you have the isles of white. And this is, in India, if you see this, the diagnosis is dengue without any doubt. Dengue fever without complications. And it's worthwhile to search for an eschar, especially in hidden areas of the body. It could be the breast, genital areas. And if you find an eschar in an undifferentiated fever in India, then the diagnosis is scrub typhus. So don't hesitate to examine the patient in detail. It is much more worthwhile rather than spending on investigations. The complete blood count is the gateway for all your undifferentiated fever syndromes. Doing a complete blood count at a standard lab is very, very crucial. With dengue, malaria, and typhoid, you would always have a white cell count that is normal. There is no business for enteric fever and typhoid and dengue and malaria to have high white cell count. With leptospirosis and scrub typhus, generally the counts are on the higher side with more of neutrophil predominant. More is said about this eosinophil count of 0 or 1 with enteric fever. All I would like to reiterate is all patients with enteric fever will have eosinopenia, but not all patients with eosinopenia will have enteric fever. So keep that in mind. So when a patient has fever, 5 days, no localization, count is normal, eosinopenia, then your clinical diagnosis is enteric fever. The drop in platelets all happens during complications. Many a times I hear physicians saying that, sir, the platelets is normal, it's not dengue. No. 80% of your dengue patients will have normal platelets. Platelets will drop only in 20 to 20% of the patients. A normal platelet does not roll out dengue. So dengue platelets will drop only in a significant minority, 10 to 20% of the patients. So with complicated malaria, leptospirochronic typhus, your platelets can drop. The hemoglobin, yes, it is of use, especially in patients with dengue, where you're looking at hematocrit, where the common man's focus is only on the platelet. But in a patient with dengue, the hematocrit has got much more value than the platelet. So going on to the individual diseases, once we have had an approach to what we are dealing with, if you think that Tamil Nadu is an area where you have a lot of malaria, definitely not. Tamil Nadu is one state with the lowest malaria prevalence in the country. And if we are practicing empiric antimalarials, that's not the right practice. All clinical suspected cases of malaria has to be proven either by smears or rapid diagnostic tests. No role for empiric antimalarials in this day and age, at least in Tamil Nadu. So what test do I do to make a diagnosis of malaria? If you do not have access to a good microscopist who can look under the microscope and tell what the species or is there a malaria or not, then we can resort to these rapid diagnostic tests. These are tests, card-based tests, which are useful. Their sensitivity and specificity is good, but don't resort to them as a routine in a tertiary care practice. They have their own little pitfalls. It can remain positive, false positive for 1 month, even after the infection is there. The traditional smear examination is very, very useful for the diagnosis of malaria. Thick film, you have multiple sheets of RBCs. It helps in picking up the parasite, whereas in the thin film where you have the one sheet of RBC, helps in identifying the characteristic of the parasite. So you can name the species by the thin film. If you strongly suspect malaria, but your smears are negative twice or thrice, then your patient does not have malaria, even if they have fever, spleen, and chills. It's not malaria, something else. Malaria in pregnancy, it is not good for the mother, it is not good for the baby. The outcomes are bad, more so in the second trimester and third trimester. Most of the information that I have projected is from the African nations. Fortunately, in India, we do not have a significant burden of malaria in pregnant individuals, except for the state of Odisha and Chhattisgarh. What drugs do I use? First trimester, that is a period where you're a little wary about using the antimalarials. If it is Vivax, chloroquine is the drug of choice, with falciparum, quinine plus clindamycin. Artemisinin-based combination therapy, the data is not that strong for use in first trimester, but nevertheless, if you have a sick patient, where artesunate, which is the most rapidly acting anti-malarial drugs, is going to save the life, then use artemisinin-based combination therapy in first trimester. Whereas with second trimester, third trimester, with Vivax, again, chloroquine is more than enough. With complicated falciparum malaria, you can use artemisinin-based combination therapy. Lactation, in general, no problem. Primaquine, to strongly avoid in pregnancy, and so would be tetracyclines like doxycycline. So with severe falciparum malaria, the drug of choice is artesunate, 2.4 milligram per kilogram, 0, 12 hours, 24 hours, then once daily for 5 to 7 days. The add-on drug would not be doxycycline, it would be clindamycin along with artesunate. Minimum duration of 24 hours IV, and then you can follow it up with artemethyl lumefantrine or artesunate plus clindamycin. That would be the treatment for falciparum malaria. Going on to typhoid, India is the typhoid capital of the world, so would be the other Southeast Asian countries. India is there in the red zone, and if we are in the practice of using a test called Vidal for making a diagnosis of enteric fever, then it's not the right approach. And none of the modern textbooks of medicine in the last 20 years mention Vidal as a test in the diagnosis of typhoid. The last line, the Vidal test can be dangerously misleading and should no longer be used in clinical practice. This was from World Health Organization, Good Clinical Diagnostic Practice Guidelines. It came way back 15 years ago. So if you are in the practice of using Vidal to make a diagnosis of enteric fever, then time to stop it. So how do I make, again, history? Clinical examination, undifferentiated fever, normal white cell, fever not settling by day 4, day 5. Then you do blood cultures, good volume blood cultures. It picks up 2/3 of cases. Bone marrow cultures, very good, but not practical. So you and I would not do bone marrow cultures. Normal white cell count, eosinopenia, habit of taking food outside contaminated water. Then you make a clinical diagnosis of enteric fever when your cultures are negative. And then what do you use for treatment? Quinolones no longer. The drug of choice for typhoid is ceftriaxone. Oral equivalent will be cefixime. Other agents like amoxicillin, cotrimoxazole, ampicillin, they all work very well for typhoid, the older drugs. The current strain of typhoid, what we have in the country is fluoroquinolone resistant. The earlier multi-drug resistant strain of typhoid is no longer there in India. So amoxicillin, cotrimoxazole, azithromycin, chloramphenicol, all works very well for typhoid. Dengue, again, India is the #1 dengue capital of world, closely followed by Brazil. In the last decade, malaria incidents have come down, dengue incidents have gone up. There is change in species. Aedes is the commonest species that we have right now. Dengue is a fascinating disease. The initial 3-4 days, it kind of behaves different. Day 5, day 6, day 7, it behaves different. After that, it behaves different. In the initial 3-4 days, there's a high-grade fever with prostration. You look in control of fever with paracetamol, hydrate your patient, oral or IV. By day 4, day 5, when the fever settles and the patient begins to think I'm getting better, that is when the platelets can drop. Don't go behind only the platelets. Look into the hematocrit. The hematocrit goes high in a patient with dengue, then there is not enough hydration. The hematocrit is the key, much more than the platelet. The drop in platelet has got little relevance to the consequence of bleeding, dengue shock syndrome, all those things. Once you go through the finish of the critical phase, then you go to the third phase, that is the recovery phase. That is a period where the fluid extravasation, now it gets reabsorbed. In this phase, we should not be vigorously giving IV hydration. We should be focusing on oral hydration. What test do I do to make a diagnosis of dengue in the initial 5 days? All we have is NS1 antigen. By day 5, day 6, day 7, the IgM antibody is expected to be positive. So the strategy that we employ in those 3 different phases are different, and the tests that we do in those 3 different phases are different to make a diagnosis of dengue. The key here is between day 4 to day 6 in patients with dengue. Dengue in pregnancy is a big problem. Because assessment of a dengue patient itself is a problem because of physiological hemodilution that happens in pregnancy, higher heart rate, lower blood pressure, pulse pressure changes, all those things kind of makes a problem to pick up a difficult dengue. So the Tamil Nadu government guidelines is quite clear. Any pregnant women with suspected dengue or proven dengue should get hospitalized. It's straight, don't try managing as outpatient. That's the Tamil Nadu government guidelines. Dengue death in pregnancy will have collectors inquiry in Tamil Nadu, so we need to be very, very careful. If you do not admit, then there will be a first question is why you didn't choose to admit. And severe dengue can always be confused with HELP syndrome. Admit them, measure their vital signs, measure the urine output. That's the best thing that you can do, hydrate, oral or IV. So the key here of dengue is no antivirals, hydration, oral or IV, avoid intramuscular injections, avoid NSAIDs, avoid aspirin, normal saline ringer lactate is good. You don't transfuse unless you don't have bleeding. If the platelet is less than 10,000, then you can transfuse. Otherwise, there is no role for prophylactic transfusions in dengue, no role for this dexamethasone in the management of dengue. So don't do all those things. All these things are proved to be harmful in the management of dengue. So what does it do to the mother? Premature labor, premature birth, and then you can have retroplacental bleed, hemorrhage, all those things. To the fetus, intrauterine death, prematurity, late miscarriage, fetal distress, maternal fetal transmission. So it's a kind of a bad disease both for the mother as well as the baby. We need to be very careful when you're managing dengue in pregnancy. So when you have a pregnant lady with dengue, during the critical phase, avoid doing any kind of intervention. If you can prolong that phase, that is what you and I should aim for. Avoid LSCS, avoid episiotomy, avoid induction of labor. Use ultrasound to quantify third space fluid accumulation or pleural effusion ascites, because with the gravid uterus, examining for ascites becomes very, very difficult. So you have to use ultrasounds. With peripartum dengue, prolong or avoid delivery by a week if possible. Don't transfuse unless there is bleeding or if the platelet is less than 10,000. Don't think of infusing only platelets. You'll have to use other blood products like Paxil or FFP also. All these things become equally important, and I think that obstetricians should should involve physicians, intensivists or infectious disease physicians whenever they manage dengue patients in pregnancy. Going on to leptospirosis, very interesting disease, zoonotic disease transmitted by rat urine contact with contaminated water. And in the majority, it is self-limiting. 80% leptospirosis, your immune system, my immune system will clear the leptospira on its own. In 20%, it can go in for problems in which 5% they can go on to the wheel syndrome, where the liver, kidney, the heart, it could be the brain, it could be the lungs that could get affected, but that's only in 5%. 80% lepto can get better on its own without getting treatment. The problem is with respect to leptospirosis, making a diagnosis of leptospirosis, it is very difficult. The test, the gold standard test, the microscopic agglutination test, the initial 2 weeks, it's not positive, and then you need to demonstrate seroconversion, or you need to have a single titer more than 1 in 400. So this is a test that is not useful in the initial 2 weeks of illness. You may resort to IgM antibodies by ELISA method, which is usually positive after day 5, day 6. Very good on paper, but on practice, what I have seen is 20 to 30% of the times, it can be false positive. So don't go by that. If you suspect leptospirosis, then it is better to treat rather than to wait for the test to prove it is leptospirosis. Doxycycline is a very useful drug, but we cannot use in pregnant individuals. So all drugs like amoxicillin, ampicillin, azithromycin is good enough. If the patient is sick, requiring hospitalization, the tradition is to use crystalline penicillin, but it is cumbersome to procure. You need to give almost 6 times a day. Ceftriaxone once or twice daily is as good as crystalline penicillin in the management of leptospirosis. But don't wait for the test to say that your patient has got leptospirosis. If you suspect, treat with ceftriaxone, amoxicillin, ampicillin. The last disease, scrub typhus, it is something that is kind of more happening in the last 10 years. Probably it was there earlier. We were not aware. The entire India and Southeast Asia, south of Himalayas, is actually endemic for scrub typhus. The causative agent is Orientia tsutsugamushi, and it is because of the bite of the trombiculid mite, which typically lives in burrows under the soil, where the rain kind of brings the mite out of the burrow. As a result, there is the mite contact. The mite which harbors the Orientia transfers that into the human host, and then we develop the disease. The earlier thought process with respect to scrub typhus was it is a kind of a village disease, agrarian disease. But this is our data to say that, I'm not sure why it is running fast. So this is our data to say that leptospirosis is not only an agrarian disease, it is an urban disease too. This is the data from Chennai. So we had around 240 patients in which 80% of our patients came from Chennai. They didn't go to villages to pick scrub typhus. All they had was they were living in independent houses, or they used to go for parks for their evening walk or morning walk, and that was good enough. And most of the leptospirosis cases that we used to see came after the rains. That was after July, August, September, October, November. We never saw leptospirosis in the hot summer month in Chennai, and that's the data that we have. So it is very important to look into these epidemiology. Post rains, think of dengue, malaria, scrub typhus. Summer season, enteric fever is much more common. So how do I make a diagnosis of leptospirosis? The test IgM ELISA is good. The PCR test is available only in research labs. As I told for leptospirosis, for scrub typhus, don't wait for the test to make the diagnosis. If you suspect, use doxycycline. In a non-pregnant individual, if you use doxy, it would take care of both your lepto and scrub. But in a pregnant individual, you cannot use doxycycline. Azithromycin works very well as a single agent. For enteric fever, it works for leptospirosis, it works for scrub typhus well. So it's a very useful agent to use in a pregnant individual. These are data with respect to undifferentiated fever. Looking into the top 5 causes for undifferentiated fever in our practice, the number 1 cause for undifferentiated fever was dengue, followed by enteric fever. Third one was malaria. Fourth one was scrub typhus. These were the top 4 causes in our practice. So it is dengue followed by enteric fever, malaria, and scrub typhus. And then we did have some leptospirosis that is down the list there. And again, as I pointed out, there is a striking seasonal variation. Dengue is found throughout the year, all 12 months in entire Tamil Nadu, but you would follow an increased spike after the rains. Scrub typhus typically follows the rains. Enteric fever more common in the summer season. Malaria more common in the rain season. So you need to look into these climatic patterns, weather patterns, whenever you're looking into these tropical infections. It's very important to keep these things in mind before you think of an appropriate, what could be the cause for the fever. Fever greater than 3 days, you're unable to localize, then you're dealing with an undifferentiated fever. You would always rule out dengue and malaria by doing a blood test because you cannot rule it out clinically. And if dengue is positive, manage accordingly. Malaria is positive, manage accordingly. Day 3, day 4, dengue, malaria ruled out, but you do not know what is the cause for fever. Then you're thinking of enteric fever, leptospirosis, scrub typhus. So you would investigate for it, but don't wait for the test to prove your diagnosis. You would start your patient on amoxicillin or azithromycin. Amoxicillin will take care of your leptospirosis and enteric fever, but it will not take care of your scrub typhus. If you use azithromycin as a single drug, it will take care of your enteric fever, lepto, and typhus. In a hospitalized patient, use ceftriaxone plus azithromycin. That is all enough. You don't need any complicated stuff. Just ceftriaxone plus azithromycin for all your undifferentiated fever. And that's my last slide. And I strongly believe that, I know that this is an age where you've got all those kind of advancements, knowledge, diagnostics, but I believe that you need to spend time with your patient, get the history, do the clinical examination, then come to the testing. Then you apply your common sense. Testing, if you're going to put in the reverse algorithm, day 1 fever, do these tests and come, you're not going to get to the diagnosis. Thank you.
Thank you very much, Dr. Sendur Nambi sir, for your very informative talk with valid take-home points. So we move on to the question and answer sessions. So may I call upon Dr. Ram Rajgopalan sir to the stage again. Due to time constraints, could we restrict to just 2 questions per speaker, please?
We can use it provided you have access to it. I'm just looking at traditional methods, thick smear, thin smear. That is something it is well evidenced. You can do a QBC method to pick up the parasite. Even research labs have PCRs also. And in a field test where you don't have access to a good microscopist, then you can go for card-based test. If you have access to an ELISA method by immunochromatography, that is good enough, not a problem at all. Welcome to do that, sir.
There are no more questions. I request Dr. Ram sir to.
Question to Dr. Ram. what are the early signs of sepsis? The patient comes in. How do I find that she's in sepsis or she's getting into sepsis? You told us about the infection and sepsis, but the sepsis is the one where we have lost patients just because we were not.
I thought I spent the initial part of my talk trying to say that. Let me just clarify this. Identifying sepsis, there is no gold standard by which you say, do this test and I'll identify it. It is looking at a series of inflammatory parameters and organ system dysfunction that will occur over a period of time. And that is what we are trying to clearly emphasize. And if you see this in the initial phases, even if you don't identify it immediately, if you see any parameter of inflammation or any sign of organ dysfunction that is not otherwise explainable, is progressively worsening, it should be something that triggers off a process of looking at the patient closely enough. The point over here is attempting to identify as many patients as soon as is possible. And that involves a sequential observation. Uma was also talking about this mu score. She has it on her wall again, and they have that red and yellow and marks for the nurses to look at so that they can judge whenever the patient is progressing. They can accelerate the care and say, doctor, you need to see this. Or the doctor says, doctor, we need to move the patient out to a ICU. So that kind of a sequence is what we need to clearly see. It becomes very obvious when a patient is hypotensive, shutting off kidneys, not waking up and all of that. That is an extreme. You want to catch it long before that. Okay, and the only solution to that is a lot of continuous surveillance under these conditions. Okay, so that will be the way.
I request Dr. Ram sir to felicitate our moderators. Dr. Naveen. Dr. Premalata. I request Dr. Naveen to felicitate Dr. Sendur Nambi. Next session, we have a case scenario based learning session by Dr. Uma. I request Dr. Uma ma'am to come to the stage, please. Ma'am, she is the director and head consultant in obstetrics and gynecology in Sitapati Clinic and Hospital and E.V. Kalyani Medical Center in Chennai. Ma'am, special area of interest?
That's fine, no problem. Thank you very much. Okay, we've had, I think, nearly 2 days of a lot of learning, a lot of practical discussions around events where the pregnant woman can get extremely sick and where we can lose her. So what Dr. Sivakumar asked me to do is a little bit of focus on how to minimize medico-legal issues in obstetric critical care. So I'll do a short presentation and then we'll take 2 or 3 cases when I will request Ram to come up and help just to see, because sometimes how the obstetrician counsels the patient and how the obstetrician may convey information can be very different from how the intensive care team looks at the problem or counsels the patient. And so we thought that may be a good way of doing it. Why are we even talking medico-legal? Now, in 2022, the annual incidence rate of medico-legal cases was about 5.2 million cases, and this is in India. So clearly, it's something that has come to stay with us. And if you look at data, and the data, this is from a publication that is more than 10 years ago, but the fact remains the same, that the specialty with the highest number of litigations is obstetrics and gynecology. It was 28.2% in 2016, and it may be higher now. The next specialty that gets sued most is orthopedics. So as OBGYNs, we have this unique privilege of taking care of 2 lives, but also, a hard place to be in because we are more likely to be sued. But what is reassuring though is only a third of these number of cases was negligence proved or settled out of court. So more than 60%, it was in the favor of the medical team, but still for anybody who goes through it, it's a very traumatic period. In the US, 76.5% of American college fellows say that they were sued at least once, and a quarter of them have been sued at least 4 times. So it's a universal thing that OBGYNs are more likely to be sued, and 58% of obstetricians report making changes to their practice as a result of the fear of litigation or the high cost of liability insurance. And this is why our practice becomes more and more defensive, and is probably also one of the reasons why our cesarean section rates, etc., are also increasing. So why is obstetrics so vulnerable as a specialty? Probably because the birth of a child is a life event. It's not medical treatment. People are coming in expecting happiness in anticipation of joy. When you have a sick patient going in for liver transplant surgery, or somebody who has an MI going into an ICU, there is anticipation of adverse outcome. Whereas when you book for obstetric care, there isn't anticipation of adverse outcome, and I think that is the biggest challenge. It's an emotional moment, it is an anticipated family moment, and I think we also project the fact that we can give fantastic outcomes. We hardly ever tell people who even have risk factors that you have a risk of becoming seriously ill. Imagine you have a patient who books with us with a BMI of 42, is a chronic hypertensive and diabetic, and she says, am I going to have a healthy pregnancy? We tend to list the complications, but we don't tell her you could die. Correct? So that is where most of the problem is, and people are expecting perfect outcomes, the absolutely perfect baby. Social media doesn't help. Today, pregnancy is all about motherhood shoots, having your pictures on social media, planning how you are going to be photographed with your baby after you're born. They don't expect that you will be given 10 units of blood, taken into ICU, spend 10 days in the hospital, and then go home. So this is the social background. The clinical background is when you have a sick mom, there are multiple teams looking after. There is an obstetrician, there is an anesthetist, there is a neonatologist, there is a physician, there's an intensivist. And when an adverse outcome happens in obstetrics, it happens abruptly. Very rarely is there a lead time. And so we become task focused, as we did with all the discussions. We are going to give IV fluids, we are going to check tests, we are going to give blood, we are going to do our procedures. Very rarely do we have time, therefore, to talk to a family which is already unprepared for an adverse outcome, and so communication with family gets affected. And I don't know how many of you have read the book called Blink, where they give you 10-second snaps of conversations between a physician and the family, and ask you to pick which of those conversations is there likelihood of a person being sued. And people are able to make that fairly accurate call by just viewing a 10-second clip. Because it's your body language, it's how you are, how stressed you are when you're having that conversation. And I think that is probably the main reason why we are not able to communicate effectively. What are the main factors that result in litigation being settled against the doctor? Incomplete consents, failure to detect hemorrhage or organ injury, undue delay in shifting. And this is a very common factor, especially if you are not in a large multi-specialty hospital, which is where a large percentage of obstetric care is being delivered. You don't know whether you have to put the family through the trouble, or you think that this patient may actually get better, do I really have to shift her, So that can happen. No proper facilities, which would include blood bank, include an ambulance, failure to diagnose an anomaly and change in the sex of the baby, which are not relevant to today's conversation. So how can we minimize these litigations and how should we respond? Mainly by prioritizing patient safety. And how do we do this? By using checklists, by huddles, which we see so often on the playing field, but not that often in our hospitals, and by debriefing sessions. Now, checklists are something that have come to stay with us. We have the WHO safety checklist for surgery, we have the safety checklist for maternity, and we have the childbirth checklist. And it has all these pause points where we need to double check that everything is available. However, we all know that checklists are only as good as the implementation. How many times in theater are the checklists signed after the patient is wheeled out? All of us know that that's how it's done in many places. So it defeats its purpose if it's not done well. It depends on the team dynamics. If the anesthetist is doing something else when the circulating nurse is asking him, "Sir, is the pulse oximeter working? Do you have any safety concerns about this patient?" And he just hushes her and she keeps quiet, then the purpose of the checklist is lost. So the checklist reader. Huddles, as we have all seen on the cricket field, they're short, focused. What do? They bring our attention to situational awareness. They help us identify what is going on, assess and reinforce. And ideally, once a shift, it needs to be done, or as often as it is needed. Protocols and drills, because technique and technical failure is also something that can happen, and that's why the drills that happened yesterday are very important. But it's not enough for one person, the doctor or the anesthetist, the obstetrician or the anesthetist alone, to know what to do. It's important that as a team, people are trained. So all staff should be trained. And as was mentioned in the morning, Ram said you may have one arrest in a year or one arrest in 2 years. Unless you refresh yourself periodically, you're not going to know how to do it. And also with drugs, we have to check labels, we have to check expiry, and all of this has to happen. The best example of teamwork is when the F1 car pulls into the pit stop. And all of you know how quickly, how meticulously these tasks are done. Which means, as you can see here, there is a person designated for everything. A front jack changer, there's a backup for the front jack, there's a right wing adjuster, left wing adjuster. So everybody has an assigned role. They know exactly what they have to do, and within that less than 1 minute, those tasks are done. We need to get to be that good when we are dealing with a collapsed pregnant patient, and very often we are not. And time is at essence, and that's what we lose. Documentation then becomes the next most important reason why medico-legally we get at a disadvantage. We have to document clearly, cohesively. We can document after the fact, because when it is going on, we are doing the task. But somebody needs to mark time, because we can't make up the time. Today, often there's a husband or a attender inside the laboring patient. All they have to do is click the clock with their phone. There is no way you can get it changed after that. So it can be written after the event, but it has to be written synchronously. What you write must be the same as what the anesthetist writes, must be the same as what the neonatologist writes, so that there is coherence and synchrony. Very clear transfer notes. If you're transferring a patient, especially if you're transferring to another hospital, where there may be an adverse outcome there. And please be aware that that hospital is also going to protect themselves. So it's very easy for them to say, "Oh, you came late." Correct? And then we are soup. So it's very important that you document why you're sending, what is the diagnosis. They may not know whether she had PPH or not. They don't know if it was prolonged first stage or second stage of labor. So you have to be very meticulous in what you are sending. And it's important to maintain an in-transit case sheet. So you're sending somebody with a doctor or a technician, make sure that that person documents the condition of the patient during the transport, and that is also clearly added on to your case sheet. Team debriefing becomes very important. Many times we do all of this, we then don't spend time because we're all so exhausted or just grateful that this woman is better, that we don't go over the event. We need to discuss and plan how we are going to communicate to the family, that there is no cross communication that happens. The nurse doesn't mention something that the doctor did not mention. The registrar doesn't say something different. And most important, please let us be aware that we ourselves as physicians and the other healthcare workers will need mental health support after an adverse obstetric outcome because we are most affected by it. We feel terrible that something has gone wrong with the patient, irrespective of how the public may view that this has happened because we were careless. We know that very often we are not, and we feel responsible, we feel guilty, we are questioning ourselves, and that definitely needs support. And sometimes it's very sad to hear that in some of the teaching hospitals, the registrars and the PGs are made the scapegoats for an error that has happened, even though they don't have the most expertise in the team. So we need to take care not just of ourselves, but also of our juniors. And when communicating with the family, important to give information, explain the possible causes, explain the treatment and prognosis, deal with their reaction. Be prepared for anger, be prepared for somebody breaking down, and as I said, deal with our own emotions. And that brings me to the last thought, which is error disclosure. This is something that is repeatedly told both by the RCOG and the ACOG, that unanticipated outcomes and medical error happens because we are human, and error disclosure is a significant part of patient safety. We are expected ethically to communicate that an error has happened to the patient, and this is the ACOG statement, which has since then been reaffirmed more than once, that it is the moral obligation of every physician to communicate honestly with patients, particularly those who experience an adverse outcome. Be open and be transparent, and they actually say that if you say there was an error and you communicate it, people will understand, and it actually decreases liability exposure. But I am very sure that we are all very hesitant to actually disclose error. In real life, it doesn't happen. It's easier said than done. Part of it is because of the way we think the family and the patient is not prepared. We are very scared that litigation may increase if we apologize for an error. And it is now, in the Western world at least, there are trained navigators who guide how you can communicate with the family. And I suppose the time will soon come in India where we have such people. So with this basis, shall we just maybe, I don't know, interest of time, maybe one case, Ram? So I just want to, while Ram comes onto the stage, take these two comments, that the burden of proof of negligence, carelessness, or insufficiency generally lies with the complainant and not with us. And therefore, it is for the patient to establish medical negligence. And a doctor is not liable for negligence if he or she has acted in accordance to practice accepted as proper by a reasonable body of medical professionals skilled there. So what do these two statements tell us? That our best protection is to have standard of care when we are treating, meet guidelines, meet what is standard of care, and appropriate documentation. The reason we cannot prevent adverse outcomes from happening. We cannot prevent somebody from filing a suit, but we can prevent ourselves from being found guilty by appropriately doing these two things. And store those records for the period of time, I think at least 3 years and at least 21 years for obstetric outcomes. So the first scenario, Ram, this was a primate, married 2 years, BMI of 28, otherwise low risk, admitted in early labor at 38 weeks and 6 days. As labor progressed, she opted for an epidural. The epidural was sited with some difficulty, so the anesthetist had a little bit of difficulty, pushed a bit, and then it was sited. Immediately after the local anesthetic was given, the patient collapsed and lost consciousness. CPR was initiated and the patient was intubated. Because there was return of pulse, she was shifted to the ICU with full support. 2 hours later, cesarean section was done and a live boy baby was delivered. The patient was on full support for a week, but then died. So what may have happened here, and what could we have done better, and how would we counsel this family? So what may have happened here? I mean, obviously this was an epidural related problem, and we know that anesthetic complications, I think, are a third, at least 20% of all adverse obstetric outcomes are anesthetic complications. So what could have happened here?
A lot of things that could have happened. I mean, it was before you even gave the local anesthetic.
No, the local anesthetic was given and she collapsed.
Okay, so there are a lot of reasons that you need to worry about it. Okay, if the local anesthetic was given, was it an accidental injection into the wrong side, the spinal fluid, then externally? Number two, it's unlikely. Usually you have a lot of problems when you have a difficult to place epidural, and there's a tendency to use higher and higher doses of local anesthetic, and potential for local anesthetic toxicity always exists. Okay? So I think we need to raise the concerns, because one of those is very treatable. When you have large doses of local anesthetic that is being given, theoretically you're supposed to be managing it with intralipid boluses, which we generally don't have available to us. We don't anticipate this problem as being common enough in the first place. So you can think of those as the primary concerns. It can't be a primary cardiac event. It can't be something like we always say, oh, amniotic fluid embolism will be an easy trash can diagnosis that we can put in. But ultimately, it was somebody who collapsed. And I think we need to recognize that when it did happen, was the approach to the management of the patient appropriate? And I think that's not what we need to focus on, Ilya. So is there anything specific that you want me to say besides this? I didn't practice this, so I don't even know what to ask. Okay.
No, so we in a lot of units that use epidurals quite liberally.
Yeah.
And if you have a busy obstetric unit, you may be giving at least 2 or 3 epidurals a day. I'm not aware that and even in our hospital we have intralipid available in the labor ward, right? So it should be possibly. And because if you do have local anesthetic related problems, we need to have that available.
In theory, in an ideal world, you should anticipate every kind of problem that you will have. Okay, here you can anticipate that you might need life support. Okay, you've gone ahead with that. But it's not going to be adequate enough to provide the life support if you don't have a primary antidote to a potential problem. So this is something that does occur, but I think we take all of this relatively lightly. Okay, it's because I'm not trying to suggest that you should be advising every family that every epidural that is going to be given is going to result in an adverse event. That is absolutely absurd. It doesn't happen that frequently, but you need to be protected against that, the possibility that if you thought of this as a possibility, did you have intralipid available? And that's a very serious question that we need to ask in the first place.
Because when we tell the patient this is a this is a reaction that has happened because of the epidural,
they'll say,
the first question that will come up is, you never told us this was possible. We talk about dural puncture, we talk about a spinal headache, we talk about hypotension and some cardiac CTG changes in the mum. We talk about its effect on labor. These are the commonest things that we talk about. So it becomes difficult to have this conversation, and we have to focus on what is appropriate.
Let
I
me-
mean, there
let
are
me put
other
it in
seniors in the audience.
No,
if
but
you
let me
want-
put it in perspective. Okay, we can't talk about a lethal event occurring in the normal pregnancy in the vast majority because it's a rare enough kind of an event. So if we can't talk about something that happened 1 in 700, 1 in 800 cases, so I don't think it is possible for us to advise the family, nor would it be very positive. You go around and say, oh, she's going to have an epidural. There's a 1 in 700 chance that she may die of it. It doesn't make any kind of a brilliant amount of sense. So honestly, could you have done anything differently other than you be prepared for a potential adverse effect? I think that has always been said. Okay, for instance, a classic situation would be in anaphylaxis. When you give a medication, the patient develops anaphylaxis. You are not taken to court if the patient died. You are taken to court if you did not you did not treat it or approach it appropriately. You didn't have adrenaline to give to the patient and you didn't know how to handle the anaphylaxis, then you would be taken to court. So the same principle can apply over here. So if you have a rare enough reaction, do you have the right tools to be able to take care of it? And I think that's the only way in which you can probably approach it. Should you have done anything better? I can't think of anything better that you could have done. You had a
Once
patient
the
who
problem happened.
yeah,
Once
you
the problem.
had an arrest, you had the right person to do the resuscitation, and of course, the resuscitation resulted in a return of pulse. Okay. This was how late in pregnancy? I didn't notice.
38 weeks, term.
Okay. The question of what did they do? Did they do a perimortem cesarean or anything? I mean, let's not use that word. A resuscitative hysterotomy or not. I don't know whether that becomes very valid. But the fact of the matter that you had a return of pulse, and I don't know if it's within a very short period of time, and you had a fetus that was delivered effectively, I think you've done the right thing. I don't know whether you've done anything differently in terms of managing this patient. What should we say at the time of the collapse?
So we have to come out and talk to the family when the collapse happens, isn't it, Bala?
Of complication normally.
So generally we use 1% as a rule, isn't it? We don't talk about everything. I mean, we don't talk about stillbirth when they come in and book with us either, even though there is a chance, even with the high-risk women, it's not something that we articulate. But maybe one take-home is, if you are in the practice of giving epidural analgesias, it is good practice to have patients counseled ahead of time and not when they are in pain and asking for pain relief. And if they are high-risk patients or high BMI, maybe better to have them see the anesthetist or somebody from the team earlier. Because some of them have bad backs, obese, anesthetists have difficulty at that time. So that's maybe, I mean, I'm not saying it could have prevented this, but at least some counseling could have happened.
Because we take the epidural like, oh, pali irka, kutturla epidural. Okay, that is not the kind of approach where we, particularly if you think it's a high-risk individual, like an obese individual, where it's going to be potentially difficult to place it. I think a pre-counseling will make such a dramatic difference in terms of the way in which you would approach that. Yeah.
Okay.
How do we counsel the family? This is an accident. This is an event that occurred. We have taken the right kind of approach. Now we anticipate that this is what will happen. Every cardiac arrest is not going to survive. Please understand that. Only in the movies, when you do CPR, that 5 minutes later the patient is awake and kissing the hero, and okay, it doesn't seem to happen in real life. As an approximation, 1 in 5 patients who after CPR are likely to come back to have reasonable circulation. Or maybe in an in-hospital situation, it may be a little bit better, maybe 50 or 60% under those conditions, but you do anticipate that neurological events can occur and a prolonged non-response in terms of post-resuscitation outcome can be expected. So this is not an unexpected kind of a situation when you look at it. So the way we need to do counsel is you need to explain to them this is all what we anticipate. How do you convince them? Very difficult.
Okay. Do we have time to do one more, or shall we stop? I mean, interest of time. Okay, maybe we should just wrap up. Yeah. Okay.
One more scenario.
Okay, so I'll quickly go through this one. This was a gravida 3 with 2 previous cesareans with an anterior placenta previa, no evidence of percreta. An elective section was scheduled 4 days from when she came in at 36 weeks with pain abdomen. Abruption was diagnosed, cesarean section was done. At section, there was a hemoperitoneum without any scar, rupture or dehiscence. We delivered the baby. There was about 800 to 900 grams of clot removed. Atonicity was present. Uterotonics were given. B-Lynch suture was done. She was given 2 units of PRBC and 2 of FFP. Uterus was contracted at the time of closure. No further bleeding. She was shifted to the ICU for further monitoring. In the ICU, she had another bout of bleeding and lost another about 500 ml. And she was taken to interventional radiology and embolization was done. And totally, she had 10 units of PRBC, 10 units of FFP, and 6 units of platelets given. I'm not going to get into this management. I think it was fairly appropriate. We communicated the risk to the patient when we shifted her. We said this is what had happened, and she had had this, and she should be doing fine from here on. But 12 hours later, in the ICU, she had a seizure, and when they did an MRI, there were watershed infarcts, and she was counseled that this happened possibly because during the hypotensive episodes, she has had a problem. So the family's question was, then did you not appropriately resuscitate her? Was this a complication of inappropriate resuscitation?
Okay. Honestly, the only way in which you can do that is to document that the resuscitative process was done appropriately. From what I can see, okay, clearly there was a period of hypotension even preceding the onset of this arrest. She had an arrest, right?
No arrest.
No arrest. She's the one who was severely hypotensive.
Yeah.
Okay, so that is more than sufficient. But remember, it is not very common for us to see the consequences of such severe hypotension on everybody. Kidney function can go for a lot of people, there's no question, over a period of time, but usually they recover. But for you to see something as clear as a watershed infarct, that means your blood flow was sufficiently low that it created a neurological change, is not something that you could anticipate. So the only way in which you can talk to them is to say, this is extremely unusual for something like this to occur. We recognize that the blood pressure was dropping. We did what is appropriate in terms of managing. You have the documentation that was done appropriately. That's all you can have as your defense. There's no way you can give a reasoning to the family and say, oh, that's what we did, and we think we are perfect. No, they will say, where is the evidence that you are perfect? The only way we can show that evidence is probably by showing the documentation of how the process went by. I think that becomes very reasonably obvious.
So intrapartum, in theater and outside, what was the trend of blood pressure? When was fluid given? That degree of detail needs to be documented. And sometimes we don't always have that as a clear documentation. So I think it is, it's important that we have recognized that an adverse incident has happened. And when we have an adverse incident, we sit around as a team and make sure that our documentation is perfect. We anticipate what are the possible problems that can come up if there is questioning or a medico-legal situation, and therefore ensure that the case sheet then and there is documented appropriately. Very important that we continue to go. Sometimes, especially if we have shifted patients to another bigger hospital ICU, sometimes the obstetricians don't go and see the patient there. I think it's important that you continue that, have that channel of communication with the family, maintain continuity, and work as a team, and hopefully that will get us through these things. Thank you very much. Thank you, Ram.
Can I give credit for that photograph? Is Dr. Umaram. I carried the camera for her. Okay.
Thank you, ma'am.
Thank you.
That was one of a kind, interesting and need of the hour session. It was thought-provoking to everyone. Now let's have a short tea break. I request all the delegates to kindly reassemble in 10 minutes so that we'll have the last exciting session. Thank you. Dr. M. Hariharan, Consultant, Department of Critical Care Medicine, Kovai Medical Center and Hospitals, Coimbatore, and Dr. M. Aruloli, Consultant Intensivist and ICU in charge, PSG Institute of Medical Sciences and Research, Coimbatore. Over to you, sir.
Good evening, all. We're coming to the final session of this wonderful CME. I request Dr. Sumana Manohar ma'am, who finished her MBBS in Sri Venkateswara Institute of Medical Sciences, Tirupati, an FRCOG and MRCOG. Currently, she is a senior consultant, reproductive medicine, infertility specialist, and obstetrician in Apollo Women's Hospital, Chennai. Her special areas of interest are high-risk obstetrics, endoscopy, and reproductive medicine. So I call upon her for giving a talk about liver disease in pregnancy.
Thank you. Thank you. At the outset, I'd like to thank Dr. Sivakumar and RCH team for inviting me for this gathering. So basically, the topic which is given to me is liver disease in pregnancy. As it has been told from the morning that the liver physiology can be changed with the pregnancy, and the liver disease in pregnancy can be detrimental to the fetus and the mother depending upon what they have. It can be pregnancy-related ones and pregnancy-unrelated ones. So almost 3 to 5% of the pregnancies can be affected with the liver disease, and it can be, as I said, it could be pregnancy-related or unrelated. It can be fatal to the mother and the fetus, and it's very important that the underlying cause is identified and prompt treatment is very crucial. So when we look at the physiology, which is again already touched upon by the first speaker of the day, so transaminases, bilirubin, and gamma GT can be same as in non-pregnancy, but we have to know for the fact that the upper limit is 20% lower than the non-pregnant woman. So it's little rise also, we have to vary about the transaminases, bilirubin, and the gamma GT, and the rest, as you know, alkaline phosphatase can go up because of the placental contribution. So today, I'm just going to touch on the few things which liver disease is related to pregnancy, like hyperemesis gravidarum, intrahepatic cholecystasis of pregnancy, acute fatty liver, preeclampsia and eclampsia, and HELP syndrome. I'll confine myself to these topics because these are the ones which can be detrimental if you do not take the management on board properly. As we know, hyperemesis gravidarum is experienced by almost like 85% of the women, and it can start off at as early as 4 weeks, and it can go up to 20 weeks. And young, obese, lean patients are more prone, and multiple pregnancies have a higher risk of having this. And the clinical assessment is being done by HELP and PUGE scores, where they will tell the patient to tell how many times you had the vomiting, nausea or vomiting in the last 24 hours, and if the score is more than 15, because they'll just say vaguely when they come to the clinics, yeah, 4 to 5 times I had vomiting, little bit of vomiting, etc. So they document all this so that we know the severity of the problem. And again, we do the dipsticks in the clinics, where we'll see whether she has got ketonuria or ketones are plus, she has got 3+ ketonuria, so she's really dehydrated. It's really not an indication of severity of the disease. So this is the PUGE scoring, just for the for you to know how it is documented. And electrolyte imbalance, normally they can have hypokalemia, hyponatremia, which has to be corrected, and they can have biochemical thyrotoxicosis, which needs to be taken care of, and liver functions can be abnormal in almost like 40% of the women, especially the transaminases can increase. The treatment would be doxylamine with pyridoxine B6 and ondansetron, which is normally safe and effective, but then there is a very small increase in the risk of orofacial clefting, which can happen in the first trimester if you give it. So don't inadvertently give the medication if they come out with this problem. And metoclopramide, we have to be really careful when there is a possibility of extrapyramidal symptoms. So that also you have to be really careful about, and you have to give it at a proper dosage and not overdose with them. And if it is refractory hyperemesis gravidarum, corticosteroids can be used. Rehydration regimes, here also we cannot really use dextrose infusions as it can aggravate vernix encephalopathy. So normal saline with potassium chloride supplements, either orally, if they cannot take it IV with 20 millimoles of potassium, you can give it the normal saline and give it an infusion. Parenteral feeding and enteral tubal feeding also they can land up in sometimes. So these are the complications, severe complications even a hyperemesis can have. We have seen sagittal sinus thrombus with hyperemesis gravidarum in the critical care units. We have seen DVTs. So it's very important because they are dehydrated and also the pregnancy is a coagulable state. We have to take care of the thromboprophylaxis for these patients. They are prone for deep vein thrombosis risk. And vernix encephalopathy is again another thing which we are not really aware of. We don't really treat it well. Thiamine supplements should be given, and at least if you give multivitamins, which has got B1, should be okay. But if they face the problem of vernix encephalopathy, they should be treated by thiamine supplements, 100 milligrams TDS. And with the patients who have hyperemesis gravidarum, they are more lean patients and they have all psychological issues. So they can have problems with the nutrition, and they should be really have a nutritionist from the beginning of the pregnancy, and weight gain in the pregnancy can directly affect the fetal weight as well. So it's very important that they are taken care of well in the nutritional status wise. Low birth weight and preterm risk is increased in these patients. If they are really intractable hyperemesis, they can have PPIs which will help in the regurg. So coming to the next problem which can happen in pregnancies, intrahepatic cholecystasis of the pregnancy, which some of us is not a really good thing. In the yesteryears, there are patients who have lost babies, not identifying it properly and not delivering properly. So delivering on time, I meant. It affects almost like less than 2% of the pregnancies worldwide, and it's more common in Asian population. And again, multifetal, IVF pregnancies, older women, history of gallstones, hepatitis, and genetic variation in the gene encoding of the hepatobiliary proteins, transport proteins also can give rise to intrahepatic cholecystasis of pregnancy. In this aspect, I want to emphasize the fact that when the patients have the baby on with the IVF program, they are in a large doses of progestrogens, and that also causes severe liver dysfunction, and it could be one of the reasons for the problems during pregnancy. So we have to be really careful about the progestrogen supplementations, what we give intravaginally, intramuscularly, orally for IVF patients to continue the pregnancy. 80% of these patients have their presentation after 30 weeks, but it can happen in the beginning of the pregnancy as well. But if they had a history of intrahepatic cholecystasis, the previous pregnancy, they can have an early onset, first trimester onset ICP. 80%, I mean, the recurrence rate is quite high. It almost like more than 50% can have the recurrence of ICP in the next pregnancy. And multiple pregnancies, again, multifetal pregnancies, the risk is increased. They don't present really with a rash like PUPP, but they can have pruritus of the palms and soles. We have to be alert, and especially with the complaints of the pruritus of palms and soles, we have to know for the fact that the pruritus may come quite early than the rise in the liver function tests and bile acids, and the liver function tests can occur even before the rise in the liver function tests can occur even before the bile acids rise. So you don't have to really wait for this bile acids to rise. So when the patient complains of pruritus, having itching in the palms and soles, and there is a rise in the liver transaminases, we have to be wary about the fact that she may be landing up in intrahepatic cholecystasis of pregnancy. But the most sensitive and a specific marker for this condition is bile acids. The indicative of the more than 40 micromoles per liter is the indicative of adverse perinatal outcome, and ALT is more specific than the AST. And bilirubin can be raised in about 10% of the intrahepatic cholecystasis of the pregnancy. Coagulation profile can be affected because of the problems with the liver enzymes and the vitamin K deficiency, and they can have issues with the coagulation. And when they have intrahepatic cholecystasis of pregnancy, you have to screen them for GDM, which we normally do it anyway, and hepatitis C can be screened for. And liver ultrasound should be done because there is almost 13% association of gallstones with the ICP. So what are the risks which can happen with the intrahepatic cholecystasis of pregnancy? Early onset, there's no increased risk. This risk is the same. They can have preterm birth, spontaneous preterm birth, or because of the rise in the bile acids, we deliver them early. Meconium-stained amniotic fluid is not uncommon. Neonatal intensive care admissions are more often, and stillbirth is the one which really is scary. When they have more than 40, I think I will tell you the timing of the delivery when it comes to it. So that's very important that we deliver them on time and monitor them very, very closely. Ursodeoxycholic acid, 10 to 15 milligrams per kilogram is the dosage which we normally give for these patients. It improves the liver functions and pruritus, but the PITCHES trial, which was done recently in 2016-17, there's no reduction in the stillbirths, there's no reduction in the preterm births or neonatal admissions. So does it really help in decreasing the intensity of the disease or the prognosis of the disease? The answer is no. Other adjuvant therapies like cholestyramine, vitamin K, dexamethasone, antihistamines have been used as well to reduce more of symptoms rather than helping with the disease process itself. The timing of the delivery is very important. If the bile acids are less than 40, you have to deliver them by 37 weeks, 37 plus weeks. If the bile acids are 40 to 99, 36 plus, you can 1 week earlier you can deliver them. If they are more than 100, it's important that if they have symptoms and it is worsening, the bile acids are increasing drastically, then it's better that you deliver them by 34 weeks itself. Or if they had a previous history of ICP, better to deliver them by 34 weeks. Otherwise, if it is more than 100, monitor them and deliver by 36 weeks. So less than 40, this is the guidelines which are given by the RCOG and ACOG compiled together. I have made this. So deliver by 37, and if it is 40 to 99, deliver by 36. If more than 100, you try and deliver by 34 to 36 weeks. The maternal outcome, the pruritus usually disappears in the first few days after the birth, and the normalization of the bile acids and the liver function tests happen. Breastfeeding is not contraindicated. After the delivery, they can breastfeed them, but the ursodeoxycholic acid should be stopped as soon as they start going into the labor, and it doesn't matter if they are on it to breastfeed. And follow-up liver function tests and biochemical tests and the bile acids can be done after. If it is still raised, then you have to investigate further to see if there's any other liver disease which is associated. So that is the intrahepatic cholecystasis of the pregnancy. Acute fatty liver is another nightmare which we can face sometimes. So it's very rare, 5 in 100,000, and it's because 20% of the times it's because of the deficiency of one of the enzymes, and because of that there'll be increase in the free fatty acids which will be deposited in the liver. It's more common with the twins, again with the male infant with a low BMI and nulliparity. Normally, again, they present in the 3rd trimester. They have nausea, vomiting, and abdominal pain. We have to know that they can go into hypoglycemia, coagulopathy, may progress rapidly to renal failure and encephalopathy. They can rapidly deteriorate, and it's very important that we identify the problem very quickly and promptly deliver them. Investigations, normally the aminotransferases, they can go up to mild. They can be up to 500 international units per liter. Bilirubin can go up in few of the conditions. Deranged coagulation can happen. Ammonia can go up. Lactic acids can go up. albumin can come down, platelets could go down. That's when we get confused between the preeclampsia or the HELLP syndrome and the acute fatty liver. Neutrophil leukocytosis can happen. Renal failure and elevated uric acid also can happen, which again can happen with eclampsias. Ultrasound findings are inconsistent, so liver biopsy is not really indicated or not really done, and diagnosis is by clinical and lab criteria. They have implemented something called Swansea criteria, where any of this, 6 of these parameters are positive, then you can diagnose it, say vomiting, encephalopathy, polydipsia, polyuria, having an abdominal pain, bilirubin of more than 0.8, and hypoglycemia less than 80, AST and ALT more than 42 international units per liter, and ammonia more than 47, uric acid more than 5.7, creatinine being raised, coagulopathy, having ascites, all this, any 6 of them positive, it can be a criteria to diagnose acute fatty liver. Prognosis, maternal mortality is almost to the extent of 5%. They can land up having encephalopathy, pulmonary edema, liver failure, pancreatitis, DIC, and metabolic acidosis. They can come back to normal once the baby is delivered, 7 to 10 days, they can get back to normal. Management is delivery of the fetus, regardless of gestational age, you have to deliver the fetus, that's the prompt delivery is the mainstay. Correct the maternal coagulation. Induction of labor or cesarean section depends upon the coagulation parameters and the gestational age. If the induction of labor is not working within 24 hours, we have to deliver by cesarean section. But cesarean section makes sure that her liver parameters are corrected and her platelets are corrected and her coagulation profile is corrected before you put the knife on the patient. Regional and general anesthesia, it depends again on the coagulation profile, and the liver hepatotoxic drugs which can be used in general anesthesia should not be used in these patients. And correction of hypoglycemia is very important. This is where we have to use the dextrose. Renal function tests, renal function can be again affected because of the acute tubular necrosis, and they can land up having hepatorenal syndrome. Fluid balance, if it is not maintained, they can land up in pulmonary edema, and plasmapheresis can be the last resort to rectify these patients. Preeclampsia, we heard about it at length. Mainly the preeclampsia, the uric acid can go up. LDH levels are the ones which we have to think about, and low platelets. AST, ALT can be a mild increase can be there, and bilirubin normally doesn't go up. Unless there is a severe hemolysis with the HELLPs, it can go up. And reticulocyte count in the peripheral smear, you can see more than 2%. PT and INR are normal unless the DIC and advanced liver injury happens. Uric acid, as I said, it's more than 7.8 milligrams per 100 ml. It does indicate the increased morbidity and mortality for both mother and fetus. I'm not going to go into the antihypertensive treatment and magnesium sulfate prophylaxis, which you already heard in the morning. HELLPs, we all know about. And coming to the distinguishing features between the liver disease unique to this pregnancy, if you look at the hyperemesis gravidarum, the aminotransferases are less than 300, whereas if you go into acute fatty liver or HELLPs, it is more than 300 to 500. So there is a drastic increase in acute fatty liver, but there will be milder increase in hyperemesis gravidarum, and hyperemesis happens the first trimester, acute fatty liver happens the second. When we get confused is between the HELLPs and the acute fatty liver, because they have all the symptoms similar, but the aminotransferases are drastically increased in acute fatty liver, and we will have hypoglycemia, and the patient is much more sicker than the HELLP syndrome. And bile acids, as we know, is the mainstay in intrahepatic cholestasis. So if you look at the recurrence in this table, the recurrence is almost like 80% with hyperemesis, 45 to 90% with intrahepatic cholestasis, and preeclampsia and liver dysfunction, it's almost like 50% with preeclampsia, and HELLPs, it's almost like 20%, and with acute fatty liver, it's almost like 25%. It's very important that we counsel the patients when we finish the delivering. So basically, to conclude, hyperemesis, be aware of the vernix encephalopathy and venous thromboembolism, which is not very uncommon. Bile acids more than 40, be cautious with the intrahepatic cholecystitis of pregnancy. Acute fatty liver, prompt delivery and correction of defective factors is important. Preeclampsia and help, you know that correction of BP, seizures, prophylaxis and prompt delivery is important. And be aware of the recurrence risk and please counsel the patient after they finish delivering. Thank you. I take this opportunity to invite you all for the 24th annual conference of Asia Pacific Association for Gynecological Endoscopy and Minimally Invasive Surgery, which is happening at Chennai from 29th to 1st of September. And it has got workshops and live surgeries, near live surgeries and scientific program. Please do come. Thank you very much for the opportunity.
Thank you very much, madam. Since madam has to catch a flight, can we take a quick 1 or 2 questions? Is that okay, madam?
Yeah, yes.
One or two. Thank you, madam. Thank you. We'll move on. Thank you. Now, I call upon Dr. Sendil Nathan, who's currently working as a consultant intensivist in Royal Care Super Speciality Hospital. And his special areas in interest is sepsis, trauma, acid-based disorders. He's going to give a talk on a trauma in pregnancy. Over to you.
Thank you, Dr. Bala. Good evening, everyone. It's so nice to see extra crowd at around 4:45 on a Sunday when everybody is in the urge of leaving the hall. So my talk given today is about trauma in pregnancy. My talk is a little easier because there will be a lot of duplications of slides since morning as Dr. Vivek dealt with the triad scenarios and Dr. Chaitanya told about the anatomical and physiological changes, and Dr. Ram sir said about resuscitative hysterotomy. So I'll try to focus upon what are the important things, how to deal a trauma pregnant patient. The scope of this presentation, I would like to touch upon the incidence of trauma in pregnancy, the primary survey, the secondary survey, and what are the imaging modalities which can be used safely in a pregnant patient, and how to prevent trauma, and few take-home message. All over the world, the incidence of trauma in pregnant ladies is about 7%, and most of them occurs in the 3rd trimester, and motor vehicle accidents is the maximum incidence, the cause of trauma, followed by falls. So almost around 22%, especially in the 3rd trimesters when the center of gravity is changed due to the increased lumbar lordosis when the gravid uterus reaches beyond 24 weeks. Intimate partner violence comes as the 3rd important incidence of trauma to pregnant ladies, followed by the last, the burns. There is increase in mortality about 1.6% or 1.6 times between pregnant and non-pregnant women meeting a trauma. And most common cause of mortality is head injury followed by major hemorrhage. Coming to the primary survey, most of the countries nowadays follow the American College of Surgeons ATLS guidance. Almost 120 countries follow that in the maximum hospitals. They follow the rule of ABCDE. Since we are facing 2 lives, whether we have to follow ABCDE square, not quite. Just follow ABCDE. Though there are 2 lives involved, but save the mother, ultimately you save the fetus. But keeping in mind, the anatomical and the physiological changes occur in the different trimesters of pregnancies. So the implications will be differ, so the management differs at what time or what trimester the patient gets the trauma. Coming to the airway, this photograph I have to show that this is the correct way of placing a 3rd trimester pregnant patient when you're planning for any intubation. You can see the right side photograph. This is called the ramp. This is with a single pillow. If you keep it, see where is the mouth and the chest. It's a very difficult position to intubate her if need so. The changes which occur in the airway happens in the third trimester. There is increase in the tissue vascularity so that there is more edema in the upper airway. There is increase in the breast of the size, and there is increase in the neck fat mass. Due to the progesterone effect, there is a lax esophageal sphincter, and due to the gravid uterus, the increased intragastric pressures. So what are the implications? It makes a difficult laryngoscopy and intubation. There is a high risk of regurgitations, and if the intubation doesn't occur in a single attempt, there is more chances of airway bleeding. So how do we manage? Please be aware of the Difficult Airway Society guidelines if the anesthetist is being called for intubating a third trimester pregnant lady, and always follow early rapid sequence induction. Keep the head in a 30-degree up position, and to facilitate easy intubation, always remove the cervical collar but maintain the cervical immobilization. Avoid not to manipulate the nasal or the blind airway. Coming to the breathing, what are the changes occurs in the breathing? There is a decrease in the FRC by 30% due to the gravid uterus, increase in oxygen consumptions due to the increased metabolic rate up to 60%, increase in minute ventilation due to the effect of progesterone on the medulla, decreased arterial carbon dioxide tensions. The normal CO2 level is only 4 kilopascals, which comes around 30 millimeter of mercury. So any increase in CO2 to the normal level or a high normal level brings a bell in the brain, so that you should be very careful that her breathing is failing. And because of the growth of the uterus, the diaphragm is pushed carefully by almost 4 centimeters. So whenever you are caring of the breathing, patients easily get desaturated because they have a very low respiratory reserve. High normal PCO2 represents the hyperventilation already sensed in due to trauma, and more chances to get a iatrogenic, diaphragmatic and visceral injury if you are trying to place an ICD because of pneumothorax. So always try to place the ICD 2 or 3 spaces above than the routine place. Normally you like to place the ICD at the 4th or 5th intercostal space, just anterior to the mid-axillary line, but in a third trimester pregnant lady, you place it 2 spaces up. So give liberal oxygen supplementation, keep 30-degree head again, which improves the FRC, pre-oxygenase adequately at least for 3 to 5 minutes, and if put on ventilator, try to keep the PCO2 at the physiological level. If you have any doubt, please do imaging appropriately. Coming to the third one, C is the circulation. Everybody has talked about since morning about the aortocaval compression or the uterocaval compression, which happens when the uterus size crosses the fundus, decreases the preload, decreases the supine cardiac output, costs around less than 30%, decreased perfusion to the placenta. So it's in turn when it decreases the cardiac output and causes supine hypotension. So how to tackle this when you're managing the circulatory part? So there are 2 ways we can manage that. Either you keep the patient in the left lateral position, but you have to always place the patient on a spinal board. Normally, if you do a put a wedge on the right side to keep in a left lateral, you are going to unstabilize if they have any fracture spine or pelvis. So to be safer, to keep it on a spine board and then tilt the whole spine board to the left side at a degree of around 30 degrees. Or if you have extra hands, you can ask one person to always manually displace the uterus towards the left side so that the IVC not get compressed. This has to be done only if the uterus size is beyond the fundus, not to do so in the first and second trimester, which is not going to help to increase the circulatory part. Further changes in the circulation, they have a high cardiac reserve, the decreased systemic vascular resistance, increase in cardiac output, increase in the plasma volume and blood volume by around 40 to 50%. So they have a large volume. So the clinical implications for this is that they don't show the signs of hypovolemia unless they lose around 1 to 1.5 liters of blood. So always you have to keep in mind that early diagnosis or early identification of blood loss is very, very important in a third trimester pregnant lady who faces a trauma situation. Rather, the uterine and the pelvic vessels are largely dilated in the third trimester. So if there any injury happens in that area, there will be enormous blood loss. So you should always have a high index of suspicion. Try to place, if your expertise are available, to the early arterial line. Fetal assessment by CTG helps not only to identify the early fetal distress, in turn also identify the maternal hypotension. This is because there is bucket loads of catecholamine receptors in the uteroplacental wall and the placenta, which easily identifies the maternal hypotension and shows as a fetal distress. Sometimes we have to do a damage control surgery by emptying the uterus to save the mother. The hematological changes already have been dealt in the morning. That's increased hypercoagulability, the physiological anemia, and there is thrombocytopenia as well. So always we have that there is altered laboratory blood results in a pregnant patient. So not all similar to a normal patient who meets with a trauma. It is slightly different. So what are the targets you should keep when a pregnant lady meets in trauma? So try to get early hematology input, do early the point of care coagulation tests, try to aim a fibrinogen level of 200 micrograms per dl or 2 grams per liter. Try to keep the PT-INR and the APT less than 1.5. And if the patient is not bleeding, then try to keep the hemoglobin more than 8 and platelets more than 50,000. This platelet count, different societies give different targets based upon what is the cause for bleeding. Some societies say 75,000 and some societies say keep above 1 lakh if you are going for any operative intervention. Coming to the disability, there is no any change in the management or assessment of disability between a pregnant and a non-pregnant patient. So just here in the disability, you see the GCS and the pupillary size as mentioned by the ATLS protocol. Regarding the exposure and environment, based upon what trimester the patient is in, because if the patient is a first trimester, the uterus is very well protected within the pelvis up to 12 weeks. In the second trimester, there's good amount of amniotic fluid which protects the uterus. But in the third trimester, if the fetal head is already engaged in the pelvis and because of the trauma, if there is any pelvic fracture, then there is more chances of injury to the fetus. Once the ABCD is finished, a quick ample history followed by the secondary survey. The normal secondary survey will involve the head-to-toe examination both anteriorly and posteriorly, but pertaining to a pregnant patient's extra, you should be able to stress upon the uterine size. Is there any tenderness, any early contractions? Is there any vaginal bleeding? Is there any evidence of cord prolapse or any bulging perineum, which indicates imminent delivery? So touching upon a few obstetrical complications, I think the most of them have been dealt by different speakers since morning. The fetal hemorrhage, placental abrasion, uterine rupture, preterm labor, and pelvic fracture. Fetal hemorrhage depends the clinical presentation. It can be a fetal distress or a fetal demise. Most of the time it is a clinical diagnosis. Sometimes you have to do an imaging, especially in ultrasound, or the abnormal CTG will pick you that something is happening between the fetus and the placenta. Back in the medical school, you have been taught about the KB test. So if you have an RH negative mother, try to allow immunize them with the ROGAM 300 mics after 12 weeks of pregnancy to prevent hemolysis of the newborn in the present or the second pregnancy. Coming to the placental abruption, so majority of them present within 2 to 6 hours following trauma, and either they present, if the trauma is in the anterior, they have an abdominal pain, or in the posterior, they present with the back pain. On examination, you might find a uterine tenderness or rigidity. They might develop a preterm labor. They can present with vaginal bleeding. If it is so much of bleeding, they can present in hemodynamic instability. Or at the end stage, they can be at the fetal distress or fetal demise. Diagnosis is by clinical most of the time, because ultrasound has got a very poor sensitivity when you are able to diagnose a placental abruption. CT is more appropriate in the context of trauma. Abnormal CTGs also would help you early to identify the abruption. How do you treat? Mainly the resuscitation of the mother. Early fetal delivery if you ensue with a fetal distress or maternal instability. Uterine rupture is not very uncommon following trauma in the third trimester. It is because of the direct trauma to the abdomen, a patient presents with severe abdominal pain and distension, there will be uterine rigidity, hemodynamic instability, and you will be able to feel or palpate the fetal parts in the subabdominal space. Sometimes the late stage they can present in fetal distress or even fetal demise. Diagnosis is by clinical method and or by abnormal CTG, and even ultrasound can pick up the uterine rupture. Gold standard treatment for this is only maternal resuscitation. Later on, may need a laparotomy to control the hemorrhage if at all needed. Preterm labor or spontaneous miscarriage following trauma, again it is due to the direct effect of the trauma. The patient can present with contractions, vaginal bleeding, or increased pelvic pressures. Diagnosis again is by clinical method or by CTG or fibronectin test. I think most of the obstetricians will be knowing what is the fibronectin test. I need not explain that. Tocolitis is not very well recommended following spontaneous or preterm labor as a result of trauma, because most of the patients in trauma might be already in hypertension. If we give tocolitis, it is going to increase the hypertension. And if the delivery is imminent and if the fetus is less than 24-34, then it is better to administer corticosteroid. Magnesium sulfite for protection of neuroprotection of the fetus if gestation is less than 32 weeks. Coming to the last obstetrical complication, the pelvic fracture, they present with pelvic pain, they present with hemodynamic instability, depends upon how much degree of pelvic fracture. If it is in the last stage, they will develop fetal distress and death. Clinical diagnosis is the most important thing in pelvic fracture. The pelvic contraction test which is done in the primary survey. Imaging is the one which gives a perfect diagnosis of a pelvic fracture. The treatment includes a pelvic binder, sometimes damage control if the bleeding is so. If you have the facility of interventional radiologist, you can take use of them, or open surgery by the orthopedician. Conservative management sometimes help with the pelvic binder, or you need a surgical fixation. One slide about resuscitative hysterectomy. I think Dr. Ram has very well said that. So if you're not able to try to save the mother in a cardiac arrest state, so if you want to save the baby, if the baby is viable enough, then you can start your resuscitative hysterectomy within 4 minutes. It has to be as fast as possible. And the incision is a vertical incision, both in the skin as well as in the uterus, and try to deliver the baby as soon as possible. Speed is the important thing, not the sterility here. A few words about imaging. These are the 4 modalities of imaging available in trauma setting: X-ray, ultrasound, CT, and MRI. Especially in a pregnant patient, suppose if you have a first trimester lady who met with a trauma, everybody has got a concern how much radiation, whether the fetus can be exposed to. Don't be afraid. The allowable limit of radiation to a fetus is, in the first trimester, is 5 rads or 50 milligray. And to show this is the amount of radiation exposure by each investigative method. So if you are going for doing a trauma pan scan, it can vary from 1 to 8 rads. So maximum allowable limit is 5 rads. So maximum exposure happens with CT pelvis. So very well needed to diagnose, you can go ahead with your CT scan. Regarding MRI, if indicated, MRI is a safe method, you can do it in any trimester, but MRI with contrast is contraindicated in pregnant ladies. It causes increased incidence of stillbirth. Ultrasound is very, very, very useful for trauma assessment, the E5. How to prevent? Always wear seat belt if you are traveling in a 4-wheeler. And the placement of the lap belt should be below the abdomen. It is not over the abdomen. And nowadays in the Western countries, they have invented a new type of extra seat belt where they place the seat belt here. There is a hook into it, so that you pull this belt and put the hook into that, so that this part is free. So your abdomen does not get a direct injury because of the belt. So to put in a nutshell, this is the whole chart. I think it is too small letters, you can't visible from the lab. So primary survey, secondary survey, which includes ample and the focused examination pertaining to obstetrics as well as for the fetus. If everything is stable, then you have to monitor the fetus at least with CTG for minimum of 6 hours up to maximum of 24 hours. Last slide, the take-home message. So manage the trauma in pregnant as same as a non-pregnant patient. Follow the ABCDE with the crucial bits of thinking about the anatomical and the physiological changes which occur in the third trimester. Always remember to keep the patient doing resuscitation, the lateral position if they are in the third trimester. Get expert help, which includes anesthesiologist, intensivist, neonatologist. If you are planning for a imminent delivery patient, the baby might come as floppy and not breathing because of your drugs which are using during intubation. Always try to use the CTG, try to save the mother, to save the fetus. Always use seatbelt. These are the few references where this talk has been prepared from. Thank you for your patient listening.
Thank you, Sendil sir, for a wonderful and informative talk on obstetric trauma. For the final talk of the day, I would like to invite Dr. Lakshmikant Sharan to speak upon respiratory failure in pregnancy. Dr. Sharan did his MBBS from PSG Hospitals, Coimbatore, MD from Kasturba Medical College, Manipal, and IDCCM from Sundaram Medical College, Sundaram Medical Foundation, and currently working as consultant intensivist in Royal Care Hospital. Over to you, Dr. Sharan.
Thank you, sir. So I know it's a difficult task to deliver the last talk of the conference. I know we are running late and many of you have to travel back. I'll try to keep it as simple and interesting as possible. So my talk is on respiratory failure in pregnancy. I'd like to acknowledge my boss, Dr. Rami Rajagopalan, who taught me everything in critical care, and my chief, Dr. Sivakumar, for his continuous career guidance. So in the next 15 minutes, I'll try to take you over an overview of what are the changes in the respiratory system in pregnancy, how to identify a respiratory failure, what are the different causes of respiratory failure, how to approach it, and how to manage it. I'll try to take it along with the case so that it will keep us a bit engaging. 30-year-old woman, a known asthmatic on inhalers during seasonal exacerbation, a G2P1, 32 weeks of gestation. She is a booked case, regular antenatal visit. She has come with a complaint of fever, dry cough, and shortness of breath. And on examination, she was conscious, obeying, febrile, heart rate, BP was stable, respiratory rate was around 25, and saturation was 90% on Roman. So I just wanted to know what comes to our mind when we see this case history. What is the organ that might be affected in this patient? There is one parameter which can tell all these things. It is your saturation of 90% of room air. So definitely there is some problem with your lung. So there is a lung failure. It is called as a respiratory failure. So when do we call a patient having a respiratory failure? It is a syndrome in which the respiratory system fails in one or both of its gas exchange function. Oxygenation, when it fails, it is called as type 1 respiratory failure, and carbon dioxide elimination, when it fails, it is called as type 2 respiratory failure, such that the normal levels of arterial oxygen and carbon dioxide cannot be maintained. How big is the problem? As we all know, only 0.2 to 0.4% of the deliveries require ICU admission. It is a very small problem, and only 0.1 to 0.2% of pregnancies are complicated by acute respiratory failure. The Western data gives us an incidence of almost 25% of acute respiratory failure in pregnant women coming to obstetric ICU. Whereas the Indian data, there is a huge difference, and this is a data from Hyderabad, and this gives only 2.5%, as we have seen from the morning. Most of the cases coming to ICU in India are because of hypertensive emergencies, IPAH, hemorrhage, sepsis, and CVS. But RS, respiratory failure, is not very common. But the same data was showing that whatever may be the reason for which they are coming to the ICU, when you consider the organ that is being affected, lung is being the most affected. So all these patients, whatever may be the reason they come for, they have some problem causing in the lung. Almost 12% of them require a ventilator support. This might be a small problem, but as an intensivist and obstetrician, we all know that whenever an obstetric patient gets into ICU, it is definitely a nightmare. So the significance, as we all know, obstetric patient being 2, there is a challenging airway, increased oxygen consumption, Whenever there is a respiratory problem causing a respiratory failure, there is an acute onset of hypoxia, which is affecting the fetus and mother, and it can cause morbidity and mortality of the factor 30 to 40, 50% of maternal mortality, 20 to 25% of perinatal mortality, neonatal death, spontaneous preterm, and fetal heart rate abnormality. Is there something that can stop all these things? It is a multidisciplinary team approach. So these are the changes in pregnancy. I think I won't go into details of all these things. It has been dealt from the morning, the increase in the respiratory effort. There is a change in your chest shape and decrease in your lung chest wall compliance. There is an elevated diaphragm. The enlarging uterus pushes your lungs up. All these things causes a compromise in the respiratory physiology of a pregnant woman. Progesterone, as it starts increasing through the different trimesters of pregnancy, as we all know, it causes an increase in the minute ventilation. So what is this minute ventilation? Minute ventilation is nothing but a product of your tidal volume and respiratory rate. What is very interesting is that in this change in minute ventilation, this change in minute ventilation was predominantly because of, or maybe we can say it is only because of the change in tidal volume, whereas the respiratory rate throughout the pregnancy remains the same. This factor is very, very important because tachypnea often is a sign of underlying pathology. You can't take it as a physiological change of pregnancy. As we know, in many parameters like tachycardia or a white pulse pressure or an increase in breathing or anything, we used to say that this might be normal in pregnancy. This might be a physiological change in pregnancy. But we need to be very careful that tachypnea is not a physiological change of pregnancy. Whenever a pregnant patient is tachypnic, you need to think about some problem in her lung. So this causes a hyperventilation, washout of carbon dioxide, and respiratory alkalosis. So a normal ABG of a pregnant patient usually will have a PCO2 of around 25 to 35. Normally it has to be 35 to 45. But in pregnancy, because of this increase in tidal volume, it is somewhere around 25 to 35. And to compensate for this, there is a drop in bicarb. It is used to be 18 to 21. So as we know in physiology, in any of the organ that we are going to deal with, there is a balance between your demand and reserve. So what happens in the respiratory system in pregnancy? In demand wise, there is an increase in respiratory drive, there is an increase in tidal volume, minute ventilation, increased metabolic demands from the fetoplacental unit, there is an increased oxygen consumption. All these things increase the demand from the patient, maternal side. Whereas the reserve, because of the mechanical effect of the enlarging uterus, the decrease in the chest wall compliance and the change in the lung volumes and a decrease in your functional residual capacity, all these things decrease the reserve. As you can see, there is increase in demand and decrease in reserve, which tilts the balance in the respiratory physiology. This makes the patient more prone for rapid desaturation in response to hypoxia and apnea. When you compare with a non-pregnant patient, this is very, very important for us. They decompensate very fast when compared to a non-pregnant patient. Some points about the fetoplacental unit. We are worried about the fetus as well. We need the oxygen to go to the fetus and the carbon dioxide to come out of the fetus. For the uterine oxygen delivery to be proper, the hematocrit, hemoglobin saturation, uteroplacental blood flow, maternal BP, and PaO2 has to be maintained. So this thing that we are worried about is the PaO2 and the hemoglobin saturation in our respiratory physiology. So we need to maintain a maternal PaO2 of more than 70. This is needed to prevent fetal hypoxia and fetal compromise. Alkalosis or acidosis both can cause a change in your oxygen affinity, and it can be a problem to the fetus. As we all know, the fetal demise, the triad is hypotension, hypoxia, and anemia. So the most important factor among the triad is the hypoxia, which has to be dealt by us in respiratory failure. Coming to the carbon dioxide, as we all know, fetus carbon dioxide from the blood of fetus has to come to the maternal side, and from the maternal side, patient has to expire out the carbon dioxide. For this carbon dioxide unloading from the fetus to mother, there has to be a gradient or a pressure gradient, carbon dioxide concentration gradient between the fetal umbilical artery and the maternal uterine vein. How much big that gradient should be? It is found to be around 10 millimeters of mercury. If this gradient is not maintained, that is a maternal carbon dioxide has to be lesser than the fetal carbon dioxide. If this is not maintained, carbon dioxide retains inside the fetus, and as carbon dioxide rises above 65 or pH goes above 7.48 in the fetus, this causes fetal compromise and adverse perinatal outcomes. To maintain this, we need to maintain the carbon dioxide of the maternal side lower than the normal. That is usually done in a normal physiology, but if at all something happens and there is a type 2 respiratory failure happening in the maternal side, we need to be more prudent in treating it. So how to identify a patient with respiratory failure? They are usually dyspneic. On examination, you can find them to be hypoxic, tachypneic. They used to have paradoxical breathing. You can see a use of accessory muscles of respiration, and if there is a type 2 respiratory failure, there can be drowsiness or altered mental state. If you do an investigation, ABG would be the best investigation, PaO2 will be less, and PCO2 will be more. So coming back to our study, coming back to our case, earlier we found out that patient is having a respiratory failure. Now we need to know what is causing that respiratory failure. So from the history and the examination, there are some things that can lead on to this history. As she is a asthmatic, it can be asthma exacerbation, but more glaring is the history of fever, cough, and temperature. So more probably this should be a pneumonia. So what other causes can cause respiratory failure in pregnancy? It is of two major categories. One is obstetric, where it is pregnancy specific. These problems are specific only to the pregnancy, and non-obstetric, which are common problems but are aggravated by the pregnancies. The obstetric causes, as we have been seeing from the morning about all these things, hypertensive disorders like PAH, amniotic fluid embolism, pulmonary edema, especially tocolytic induced, aspiration pneumonitis and peripartum cardiomyopathy. Non-obstetric, as we all know, venous thromboembolism, pregnant patients are almost 5 times more prone for a venous thromboembolism when compared to a non-pregnant woman. Bronchial asthma, any bronchial asthmatic, it is found that almost 30% of them have exacerbation during pregnancy. Pneumonia is very, very important. That too, after the COVID and H1 pandemic, many of us would have had a pregnant patient with pneumonia and respiratory failure. It is found from a literature from US that 7 times more hospitalization and 7 times more severity of pneumonia was found in pregnant patients when compared to a non-pregnant patient. So other reasons could be cardiovascular diseases, pulmonary artery hypertension, neuromuscular diseases, and other things. So how to approach them? We now know what is the problem, what is the cause. We need to ask for a history of asthma, heart disease, fever, cough, or immunocompromised state. On examination, assess saturation. If it is less than 95, it is definitely concerning for us. The fetal oxygenation might not be maintained. Ventilation, if it is not fine, patient can get into a type 2 respiratory failure. Assess the respiratory rate more than 30. As I told you earlier, tachypnea is definitely concerning. Auscultation, you can see for wheeze, creps, or decreased air entry. Fetal edema can direct towards a cardiovascular problem. A unilateral leg swelling can be a problem with a deep vein thrombosis. Investigation-wise, the most useful investigations in respiratory failure is a ABG. With the ABG, you can find out the type of respiratory failure, type 1 or type 2, severity, whether it is mild, moderate, or severe, and if there is a respiratory fatigue, you can identify with it. Infectious workup, like any other patients, total count, CRP, and blood cultures, sputum cultures, and a nasal swab. Next comes the imaging. Whenever we want to do an imaging for a pregnant patient, we are always skeptical. We don't want to expose the pregnant patient and the fetus to the radiation. That is not the case. Now it is almost that all the international bodies have given a recommendation that if it is going to change the course of treatment, if you think it is going to change the course of treatment that can improve the maternal outcomes, you can definitely do an imaging. As Dr. Senthilnathan told in the last talk, the amount of radiation with a chest X-ray or even a CT thorax is not very high to cause a problem to the fetus. Only a CT abdomen or a pelvis can have a increased radiation which can cause a fetal problem. So if at all a chest X-ray needs to be done, you do it with a shielded abdomen. There is a unilateral infiltrate, think of a pneumonia, bilateral, think of a pulmonary edema, radius. If it is normal, even it can be a pulmonary embolism or an asthma exacerbation. Echo to rule out pulmonary edema, peripartum cardiomyopathy, pulmonary embolism. Lower extremity Dopplers can be done even in the bedside to find out DVT. Chest CT scan, as I told you earlier, it is an excellent diagnostic ability. If you think it is going to change the outcome, please do it with an abdominal shield with acceptable risk. If high suspicion of PE, definitely. The one problem that can happen with a chest CT or a chest X-ray is exposure of the breast. Breast cancer is very high when these pregnant patients are exposed to a radiation. Their breast tissues are more proliferative during this period of time, and radiation can be carcinogenic to them. But that again depends on the risk and benefit. If you think it is going to be more beneficial, do it. Ventilation perfusion scan can be done if you have a high suspicion of pulmonary embolism. It is almost equal radiation. It needs availability and expertise. This is the other investigation modality that has come into the almost all the OPs and ICUs in the last decade. This is the point of care ultrasound. As an obstetrician, you'll be well versed in doing an abdominal ultrasound. We are just going to move that ultrasound probe to the chest and look at the lungs. There are a lot of information that we can get from the ultrasound in these patients, which can differentiate the different causes of respiratory failure. As you can see from here, these are A lines, these are B lines, which we can be seen in the pulmonary edema. These are findings of consolidation or air bronchogram, which is usually seen in a pneumonia. These are the pleural effusion, which can be seen in a pulmonary cardiac failure, or if there is an infection in the pleural effusion. All these things can be seen at the bedside by an intensivist or anyone who can use an ultrasound. Using this, there are a lot of protocols that have come to help us, and with this, almost all the causes of respiratory failure in a pregnant woman can be found out. It has improved the diagnostic accuracy, reduced the time to reach diagnosis, improve patient safety, decrease complication rates. So coming back to our study, patient had a saturation of 90%. We did a ABG, PaO2 was only 56, and total count was 14,000. Echo was normal, RV was normal, X-ray was showing a right lower lobe infiltrate, and ultrasound was showing a consolidation changes. So the next is we need to treat this patient. How do we treat this? The aim of treatment, fetus is sensitive to hypoxia and acidosis. Aim for a saturation of more than 95 and a PaO2 of more than 70. Depending upon the level of hypoxia and work of breathing, select the oxygen delivery device. These are different oxygen delivery devices available to us depending upon the amount of FaO2 that you need. If it is less than 60%, you can use a nasal cannula, simple face mask, or a venturi mask. If it is more than 60, if you think patient might be needing, use a non-rebreathing mask. This is a lifesaver. This has saved a lot of lives during the COVID period. If at all you're trying to shift a patient to another hospital with hypoxia, always try to shift them with a non-rebreathing mask. This gives a very good FaO2. Our case, we started her with a face mask of 5 liters of oxygen, started on augmentin and azithromycin. On day 2, that oxygen requirement from 5 has become 15 liters. She's become tachypneic. Now what do? From oxygen delivery devices, we move to some sort of a ventilatory support. First, we decide on the non-ventilatory support. It can either be a non-invasive ventilation or a high-flow nasal cannula. NIV, as we all know, it is easy to initiate and use intermittently. It avoids intubation and sedation. Both can be deleterious in pregnancy, so it is good that we can avoid that. It has a good success rate, but the problem is it has limitations. It has to be closely observed. If there is failure of improvement within the 30 or 40 minutes of starting the NIV, you should go for intubation. Do not wait for a long period of time. It is advised for an alert, conscious patient with protective airway reflex and good respiratory drive, stable hemodynamics without severe acid-base balance, with the appropriate interface in a close observation in ICU. Always in a propped up position. Awake training can be done in this. HFNC, as we all know, it has been used during COVID a lot of times. Compared with the NIV and HFNC, if patient is tachypneic and cooperative, always try with the NIV. If patient is not tachypneic, less cooperative or claustrophobic, you can go for a HFNC. Same patient, we tried NIV on this day 3. The day 4, what happens? She's slowly become more and more tachypneic, more and more hypoxic. We becoming drowsy. We do ABG, PCO2 is 40. PCO2 of 40 is normal. 35 to 45 of PCO2 is normal, but not for a pregnant woman. That too, a pregnant woman who is tachypneic, if she is not able to maintain a carbon dioxide on the lower side, it means that she is fatiguing out. She is failing. This means that we need to go for the next level of support whenever there is a type 2 respiratory failure. This can happen when they fatigue out or if there is a COPD. So mechanical ventilation, when do you consider it? In acute respiratory failure who are not responding to conventional methods, dyspnea, nasal flaring and use of accessory muscles, respiratory muscle fatigue and altered mental status. Intubation, as we all know, intubation in a pregnant patient is very, very difficult. It is almost, intubation failure is 8 times more common when compared to a non-pregnant woman. It is because of the mucosal edema, increased mucosal vascularization, increased risk of aspiration, decreased oxygen reserve, and the large breasts making laryngoscopy difficult. What can be done? Most experienced among the group has to intubate, proper positioning before intubation, increase the FRC by pre-oxygenating the patient with either a CPAP or a NIV. You can do apneic ventilation with HFNC and use video laryngoscopy. All these things have improved the intubation success in pregnant patients. Mechanical ventilation, we maintain a minimum FaO2 to maintain a saturation of 94 to 95, PaO2 of 60 to 100. As I said earlier, the gradient of 10 millimeters of mercury in PaC2 has to be maintained. With non-pregnant patient, we used to keep a permissive hypercapnia in ARDS. That cannot be done in a pregnant patient. So the same patient on ventilator has gone up to a FaO2 of 90% and PEEP of 14. Still she is not able to maintain her oxygenation. What do we do? This is called as a refractory hypoxia. So what usually we do is, in a non-pregnant patient, we prone the patient. This is called as a prone ventilation. Do we have evidence? Definitely we have a very good evidence in non-pregnant group. In pregnant patient, there are not many evidence available, but it can be extrapolated to, in a pregnant patient as well. But the problem is difficulty in positioning a pregnant woman. There can be aortocaval compression, and if there is an imminent delivery, it might be difficult. But with adequate manpower, these sort of bolsters can be used and prone. We have prone many of these patients during COVID and H1N1 period. And recent H1N1 and COVID experience have shown good results with the prone ventilation. Other thing is ECMO. It has become a fashion statement now. Whether it can be tried, the problem is the heparinization that we need for this, which can cause a fetal demise. But two recently published systematic reviews on ECMO in pregnancy, especially during the H1N1 and COVID period, have suggested benefit. Maternal survival was almost up to 78% and infant survival was up to 65%. So definitely, if needed, ECMO can be considered for a pregnant woman. Our same patient, he is maintaining on prone ventilation with a FaO2 of 40%. We are trying supine and prone on every day. What other things that we need to consider in this patient? Fetal monitoring. Fetal monitoring is important, especially in a patient who is having a respiratory failure when the chances of fetal compromise is more. These sort of patients, fetal monitoring can be done in the ICU. At least once a shift, it has to be done. And if at all there is a fetal compromise, we need to think about how to proceed. But do not alter your decision based on fetal monitoring status alone. Maternal health is more important for us. The decision regarding delivery. We always think that if delivery is done, it can improve the patient's condition. But there is no major evidence to suggest that if delivery is done, the lung compliance improves, the hypoxia improves, or the maternal mortality improves. There is no current evidence for that. This cannot be advocated for all the cases. It is only on the case-to-case basis that need to be a multidisciplinary team discussion on each patient, and we need to decide whether we have to go for a delivery in these patients. Mode of delivery, again, there are not major literatures on that. Vaginal delivery, problem in respiratory failure is there is less blood loss, but increased oxygen consumption due to the pain and the strain that the patient has to have for a vaginal delivery. In LSCS, the oxygen consumption might not be more, but fluid shifts are high, blood loss are large and more rapid. So both are not very good. Choose what is safer according to the patient. and according to the with the mother as a preference. Until further data are available, standard obstetric indications for cesarean has to be followed, and optimize maternal oxygen and pain control during vaginal deliveries. And once the patient improves on the ventilator, what is more important is a rehabilitation, both psychological and physical rehabilitation. Get the family to the patient more often, get the child breastfed by the patient if there are no major problems, even when she is on ventilator. You need to mobilize the patient. All these things are found to be improving the patient's psychology. So these are the different approaches that we can do, from room air to the different oxygen delivery devices to non-invasive devices and invasive ventilation, and at last going for a prone ventilation or ECMO in a respiratory failure in pregnant patient. So for a best practice, I would suggest we need to have an early recognition, prompt diagnosis, vigilant monitoring of these patients, start treatment immediately. Early referral to an equipped and experienced center is very, very important. Proper family counseling and prognostications. All decisions are to be based on the maternal health and not on the fetus. Multidisciplinary involvement and discussion at each stage is very, very important. Maintain oxygenation at all the time with appropriate devices. NIV or HFNC can be used, but with caution. Do not delay mechanical ventilation just for the fact that you don't want to intubate the pregnant patient. Rescue measures, if needed, has to be done. Continuous fetal monitoring is advised. Delivery of fetus can be done if it would improve maternal survival according to the patient status. Rehabilitation and psychological support is important. The take-home points: physiological and mechanical changes increase metabolic requirements of the fetus and impaired native immunity pose them for a greater risk of respiratory failure even with a trace insult. Careful assessment and early management significantly improves the outcome in these patients. Breathlessness and tachypnea are not to be dismissed as physiological. Infection, it is present more insidiously and have more severe sequelae in these patients. Identify it and treat it early. Do not withhold diagnostic imaging just because to avoid radiation in pregnancy. Optimizing maternal health ensures the fetal and maternal well-being, so that needs to be the priority. Early multidisciplinary involvement improves the outcomes in complex cases. These are some of my references. Thank you.
With the permission of chair, I request all the delegates to stay for 5 more minutes. I think you have stayed all the day. I think in the last 5 minutes of the day's program, so request you to stay back.
Thank you, Charan. That was a very informative talk. Any questions from the audience? Sendil, you can also join. Let me start with one. It's like Sendil, like a brain, we have a sort of targeted blood pressure to maintain. Likewise in trauma and pregnancy, do you have any sort of blood pressure targets to maintain? Because permissive hypotension obviously not a choice for them.
As per the ATLS guidelines, if a patient is pregnant or non-pregnant, the target blood pressure does not change. Depends upon what type of injury the patient has sustained. If the patient doesn't have a head injury, then some amount of permissive hypotension is permitted. But if there is a head injury, then at least you have to maintain a systolic blood pressure of 100 millimeter of mercury always, and to keep saturations more than 90% to avoid hypoxic secondary brain insult. And always keep monitoring the CTG to see the fetal well-being.
Do you use any prophylactic relaxants for a fetal well-being?
Prophylactic? I couldn't hear it.
Prophylactics, anything?
No. Prophylactics is not recommended following trauma to stop the bleeding, and especially when the patient is in hypertension.
Any other questions? If no further questions, I'd like to thank all the audience for staying patiently till this evening, and both speakers, I'd like to extend my thanks. Thank you very much.
Thank you, sir. I request you to stay back.
I request Dr. R.S. Kumar, Consultant Intensivist, Royal Care Super Speciality Hospital, to felicitate the session moderators. Dr. V.M. Balasubramani. Dr. M. Hariharan. Dr. M. Aruloli. Thank you, sir. Now I request Dr. V.M. Balasubramani to felicitate the session speakers. Dr. T.A. Sendilnathan. Dr. S. Lakshmikant Sharan. Thank you so much, sir. I request Dr. M. Sivakumar, Head Institute of Critical Care, Royal Care Super Speciality Hospital, to give the closing remarks.
I think we have come to the end of today's program. I think in the interest of time, I won't be able to thank each and every one of you. So I take this opportunity to thank each and everyone who have been part of this meeting, and particularly I want to thank all the delegates. I think without your active participation, we won't be able to conduct such good meetings. So we have got a very good participation in all our ICU update. Again, this year, both in workshops and CME, we had a very good participation. So thanks for all the delegates who have come from various parts of Tamil Nadu and Kerala. Whenever we go to a scientific meeting, I think at the end of the day, we feel like, I think we have learned something. So, but when you go back and you don't practice, I think over a period of time, you lose the knowledge and you lose the skill. So probably to retain the skill and to keep up the knowledge, I think you should keep doing some drills at a local level or an institution level. So it happens to us also when we go for an ECMO meeting and come back, we feel that tomorrow we can put an ECMO. But if you don't do an ECMO for next 6 months, I think then probably you lose the confidence. So similarly, I think whatever the skills you have learned, I don't ask you to go and do a CPR on your patient tomorrow. But I think at a local level or a hospital level, you try to have small drills so that you try to retain the skills. And there may be some flaws in when you do such meetings. So we will be sharing a feedback form in the CME group. So please give your genuine feedback. This will help us to improve future programs. And until then, we meet in the next ICU update. Goodbye to all of you and wish you all a safe journey back. Thank you.